नहीं था कि भाई इवन रेजिडेंट्स और नॉट चीफ एजेंट को सही क्लियर नहीं था कि एएलएस में कुछ है भी कि नहीं है, सारा ऑनलाइन है या पोस्टर में भी कुछ ऐसा मेंशन नहीं था, तो आपसे बात नहीं हो पाई वरना मैं आ जाता। आज मैं देखता हूँ, अगर सुबह सुबह नहीं होता तो आई माइट हैव कम देयर। उठ ही अभी पाया हूँ 10-15-20 मिनट पहले।
आपका श्योर, क्योंकि इधर भी जो है ना रेजिडेंट्स आ गए थे दो, वो शमसी और हमाद आ गया था, दे वर वेरी हेल्पफुल। तो अच्छा, ये लाइट से फर्क पड़ता है दो से। ताज, मेरी पिक्चर क्लियर है? या दैट्स मच बेटर। वो ठीक है, फिर 8:15 शुरू करते हैं। जितने भी हो गए लोग, 5 अटेंडी हैं अभी।
जी बिल्कुल। मेरे पास आई डोंट नो प्रेजेंटेशन किसकी है। आई डोंट हैव अ वेरी लॉन्ग प्रेजेंटेशन, ब्रीफ सी है। अच्छा, आप ही की है, ठीक।
Sir, it's 8:15. Can we start?
13 है, 2 मिनट रुको। मलिक जावेद इकबाल की मुझे कॉलें आ रही थी, पता नहीं वो ये ना हो गया रात, फिर मैंने कॉल बैक किया, वो नहीं उठा रहे थे। आई होप यू कैन मेक इट। चलें जी, बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम। Welcome back to all course participants and faculty members. We'll start the proceedings of day 2 today. We will be dealing with acetabular fractures mainly today. And hopefully we will have another useful day spread out over the whole day till about 5 p.m. We finished at about 6:30 p.m., slightly overtime yesterday. But I hope it was useful, and the case discussion and the interaction between faculty members and discussion was useful for you. Now, please feel free to ask questions whenever you want through the chat box. We'll try to address as much as we can on all the issues that you raise. I hope the workshops, table workshops, projections were also useful. Due to COVID restrictions, we could not have an hands-on course this time. So that's the only thing I could think of to project the actual practical part of the workshop. Anyhow, your suggestions are most welcome. Let us begin the proceedings of the day in the name of Holy Quran. Please start the recitation. Thank you.
بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لله ما في السماوات وما في الأرض، وإن تبدوا ما في أنفسكم أو تخفوه لمن يشاء ويعذب من يشاء، والله على كل شيء قدير. آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير. لا يكلف الله نفسا إلا وسعها، لها ما كسبت وعليها ما اكتسبت. أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين.
Sadaqallahu al-Azim. Over to you, Dr. Masood Umar.
Jazakallah. Let us begin today's proceedings with our first talk on acetabular anatomy by Dr. Naveed Bloch. Over to you, Dr. Naveed.
Thank you, sir. So we'll be briefly going through the acetabular anatomy, important landmarks and important structures. Let me just share my screen. So I hope everybody is able to see.
Yes, sir, we can see. Please go ahead.
Okay. So pelvis per se, if you can say, it's a bony structure. They transmit the weight of the body, uh, uh, weight of the whole axial skeleton to the lower limbs, and composed of three bones, middle is the sacrum, three bones on each side, which are distinct during the development, but they in adult life they coalesce to form the innominate bone on either side of the sacrum. The iliosacral joint connects the sacrum to the ilium. The ilium becomes pubis anteriorly and ischium inferiorly, and then the two pubic bones are connected in front by the pubic symphysis. So coming to the acetabulum, so I'm not going in detail of the Greek names of the acetabulum. So obviously it was just reflecting some kind of cup. The three bones, the ilium, ischium, and pubis, join each other centrally to form the acetabular cavity, and it is kind of an incomplete hemispherical socket with an inverted horseshoe-shaped articular surface surrounding the non-articular cotyloid fossa. Now, the horseshoe-shaped cartilaginous portion of the acetabulum is the main region through which the weight is transmitted from lower limb to innominate bone. And maybe you can say the articular surface is relatively more on the posterior side and posterior column as compared to the anterior side. So the column concept was given by Jude maybe in the second half of the 20th century to understand primarily the fracture patterns and to help in classifying the fractures and deciding the management principles. So the two columns of bone which form an inverted Y from form and support the cotyloid fossa anteriorly and posteriorly. So you can say how the inverted Y is represented in the actual acetabulum, dividing the bone, the whole acetabulum into the anterior and the posterior column. The anterior half of the iliac crest, the iliac spines, the anterior half of the acetabulum, and the pubic form the anterior column. Now the ischium, the ischial spine, the posterior half of the acetabulum, and the dense bone forming the sciatic notch form the posterior column. We'll be discussing a little bit detail about the bones of anterior and posterior column and the important landmarks in terminology, which is used when you are discussing the anatomy of the acetabulum, especially the surgical anatomy of the acetabulum. So the anterior column, also known as the iliopubic column, extends from the anterior iliac crest to pubic symphysis. It has three segments: the ilium or iliac bone itself, the acetabular component itself, and then the pubic component. So it might be easy to understand in these three divisions. Iliac segment is the anterior aspect of the iliac wing and anterior border marked by the anterior superior iliac spine and the anterior inferior iliac spine. It has two surfaces, the pelvic surface and the external surface. Pelvic surface is concave, superior to inferior, and extends to iliopectineal line. And external surface of the gluteal, you can say, surface is roughened and forms large part of the gluteal surface, as I said you. So, and that surface is actually divided into divided by with two semicircular lines, dividing it into three zones: the posterior, middle, and anterior, and it respectively attaches three main muscles of the posterior hip or abductors: gluteus maximus, gluteus medius, and gluteus minimus. So, if you look from above, the iliac wing appears as a S-shaped structure. It begins anteriorly with a slight medial oblique orientation, and posteriorly it forms posterior iliac spine, which is sagittally oriented. Now, various muscles are attached to the iliac wing and iliac crest on different sides of it. The lower extremity hip muscles are attached on the outer side, as I said already, divided into three different fossa, the gluteus maximus, medius, and minimus. And along the inner portion, the iliacus and obturator internus and the pelvic floor muscles are attached. The abdominal muscles are attached anteriorly and paraspinal posteriorly on the top or the crest portion. Now, other important structures which you may need to know are uh, there is a strong buttress of bone extending from the iliosacral joint toward the acetabular, which is known as sciatic buttress. So, in many of the time, we try to purchase this bone while we are doing fixation of the fractures. The lumbosacral plexus as well as the gluteal vasculature lies in the vicinity of this bone. These vessels are the main source of bleeding, and they can also be injured during surgical approaches. And the posterior superior iliac spine is adjacent to the sacroiliac joint and outer ilium. So, picture is also shown. The anterior most border of the iliac bone begins with the anterior superior iliac spine, and which gives origin to the fascia lata, sartorius, and inguinal ligament. And then the anterior inferior iliac spine lies just below the anterior superior iliac spine, where the direct head of the rectus femoris is attached. So this one, the iliopsoas muscle passes just medial to anterior inferior iliac spine, under which lies the iliopectineal eminence. So these are structures are labeled as well. So the indirect head of the rectus femoris is attached inferior to the anterior iliac spine, just above the dome of the acetabular. Now coming to the acetabular segment, it has can be divided into three surfaces: posterolateral, internal, and anterior superior. The posterolateral surface supports anterior articular segment and front of the cotyloid fossa. The internal surface formed by anterior aspect of the quadrilateral surface and extends to the obturator canal, and then anterior superior surface, which has the gutter of iliopsoas tendon below the anterior inferior spine and iliopectineal eminence. These both form the superior surface, and the inferior limit of iliopectineal eminence is at the same level as the anterior horn of the acetabular. Coming to the pubic segment, you can again divide it into the anterior superior surface, internal surface, and the inferior surface. The most important is the anterior superior, which gives origin to a number of muscles, including the pectineal insertion and the medial insertion of the rectus abdominis muscle. So this is the pictorial presentation. The outer border of the outer surface of the anterior column and the inner side of the anterior column. So you can appreciate the much of the iliac bone, the much of the ilium is part of the anterior column, and then rest is then divided in some portion, some free portion, and then the it forms the sacroiliac joint. So the iliopectineal eminence, the other things which you must know, the iliopectineal eminence is the prominence in the anterior column that lies directly over the femoral head. Both these structures limit the fixation of the anterior column fractures and fractures of the acetabular. Coming to the posterior column, it is also known as the ilioischial column. The internal surface posterior surface, anterior surface can be divided into these three surfaces. The internal surface, you can describe it as a choroidal plate continuous with inner surface of skill spine. The posterior surface is the convex area comprising retrocotyloid surface, part of posterior wall, and subcotyloid groove, which is obturator externus tendon is attached there, and scale tuberosity. So the anterolateral surface, posterior part of the acetabular articular surface is superiorly, body of scheme inferiorly. The posterior border formed by posterior edge of the innominate bone with greater and lesser sciatic notches separated by skill spine. So here again you have the outer side of the posterior column, inner side of the posterior column. So you can see the most important structure posteriorly has the skill spine, which separates the greater sciatic notch and the lesser sciatic notch, and forms the outer edge of the posterior column, posterior edge of the posterior column. So greater sciatic foramina, what is important about it is that it contains the piriformis muscle, superior gluteal nerve, sciatic nerve, ischial vessels, and internal pudendal vessels and nerves. The lesser sciatic foramina contains the obturator internus muscle and the internal pudendal vessel. The important thing is that these structures exit the pelvis via greater sciatic foramina, and then after crossing over the sacrospinous ligament, re-enter the pelvis via lesser sciatic foramina. The shorter posterior column meets with the anterior column at the top of the sciatic notch. The column concept is very, as I said earlier, the column concept is very vital not only for classification of acetabular fractures but also in deciding the operative approach and hence the management. So you need to know the fractures involving which columns, and there that will guide you to decide which approach you are going to use, whether anterior, posterior, or combined, or what else you need for your intervention. The weight-bearing portion of the articular surface is known as the dome or roof that supports the femoral head, as I said earlier. Now, the goal of both operative and non-operative treatment is the anatomic restoration of roof or dome with concentric reduction of the femoral head. Now, other important structure which you need to know the choroidal surface, the flat plate of bone forming the lateral border of the true pelvis, or the medial border of the acetabulum, you can say this medial or medial superior border is known as the choroidal surface. It lies adjacent to the medial wall of the acetabulum. And it's very important to know this. I mean, it forms a part of the both columns, anterior and posterior, and can be fractured separately as well when you have medial protrusion of the head. The boundaries of the outer foramina formed by the pubic superiorly, the ischium inferiorly, and the anterior horn of the acetabulum posteriorly. And the important thing is that it is covered by the obturator membrane. It's a very strong membrane, fibrous membrane. The integrity of the inguinal ligament and obturator membrane prevents the separation of rami fractures during reduction and fixation of the symphyseal plate. So here is the obturator foramen. Inferiorly is the ischiopubic ramus, and then superiorly surrounded by the inferior part of the acetabulum. Coming to the important vascular structures, the aorta bifurcates in the lower peritoneal region into the common iliac arteries. The common iliac begins at around L4 and divides at around L5S1 junction into the external and internal iliac arteries. The internal iliac, also known as the hypogastric artery, branches to form the superior and inferior gluteal vessel, the obturator, the pudendal, and the coccygeal and sacral and vesicular vessel. So most the posterior structures, deep vessels are formed by the internal iliac. The internal pudendal artery exits I mean, the internal pudendal is one of the important artery of this branch of the internal iliac. It exits the pelvis underneath the piriformis and re-enters the pelvis through the lesser sciatic notch and terminates as the dorsal artery of the penis and clitoris and cavernous artery. Now, the external iliac artery, just proximal to the inguinal ligament, branches to form the femoral artery, which has three main branches: urethra, inferior epigastric, and iliac circumflex. The important thing which you must remember here is the corona motus. The epigastric vessels, travel deep and then anastomosis with the operator vessel. The corona motus is the anastomosis, or you can say the anomalous anastomosis connection between epigastric and the obturator vessels. So posteriorly under the fossa is the obturator, anteriorly over the ramus is the epigastric. There may be some anomalous connection which might be passing superior or behind the superior pubic ramus, uh, and it can cause fatal bleeding if not identified and ligated during surgery. So when you are doing ilioinguinal anterior approach, you need to look for this connection and ligate it before proceeding for your dissection, further dissection. Ascending branch of the medial femoral subcutaneous artery, it is the main blood supply to femoral head, deep to quadratus humerus. So this is posteriorly. So this artery is important when you are doing the posterior approach. Deep to the quadratus humerus, obturator internus and piriformis, and superficial to the obturator externus. So when you are doing posterior dissection and disconnecting the short external rotators posteriorly in the cochlear approach, you should be careful about this branch, which is the main supply for the femoral head. Other important thing, artery is the supragluteal artery. It exits the greater sciatic notch, may be lacerated secondary to injury or during superior lateral retraction during cochlear approach. So anteriorly you have major vessels which may lead to significant bleeding if not identified, some anomalous anastomosis. Posteriorly, you have some important branches which are supplying important structures and which, if they are damaged, may lead to postoperative complications. Coming to the neurologic anatomy, there are two important plexuses, lumbar and the sacral plexus. As you know, the lumbar plexus consists of the first three lumbar and anterior rami and a portion of the anterior ramus of the fourth lumbar nerve. The femoral and obturator nerves are the terminal rami of the lumbar plexus. The sacral plexus is found by the coalescence of the lumbosacral trunk L5 anterior ramus with L4 anastomotic ramus and the anterior rami of the first four sacral roots, so L5 to S4. The plexus ultimately becomes the sciatic nerve, which is very important structure. It has two main components, posterior tibial and the peroneal nerve. The posterior branches relevant to the orthopedic surgery are the superior gluteal nerve, branches with the external rotators, and inferior gluteal nerve. Now, the sciatic nerve is very important anatomically because of its variable exit from the greater sciatic notch in relation with the piriformis muscle. It exits the greater sciatic notch. In 85% of the cases, it courses in front of the piriformis. In front, that means posterior to the piriformis. So, I'm sorry, I mean not posterior, anterior to the piriformis. When you will lift the when you cut and lift the piriformis, you will see the greater sciatic, the sciatic nerve, and deep or to the piriformis, in front of the piriformis, but posterior to the short external rotators. The other variants include penetration and splitting around the muscle in different configurations. So 88 or 85% of the time in this configuration, and it may split. It may pass splitting through the muscle as a whole, or may divide earlier in the branches. They come out splitting one of the branches in front of the muscle, one through the muscle, in from the middle, or entirely from above the muscle. The fractures and dislocation in this area have very high incidence of sciatic nerve injury, and most common to be involved is the peroneal division of sciatic nerve. Other two important nerves as I discussed are the superior gluteal nerve. It exits the greater sciatic notch with superior gluteal artery, may be lacerated secondary to injury or aggressive retraction, and the inferior gluteal nerve, it innervates the gluteus maximus muscle, branches innervating superior one third, located halfway between posterior iliac spine and greater trochanter. And proximal and superior extension of cochlear approach may cause iatrogenic injury. So you need to be very careful when superiorly extending your incision or giving retraction in higher posterior column or fractures which are more involving the dome of the acetabular. So thank you. So that was the all important acetabular anatomy to kick off today's session. So we'll be happy to answer any questions. Thank you.
Okay, thank you very much, Dr. Naveed. Any comments, questions on anatomy? It's a very difficult area, nicely covered. Osteology, myology, nerves, vessels, huge domain of minor things which are crossing. entering or crossing that area. So there are no more. If there are no comments or questions, we move on. Just give me a minute. I need to copy it for the. Is my slide visible now?
Yes, yes.
Yes, it is. Yes.
Okay. Bismillahirrahmanirrahim. Allahumma salli ala Sayyidina Maulana Muhammadin wa alihi barik wa sallim alayhi. So nextly, after anatomy, we'll go through the radiology, basic radiology of acetabular fracture. As Dr. Naveed already mentioned, it is a lambda-shaped structure in the body with an anterior column and a posterior column, easily definable and discernible with gross as well as on radiology. So the division between anterior and posterior column has to be clearly defined. And as Dr. Naveed has already alluded to them, so I'll just skip them in the interest of time. For plain radiography, we would focus on an AP view and the Jude views that he defined as obturator oblique and iliac oblique views. These are the 4 lines, 5 points which need to be highlighted. Actually, they were highlighted here, but I think there's something with the anyhow. So the number 1 is iliopectineal line. This is hemipelvis AP view of the right side. And if you go one by one, lines, the number 1 is iliopectineal line, number 2 is ilioischial line. So these are the lines which will be very easily visible to you on X-ray, on a plain AP X-ray, and will be shown repeatedly throughout today. Either they are intact or broken. Number 3 is the teardrop formed by it has 2 walls, medial and lateral walls. Without going into those details, it is a very distinct structure. Also becomes very important when we're doing arthroplasty of the hip. Number 4 is sourcil or the dome. Sourcil is a French word for eyebrow, and it is in the shape of an eyebrow, and it's the weight-bearing dome of the acetabulum, which is our primary concern during reconstruction. Number 5 is the anterior wall, and number 6 is the posterior wall. अगर आपने ये 6 lines identify कर ली इस talk के बाद, तो then my work is done, right? You have to remember that the anterior wall falls short of the posterior wall. That is equivalent to acetabular anteversion. Okay? If the anterior wall and posterior wall are crossing each other like this, or anterior wall goes lower than the posterior wall, then this is a dysplastic acetabulum. Okay? फिर हम dysplasia की domain में चले जाते हैं. So whenever you are tracing on an AP, make sure that the anterior wall is proximal or medial to the posterior wall. That is acetabular, normal acetabular, anteverted normal acetabulum. This great person is the father of acetabular surgery called Emile Letournel, French surgeon. And he described mainly the radiology by placing wires on discrete structures and then taking X-ray and then describing what is a particular wall, what is a particular column, and how do they appear on particular AP and obturator and iliac oblique views. This was the definition of teardrop, but we'll just skip it, not clinically important today. We'll just briefly touch on the concept of roof arc. Roof arc is the, as I mentioned, sourcil or the dome is the most important structure we are reconstructing. And that roof arc is the portion of intact dome which is left intact after the fracture, as is shown in the yellow arrow. Here, this is the workable dome that is left behind. The rest has broken and displaced, so we need to reconstruct that. We will come back to that. Now, the next thing is to learn how to do obturator and iliac oblique views. Obviously, with an injured acetabulum, it's very difficult to move that side, so it is better to move the beam of the X-ray. So you don't ask the patient with an injured acetabulum, broken acetabulum, to move his pelvis rightwards or leftwards. It is much better to move the beam towards an angle of 45 degrees to get an iliac oblique or a obturator oblique view. Now, this is an iliac oblique view. The best definition of an iliac oblique view would be that you would see a big ilium, a very flattened out ilium here, which is being followed into the greater sciatic foramen and the ischial spine and then the posterior column. So very, very clear view of the posterior column is seen by the iliac oblique view, which is shown here. And then the other thing which you can see is the anterior wall. So posterior column and the anterior wall, you can see with the iliac oblique view very clearly. This is the whole thing is posterior column, this whole thing, right? And then the anterior wall. So you remember it by, again, as I said, by the big appearance, flat appearance of the ilium. And next is obturator oblique view. If the hallmark of it is that you see a big obturator in front, the obturator foramen in front, right? And you see the ilium as a blade. You see the two flat surfaces, just like my hand. This is how ilium would appear with the outer and inner table and a big acetabulum ring on the lower side of that is an obturator oblique view, known to see the iliopectineal line, which is visible here, and the posterior wall, right? So this is how we diagnose posterior wall fractures also on an obturator oblique view, and we see the anterior column at the same time. So as I mentioned, if we take both, the AP view shows the iliopectineal line, teardrop, anterior rim, ilioischial line, and posterior rim very clearly. And the fifth thing was the dome. The obturator oblique view shows the iliopectineal line where the and the posterior rim or the posterior wall. The internal oblique, the iliac oblique view shows the anterior iliac wing, the greater sciatic notch, and the anterior wall or anterior rim of the acetabulum. ये अगर आप सिर्फ बॉक्स जहन में रखें, तो जब आप फिर intraoperatively when you are doing C-arm manipulation, you don't confuse yourself. You do it before prep and drape, which is the obturator oblique, which is your iliac oblique. And you also train your radiographer who's going to manipulate the C-arm during surgery that you bring in two respective positions, which are exactly at 90 degrees to each other, and with respect to the acetabulum and where is the AP view. And what respective structures will you see? And then obviously your drills and your subsequent screws, how will they enter? These are further views to show again anteroposterior view, iliopectineal line, the respective walls. And if you see iliac oblique view, as I was mentioning, and the obturator oblique view, where you can see a big portion of the obturator. A CT scan, I'm sorry, a lot of the text of the slide should have been projected, but it's not visible. I don't know why. Anyhow, this arrow is showing marginal impaction, which is important for CT scan. The picture on the left, the utility of the CT scan is for impacted fractures as well as incarcerated fractures, which is shown on the left, and the impaction of the acetabular cartilage is shown in the picture on the right. So I would stop here. I would try to come back with better definition. My text is missing, which is anyhow. I would come back with CT. CT is being correlated with the anatomical parts. If you see, this is very close to the dome. This is almost a femoral head extruding through the dome. If you cut slices through the dome, this is how the CT appearance would be on the right side, with compared to a bone cut on the normal side. As also shown here, this is the flat part of the ilium, and this is how it would appear on the CT scan with picture on the right. And this is now we are nearing the column part. This is the quadrilateral plate behind. We are entering the anterior column and then the posterior column. How they would appear. And as you go down, this is how they would convert themselves or narrow themselves down into walls. This is posterior wall, the red arrow, and the white arrow is anterior wall. So I would stop here. That was basic radiology. So X-ray AP view, what would it show? Just to reiterate, if you just remember this box, AP view, it would show all four lines as well as the fifth structure, which is dome. And then the obturator oblique view would show a great ilium like my hand. Just remember your own hand like this. And the obturator foramen, where it would show you the anterior column and the posterior rim. And then the iliac oblique view, which is done for posterior column, in the flat ilium as well as the anterior wall. So if you remember this is, I think, enough for residents, and we will dwell more on the CT pictures as we go along the course. So I would stop here. If there are any comments or questions, I will be happy to take. So, in the interest of time, we would move ahead. Malik Javed Iqbal Saab is here with us. He would take us through classification of acetabular fractures. Over to you, sir.
Okay, Assalamu alaikum to everybody, and a very good morning to everybody. The topic today is internal classification of acetabular fractures. Can you hear me? Can you hear me?
जी बिल्कुल we can hear.
We can. आ रही है आपकी क्लियर आवाज आ रही है अभी स्लाइड नहीं आई
स्लाइड आई एम शेयरिंग तो कर मैं तो शेयर तो कर लिया मैंने एक मिनट बैठ
अभी वो लोड नहीं हुई सर उस पे शेयर स्क्रीन पे
अच्छा मैंने तो शरीफ को भी भेजी है उसको
शरीफ आपके पास है तो आप चला दें सर आप अपनी अनशेयर कर लें हम चला देते हैं आप स्टॉप शेयरिंग कर दें हम चला देते हैं यहाँ से
एक मिनट वापस कैसे जाओ यार इसको?
बस आपको ऊपर स्टॉप शेयर होगा, उसको ये थैंक यू सर। जी शरीफ
स्टार्ट।
जी सर, अस्सलाम वालेकुम।
अस्सलाम वालेकुम।
वालेकुम।
मुझे तो नजर नहीं आ रही स्लाइड्स।
आ रही हैं सर, 1 मिनट बस।
तो शरीफ शेयर कर रहे हैं।
अच्छा ठीक, थैंक यू। Right, okay, thanks very much. I can see my slides now. So today I'm going to talk about this littoral classification of acetabular fractures. So next, please. आप इसको forward करेंगे? Yeah. Well, acetabular fractures, you see, these are also very common fracture these days because of this, very road traffic accidents, and also because of the the vehicles are now being involved, the motor vehicles. But it could be due to a simple fall, when if it is an isolated injury, which is usually because of an old age. In old age, when the bones are quite soft and porotic, or when the bone can be pathological, like an osteoporosis, or in younger people, it usually is due to road traffic accident, and there is a high incidence of associated injuries as well, and it's usually young patient. Next, please. Next, please. Right. So much of the anatomy has been discussed very well by Dr. Navi. So I wouldn't really go into much more into that. But just anatomy, it got about the sixth part. From the classification point of view, we divide into anterior column, posterior column, anterior wall, posterior wall, acetabular dome, and medial wall. And you can see on the diagram, the anterior column is this gray area on the picture, and the posterior column is the pink area, and the rest is the two. This is the istiopubic ramus connecting the columns, and there's a posterior part which is a quite strong part as well there. Next, please. Next, please. Right, so incomplete, as Masood mentioned as well, that's an inverted Y, a lambda, and the two columns, and the acetabulum is stuck between the two columns is a hemisphere, and an inverted horseshoe shaped. It has an articular surface, and it is a non-articulating part, which is a cotyloid fossa, which is the lower part of the articular surface is supported by these two columns, which were described by Latona and Jude as an inverted anterior column and posterior column. Next, please. Next, please. Right. So the anterior column it starts from the iliac crest superiorly and down to the pubic symphysis below, and it does the crossing the acetabulum. And the posterior column is a shorter column as compared to the anterior column. The anterior column is quite big, and the posterior column is short, but it's quite thick and stout, and it's with the posterior part of this. It involves the greater sciatic notch and to the ischial tuberosity and traversing through the acetabulum. Next, please. And there is this very strong part of the iliac bone, the hemipelvis, which is called a sciatic buttress, and it's aligned posterior to the anterior column, and it articulates also with the sacroiliac joint, that area, which is quite thick, and it forms the superior border of the sciatic notch, and the quadrilateral plate, which is on the medial side of the pelvis, and it forms the lateral border of the pelvic cavity. Next, please. Right. So this is the pictorial diagram. This is how can you see the columns, the anterior column and the posterior column, because the whole of the classification is based on the column theory which was put by Littonal and Jude back in 60s. Next, please. Right, so it's Littonal and Jude It's a very commonly used and easily used. Mostly we are quite used to this kind of classification. Now there are other classifications coming out as well, with the AO classification and modification of AO classification, but still this is the gold standard. This is being used all over the world, the Letournel classification, and this is the one I've been trained with, and I was trained with this classification. So it has mainly two components, which is the elementary fractures and associated types. Elementary classification or associated type. In elementary, there is a posterior wall fracture, posterior column fracture, anterior wall fracture, anterior column fracture, and transverse fracture. So these are the elementary fractures that happens. Next, please. And then associated, which is one or two columns are being involved, or one or two parts of the columns are involved. So it's one is a posterior column and posterior wall, and then transverse fracture and posterior wall. Now, transverse fracture is a fracture which actually involves both columns in a transverse plane. It cuts the acetabulum through it, from anterior to posterior. An anterior column or wall and posterior hemitransverse. And then there is a T-shaped fracture. Next, please. And I'm sorry, and there is both column fractures as well. So this is a pictorial diagram of that classification. You can see very clearly on your left. This is the elementary classification, elementary fractures. So this is the first is just the posterior wall, in which just the posterior rim or posterior wall of the acetabulum that is fractured. Now again, the posterior wall again can be divided further, but we will not go into that, but just simply remember, if this is just a posterior wall fracture and it comes into the elementary type. And then this fracture, on your right, that is the posterior column fracture, which you see that the fracture is extending from the pubic ramus, inferior pubic ramus, to the traversing through the obturator foramen and through the acetabulum, and then exiting at the sciatic notch. And it is separating the posterior column from the rest of the pelvic bone. So this is the posterior column. Next, please. Now, again, this is the anterior wall and anterior column, anterior wall fracture, in which the anterior wall is involved. On your left, on your right is the anterior column fracture, which is involving the ramus, the inferior pubic ramus, and is traversing again through the obturator foramen, and then through the acetabulum, and is going towards the ilium, and it can exit at variable distance at a variable part of the ilium, right, exiting up to the iliac crest area. Next, please. Now, this is a transverse fracture. This transverse fracture is involving, it's going right through the acetabulum transversely. So that's why it's called as transverse fracture, but it involves both columns. It's different from the associated both column fractures or both column fractures as well, also, which I'll explain later. But this is, for this moment, you can see that this is a transverse fracture, which is involving both column and is traversing through the acetabulum. Next, please. Now, this transverse fracture, it depends upon where the fracture is in the acetabulum. It could be infratactal, it could be juxtatactal, or it could be transtactal. It means that it's going at below the middle of the acetabulum, then it's infratactal. If it is going through the middle, juxtatactal, it's just going above the middle of the center of the acetabulum. This is the supratactal or transtactal, right? It has to be differentiated from the both column fracture because some part of the acetabular dome, it's still attached to the axial skeleton through its SI joint. So this is the transverse fracture. It's not the both column fractures, the associated both column fractures. Next, please. Right, then this is the posterior column, and this is now we are going into the associated column associated fractures. Now this is posterior column and posterior wall. Posterior column and posterior wall. So there is a posterior column fracture, but there is a posterior wall fracture at the same time. And this is transverse and posterior wall transverse fracture with a posterior wall element to that. Next, please. Now this is anterior column and posterior hemi-transverse. Anterior column is fractured, and there is a fracture again running through the acetabulum and exiting into the greater sciatic notch. Now it's a bit different than the T-shaped fracture, which you can see on your other slide. That it is not in the T-shaped fracture. The T is is going through and through the acetabulum. In this case, this is the anterior column posterior hemi-transfer. It is exiting above. While in T-shaped fracture, there is a fracture, transverse fracture, and then the vertical limb of the T is exits into the through the foramen, obturator foramen, into the inferior ramus. Next, please. Right, and then this is the both column fracture. Now look at this, the both column fracture. There are both columns are involved, right? There are both columns are fractured, but it is different from the transverse fracture in which both columns are also involved. Now, if you look at carefully, there is the articular part of the acetabulum or articular surface of the acetabulum in this both column fracture is not attached to the axial skeleton. It is floating free. It's floating free. While in case of transverse fracture, there is some part of the articular surface is still attached to the axial side. So that's how you differentiate between the both column fracture and the transverse fracture. So this is quite a serious fracture. So it's a serious injury and and also difficult to fix as well, difficult to treat as well. Next, please. Now, this is my topic was actually Letourneur classification, but I also added a little bit of this comprehensive classification, which is also being used as well, and it is actually extension of the Letourneur classification. So in this case, they say that type A, B, and C, depending upon the severity of the fracture, like the AO classification. This is also from less severe to more severe. Type A is partial articular fracture. Only one column is involved, or one part of the column. Posterior wall fracture, posterior column fractures A2, and anterior wall or anterior column fractures, that is A3. Next, please. Next. Then partial articular fracture type B, which is a transverse or T type fracture, and when both columns are involved. So it is a partial articular fracture, but because still there is some part of the acetabulum still attached to the axial skeleton. So it's a transverse fracture or T-shaped fracture will come into this anterior column plus posterior hemi-transverse fracture. That will be V1, V2, and V3 depending upon the severity of the injury. Next, please. And then C type C is a complete articular fracture. So it's both columns are fractured and then the acetabulum is floating, like both column fracture in Letourneur classification. So C1 is both column, which is a high variety. So anterior column fracture extends to the iliac crest, and C2 is both column fractures. It's of a low variety when anterior column fracture extends to the anterior border of the ilium. And C3, both column fracture is when it is involving the sacroiliac joint. Next, please. Next, please. Now, there are additional qualifiers for this. You can further qualify it depending upon the femoral head, whether it is subluxated or whether it is dislocated, and then the articular surface of the acetabulum, whether it is only a chondral lesion or when it is impacted above the femoral head, whether it is chondral lesion only or it is the articular surface on the femoral head is impacted, or there is also an osteochondral fracture, and when it involves the there is an intra-articular fragment when the sacroiliac joint involvement there as well. Next, please. Next. Right. So type of fracture. depends upon the position of the femoral head in the acetabular and magnitude of the force. And so that means depends upon the position of the limb at the type of the impact. So if it is, the in flexion position or in extension, medial rotation or lateral rotation, depending upon where the force, which way the force is coming, and that, the fracture pattern will happen according to that. Next, please. So there is a radiographic evaluation. You evaluated by X-rays, as Masood has already said. You need 3 X-rays, standard AP view, and then 45-degree obturator oblique view, and 45-degree iliac oblique view, and then for a bit more clarification, and you want to know whether about the articular surfaces, whether they are impacted, or whether there is any damage or osteochondral fracture, or there is any intra-articular fragment of the in the acetabulum. You want to have a CT scan. For the just for ordinary diagnosis or ordinary acetabular fracture, I think the 3 standard views of the X-rays, they are sufficient. But CT nowadays we need for a bit more detailed view to plan the surgery. Like if there is impaction of the acetabular articular surface of the femoral head or the osteochondral fracture, so we can plan ahead. Plan ahead for this for surgery if you're doing. Next, please. So these are the lines which Masood was talking about. The one was iliopectineal line, ilioischial line, teardrop, the anteriorly, posteriorly. Next, please. So and the dome of the acetabulum. So these are 6 lines which you must qualify, and you must actually identify on a plain X-ray before you can actually diagnose a fracture of the acetabulum, whether it's one column is a anterior column or posterior column or like that. Next, please. So these are just the pictorial drawing. So you can actually draw those lines when you have next time when you have an X-ray. So you can draw those lines and then try to identify them. And unless you have identified, don't go further. So you need to then only if you have identified those lines and mark them, only then you can go further. Next, please.
Hotspot on the connection.
And this is the obturator oblique view. You can see the obturator foramen is this is the view that in the iliac bone it shows as a blade, and you can see the anterior border of the iliopectineal eminence and the anterior border of the ilium, as well as in the pubic the superior pubic rim is in one line. And very clearly, you can see that there is an obturator ring or obturator foramen. So this is the obturator view. So in this, this is for the anterior column and for the posterior wall. Next, please. Next, please. Right, and then this is the iliac oblique view. So I'm not going into much detail because Masood has already talked about it. Again, this is, you see the whole of the inner surface of the acetabulum, the iliac view. The iliac bone is very clear, and the ischial spine, as well as the inner surface of the pelvis. So this is very clear. This is the iliac oblique. This is for the posterior column and for the anterior wall or anterior. Next, please. Right. So CT scan, axial cut should be taken with thin slices, and it extent and location of acetabular wall fracture is shows you, and the presence of intra-articular free fragment, orientation of fractures line, and marginal impaction. And femoral head defect, rotation of fracture fragments, and pelvic hematoma, sacroiliac joint integrity or sacroiliac joint fracture injury, it shows you as well. Next, please. Oh, right. This is a very important slide for the CT scan on your left. If you see this view, and if there is a fracture in the transverse plane, this is the column fracture. And if there is a fracture in the vertical plane, this is wall and transverse fracture. Just remember that. If you can remember this diagram, so you will actually can diagnose fracture on a CT scan. Next, please. And then this nowadays we use 3D CT scan as well, just for it makes life a bit easy, and also it helps us in planning. And it helps us in better understanding of the fracture and operative approach, and we can also take away unwanted part of the bone and to see the fracture very clear. As you see in the lower part of the diagram, the head has been taken out of this fracture of this scan, and so that we can see the acetabular very clearly. Thank you very much. Next, please. Yeah, so that was the end of my presentation. Thank you very much. If there's any questions, we can talk about that. Thank you.
Thank you, Dr. Javed Saab. Very elaborate presentation. Obviously, as I said yesterday, there will always be overlap of the concepts. So the good revision of classification as well as gain the radiology, pertinent points, the lines as they would appear on the X-rays, AP and both oblique views, and the CT scan. So any comments or questions, please? It is a Sunday morning. People are slow to join in. Anyhow, we have 17 participants. Let's hope rest of them join in due course of time. We will continue in the interest of those who have joined on time. So next
Sorry,
is
Masood.
our colleague.
Masood, can I say just something? You see the previous link that was advertised in the first week, that is still active. I was on that link for about 15-20 minutes and nobody was in, so I really got worried. So then I looked into it. So the link has changed. So if they can cancel that, it's not been canceled. So if they can cancel that, so then nobody can join there.
Masood, can I have a request, please?
Yes, sir.
Dr. Ayaz, बात कर रहा हूँ.
You go ahead, sir. Go ahead.
Masood, we have हमारा बिजली का कुछ मसला है. Even right now the electricity is not there, and मैं hotspot से connect हो चुका हूँ. If you can, मेरा हनीफ के बाद मेरा लेक्चर है, लेकिन अगर हनीफ के बाद से पहले मेरा कर दे, ऐसा ना हो कि कुछ मसला आ जाए.
हनीफ साहब, कोई मेरा ख्याल कोई प्रॉब्लम नहीं होगा. He's kind enough. आप शुरू कर लें सर. I know वो कल फायद साहब के साथ भी कुछ हुआ था ये वाला issue.
Exactly the same issue is getting.
No problem, sir. Ayaz bhai, आप please आप start कर दें. Dr. Ayaz साहब is a professor at Khyber Medical College, our very dear friend. He will take us through the talk of choice of approach, which fracture and which approach to take on which fracture. Please go ahead.
Thank you. Okay.
Yeah, we can see your slides. Yes, sir.
Okay, thank you very much, Masood, for inviting me for this talk. And you see, my job today is to have approaches to the acetabulum and what is the choice of approach. We all know that there is no one surgical approach which is applicable to all the fracture. But the important thing which we all should know is that the precise anatomy of the fracture should be defined pre-operatively. A surgical approach to fix all or most of the fracture parts should be then selected. A precise knowledge of the capability of each surgical approach is also necessary. One should know that with which approach he can fix most of the fracture part. And of course, capability and preference of the individual surgeon matter also. The approaches we all know about, the approaches that the famous Cocker-Lingenberg approach with or without trochanteric osteotomy, the ilioinguinal approach and his modification of Stupa approach, iliofemoral approach and extended iliofemoral approach. Any one of these approach can be used, or a combination of approach can also be applied to it. The Cocker-Lingenberg approach, which is, you see, this is the non-extensile approach to the posterior acetabular fracture. This approach, you see, you can do this approach either in the prone position or in the lateral positions. The important thing is, you see, this approach, you can reach to the posterior wall and posterior column of the acetabulum. And if you need more dorsocranial portion, you want to have more dorsocranial portion, you see, you have to need through a trochanteric osteotomy to reach to the, and direct visualization of the dorsocranial part of the acetabulum, that should be either through the fracture gap or after capsulotomy of the fracture. Okay. You see, if you look at this diagram, you see the dark brown area. You can access to this dark brown area directly through the Cocker-Lingen back approach. But if you need to take a trochanteric osteotomy, now you see it give you more dorsocranial access to the posterior element of the acetabulum, while the green area, this area, if you reflect the femoris quadratus muscle, it give you more access inferiorly to the area. The area in light brown can be accessed by palpation, or you can reach to this area with a clamp placement. The skin incision for this approach, for the Cocker-Lingen approach, the first of all, the 3 points must be identified and it should be marked. That is the posterior superior iliac spine, the greater trach, and the shaft of the femur. The incision then started from a bit posterior and distally from the few centimeters from the posterior superior iliac spine, and then it's toward the greater trochanter, and then curve along the shaft, along the shaft of the. First is the skin and subcutaneous iliotibial tract, and the other is the gluteus maximus muscles. You see, you cut the iliotibial band, you see, cut it, and you extend it proximally, then split the gluteus maximus muscle. You create actually two bellies. One is the interior belly, and the other is the posterior belly. The interior belly is based on the superior gluteal artery, while the posterior belly is based on the inferior gluteal artery. Once you do it, then you have to do the deep dissection. Once you remove the fats from the external rotator and put the foot in the limb in the external rotation position, you will see these important structure, that is the superiorly the piriformis muscle, the superior and inferior gemelli, the obturator internus, and the femoris quadratus. And you can see the sciatic nerve, which passes interior to the piriformis muscle, while it passes posterior to the gemelli and obturator internal muscle. The next step is the exposure of the, you see, once you have this exposure, then you have to take and cut these short muscles, especially the superior, inferior, and obturator internus muscle, and half of the piriformis muscle. Once you do it, you will see that you flap the muscle, and you can see the giant capsule, and most of this wall, this posterior wall and structure is now visible. You can put one retractor here, one here, and one here in the greater and lesser sciatic notch, and here you can see now almost all of the posterior element is visible. Now, for additional exposure, you need a trochanteric osteotomy, and that I already said that the green area, that this blue area, you can see as if you do a capsulotomy or exposure that give you access more. If you have the option to perform a capsulotomy, then a T-shaped incision should be given in the capsule to see the articular surface directly and to reduce it. You see this limb of the T should be a few centimeters from its attachment, and then this vertical limb of the capsulotomy should be along the neck of the femur. Again, the same thing, you can see the incision. If you need a proximal extension of this dotted area, this dotted incision, you can extend the incision proximally. It will give you a more cranial exposure of the muscle. Again, you can see that the muscle and the transverse fasciolata and the gluteal muscle has cut and the two bellies are created. You can see here again that deep dissection. You can again see the muscle, and all these muscles should be cut a few centimeters from their trochanteric attachment. You can see the
Hello, Ayaz Saab. I think we have lost him for a while. It may be some power issue, electricity. मेरी आवाज आ रही है नीफ साहब?
जी सर, आपकी आवाज आ रही है।
जी सर, आ रही है
जी। तो फिर क्या करें, आप मेरा ख्याल शुरू कर दें
सर।
उनका शायद पावर इशू हो गया, वो कह रहे थे। आई थिंक इट वाज टाइम बाउंड,
सर फोन करके पता कर लो, फोन करके।
We will take him back once he on. Saad, can you privately contact Dr. Ayaz, please? ये नीफ साहब आप शुरू करें, बिस्मिल्लाह, indications.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning to everyone. My task is to go through the indication. Is the voice clear?
Yeah.
Yes, very clear.
Okay. So our concern is pain, instability, and decreased range of motion. So the function. So factors leading to poor outcome. They are a personality or type of the fracture, fractured area, displacement, marginal impaction, associated dislocation, and other associated injuries. So accuracy and stability of surgical reduction is very important, as well as the post-operative rehabilitation. So emergency indications are open fracture, irreducible hip dislocations, progressive neurological deficits, and vascular injuries. So non-urgent semi-elective, when we have the physiology normal, when the patient is stable to operate on. So this is within 3 weeks of the injury, and it is said as early as possible. So it is the ideal time is less than 2 weeks. So the indications, we know that hip joint instability and incongruity. And if we go into the details of indication, so the patient has to be physiologically stable. As yesterday, Dr. Gavin showed a case, they were not able to operate him on for a longer period until the patient was stable. So a displacement less than, if the displacement more than 2 mm, it is again controversial, or maybe it is overrated. So up to 3 mm and up around 3 mm is acceptable. Of the weight bearing dome in both AP and Jude views, unstable on image stress examination and anesthesia, intra-articular fragments, articular cartilage impaction. So lack of secondary congruence or significant deformity in both column fractures, displaced associated femoral head fractures, posterior wall fracture involving more than 40%. So it is very difficult to judge and assess that what is 40% and how to go about it. So posterior wall fracture dislocation, this clear cut, and preservation of the bone stock. So displacement of fracture more than 2 mm in weight-bearing area. This was a study published by Mata, that fracture reduction has to be within 2 mm, and incongruent reduction correlates strongly with poor outcome. As well as if the incongruency is in the non-weight-bearing area, the outcome is good. So operative treatment of displacement fracture of acetabulum, there was a meta-analysis. They studied 3,670 fractures operated in 40 years of time. So most common long-term complication was osteoarthritis in 20% of the patient. And they studied that if the reduction was satisfactory, less than 2 mm, the incidence of the osteoarthritis was as less as 13%. And if the reduction is not acceptable or not within the range, then the osteoarthritis incidence is as big as 43%. So roof arc angle, this is also called the meta angle. This is very simple, maybe not simple for the resident. So if the angle is big, like if you see, if this is AP view or medial roof arc angle, this is a vertical line, and this is the line which is passing through the fracture. So if it is the angle is more, we are safe. We can do the conservative treatment. Again, we have to measure the same angle in the obturator oblique and as well as iliac oblique. So fracture through this part will result in significant poor outcome. So articular cartilage impaction, they are also not good for the osteoarthritis. They also have the osteoarthritic issues when they are not reduced properly. So it is said that we have to reduce them anatomically as we do the proximal tibial fracture disimpaction. So this is the example of the impaction. You see the both column involvement, maybe anterior column, posterior hemitransverse, and this is kind of gold sign showing us the impaction. So again, this is the CT showing us the impaction of the acetabulum. So fracture dislocation, they are clear-cut indication for the operative treatment. So this is posterior fracture dislocation is the most common thing, and we see the wall along with the dislocated head, and these are the CT images. There is the incarcerated intra-articular fragment, and you see the impaction here. So this is the 3D image. So if can you see the picture down there on the right corner? You can see, sorry.
Yes.
You can see this one. So here I can't see. I think there's some problem. Anyway, so in this picture it is shown. So there about the intra-articular fragments. If they're well in the fovea, and they are stable, we can leave them alone. And if the fragments are outside the articulation, less than 5 mm, can be left alone as well. But if the fragments are intra-articular like these ones, we have to take them out. So secondary congruency, this was described and defined by Luterne. He says that when both columns fractured, they don't have any association with the axial skeleton, and they move as a single component, single unit, along with head, along with the acetabular cartilage. They are displaced from their normal anatomical position, but they retain their congruency along with each other, the head and the acetabulum. This is called the secondary congruency by Luterne. So if you see this, these are not secondary congruent, these are non-congruent both column fractures. So lieutenant treated 13th both column fracture non-operatively, and the score was good to very good. And he says that, you know, there is selected high risk for operative complication. Then we go for the, you know, the secondary congruence non-operative. Again, here are the, you know, secondary congruent joints, both column fracture. So we can preserve the joint by leaving them alone, but at the cost of significant deformity in the pelvis, limb length discrepancy, and malrotation as well. And it is not preferred method because, you know, we are sacrificing the function. So lastly, we operate the patient for the bone stock preservation for the future THR, because not all the fracture can be fixed, not all the fracture can be reduced. So when we see that there's gross combination, gross malalignment, we are unable to reduce them anatomically. We just fix them to preserve the bone stock and to have the normal or neo-normal primary total replacement. Very common fracture, and when we can't reduce them properly and reduction is impossible or not acceptable, are the great damage to the articulate cartilage. So we have to consider these things: the medical comorbidities, Marlowe injuries, open wound, suprapubic catheter, infection around the around our operating sites, osteoporosis, yes, secondary congruence in both column fracture. When we can leave them alone, we can leave them alone. Displacement more than or less than 3 mm. Pregnancy is not the contraindication for any fixation, especially the pelvic. So we have to take on board the gynecologist and the obstetrician, and we have to do the, you know, pre-operative ultrasound to see the life of the baby, and discuss with them all the, you know, possible complication, and still we operate. And there is study from Turkey that they operated such cases with the percutaneous fixation. So obesity, again, in some of the literature, they say this is the contraindication. I don't think so that this is contraindication, but this is very difficult to operate on the obese patient. But again, you know, we have to weigh between the benefits and the we have to weigh between operating and non-operating treatments. So this is the clinical example of our own case. So it looks like an anterior column with posterior hemitransverse, a young lady of 30 years. She don't have any other problem. So on this X-rays look to be secondary congruent, but, you know, the Mata angle tells us that, you know, it should be operated. So we operated on with the alveolar approach. So we fixed the posterior column as well with the 2 screws, and dual fixation with single approach. Very good outcome. She came to us after maybe 6 or 8 weeks with walking full weight bearing. Another case, 25 male, had RTA, managed as per ATLS, no other injury, you know, grossly comminuted fracture, both column fracture, no part of the column, of any column attached to the sciatic buttress or the axial skeleton. So these are the Jude views and iliac oblique and obturator oblique. So these are the CT images. So what to do with this? So we optimize the patient for the surgery. When the physiologically patient was stable, we planned and we operated on. So we used alveolar approach, and it was very difficult for us. I don't know, sometimes we have difficult imaging. So it was very good reduction of the posterior column as well. And we could have put, you know, the indirect and anterior to posterior screws, but due to imaging, or maybe what happened, it's an old case about 2 years ago. So we have to stop it there, and we stage it, and we went for posterior cochlear back, and we fixed with the 2 plates and the screws. So this is the final outcome. The patient is doing fine. Thank you. Any question?
Thank you, Nibai. Any comments, questions from the house? I did manage to talk to Ayaz, and there is a power issue there. We will reconnect with him as soon as the situation allows. So if there are any comments, questions?
My question from Prof. Masood.
Yes, please.
How about morbid obesity and how about pregnancy? How do you manage those cases?
Well, if I was to answer, I just had a bad 6-month-old pregnant lady with a badly displaced transverse. It was a T fracture. Managed initially. She went to northern areas for vacations, and there she had this accident. So initially managed in a local hospital with trochanteric traction, and then brought to us. But it was very displaced and may have required a dual approach. So I just shied out. So I was not comfortable doing a percutaneous job and required elaborate dissection. So 6 months pregnancy, I just told her to have a longitudinal traction and come back to me once she delivers. We will handle the malunion or do a total hip. She was a 30 plus lady. Depending on what's the outcome at the 3 months down the line at the time after delivery. So this is a very recent case that I did not manage actually. I opted for a conservative treatment. Maybe we can go around the group and have their opinion.
Thanks. How about obesity?
Obesity, I think, should not be a contraindication. There are anesthesia issues, there are concurrent other injury issues which may take precedence. But I have operated on big people, really inguinal also. You have to go very deep, and posterior Cocker-Langham approach also you have to go. But I guess we are used to it. We can manage, and I have managed. So it's to me, it's not a big time contraindication. But pregnancy certainly is. You are dealing with 2 lives rather than 1, and obviously both are precious. You need to take a very calculated decision. So, any other comments from group members about pregnancy? That is you do encounter occasionally.
Yeah, in case of obesity, I had, when I was training back in England, I had, I think on 2 occasions, we had this very hugely morbid obese patient. And you see, it all depends upon the local environment and the facilities and the surgeon. How much the surgeon is comfortable doing this. Yes, it can be done. In America, they are doing all these morbidly obese patients, all these, because they are all geared for it. And their table is big. The big table, they have this big table, almost double the size of the normal table. The instruments, they have actually custom-made instruments for these, for these obese patients. So if you don't have those, facilities, and you don't feel comfortable, I think it's better to treat them non-operatively than really operatively. And so my view would be just look at to yourself whether you are able to do it, you have the guts to do it, or you have the team around you and the environment around you which can support you. And then I think you should make the decision whether to operate or not to operate. I think that's what I would say.
Yeah, as long as you have the anesthesia issues covered, morbidity basically is not contraindication for surgery. You can use slightly larger incisions, and having a good radiation table helps. And wherever possible, you should go for percutaneous fixations. Patient with morbidity.
Nadeem, Umair has a large number of patients in Gurki. I would like to ask him, Umair, do you have operated on pregnant females in their mid-trimester or?
Yes, that's a very interesting. You really are, converting the devil in the deep blue sea. I had this lady 7 months pregnant, and she luckily had a geometry type which I could operate in a lateral decubitus position. It was a transverse posterior wall. So we operated on her with special consent and proper anesthesia care, and we did not use any image intensification. We passed the anterior column screws by manual palpation through the greater sciatic notch. Only one experience yet, and I think it went well.
Obviously, these are very rare to happen in these pregnant ladies. And
there are a dedicated anesthesia team that specifically looks after the pelvic and acetabular fractures.
Yeah.
So it was discussed with them, and when they gave a go ahead, we.
Yeah, but yeah, this the issue of radiation, during pregnancy. I mean, you said about how much trimester she was? 6 months pregnant, was she?
7 months. The lady I operated was 7 months pregnant.
7 months.
But we had, because we went to the Cochlear back, we didn't have to go around the pelvic.
Oh, that's what I'm just asking the panel whether it's quite safe to give radiation in the 7 months pregnant lady. I mean, because doing it blindly, it will be quite I would say quite unsafe to do to fix those columns if you're not doing without image intensifier. But I would say it would be quite safe, wouldn't it?
Even at 7 months, the radiation is relatively safe. Obviously, the period of organogenesis is gone, but patient and their attendants, they're concerned. So if you can avoid radiation as much as possible, it's good. I told the geometry was such that it could be dealt with without image intensification, which is a transverse posterior wall.
Gavin is also online. Any thoughts on this issue of pregnancy and fixation of acetabulum or even pelvic fracture?
Hi, Masood. Hi, everybody. Can you hear me okay?
Fine. Yes, I can hear you.
Good. I have to say I have very little experience of dealing with acetabular or pelvic trauma in pregnancy. I think everything that's kind of been mentioned so far is all very reasonable. I think trying to avoid it as best possible and minimizing radiation exposure to the unborn, maybe no matter what trimester they're in, is important. I think it really also comes down to your confidence in dealing with the I suppose post-operative malunion and the consequences of that. As Umair has said, if you have relatively simple fracture patterns that you can treat, staying well away from the true pelvis without much or no radiation, then I think it's okay to do that. However, you may need to just be selective in what you do for parts of the fractures. You maybe partially fix the fractures as opposed to passing blind screws. But as mentioned already, whether it's for pregnant women or for obese patients, a lot of it has just got to do with your own comfort, skill, ability, and I suppose risk profile for these things. I think most people would definitely err on the side of caution and try and treat as conservatively as possible.
Great. So I think the message is clear. Depends, be sure what you are trying to deal with. You should have a team and need to discuss with the patient. You're dealing with 2 lives now. Avoid radiation as much as possible, and you can avoid, if possible, avoid surgery. I think we may still discuss the issue again with other international participants, but in the interest of time, we move ahead. with Dr. Umair. I think I saw Ayaz, but he again disconnected. So let's move ahead with Dr. Umair.
Masoud, my connection is now good. If you can kindly allow me to complete my talks.
Okay, sir. Okay, I just saw you and I thought you were disconnected. Now you're back. Please go ahead. Go ahead.
Okay, thank you,
You can
Masoud.
share your screen. No problem.
Okay.
What was it? The power issue or something else?
It is a power electricity problem because we
right.
don't have. Please allow me to share my screen.
Dr. Hanif, you can unshare, please.
Yes.
Okay, Azbai, you can share now.
Okay, thank you. Okay, thank you. I will just quickly go through my previous slides. And you see that I have already discussed these few slides about the Cocker-Lingenbeck approach, and it is an extensile approach that usually put you to the posterior elements and paraacetabular area. If you need an extended, then you craniodorsally, then you do the incision is, you see the 3 points, that is posterior superior iliac spine, greater trach, and shaft of the femur should be marked, and the incision should extend, curve over the greater trochanter. Then you have the superficial dissection, that is tensor iliotibial band and gluteus maximus muscle. Incision should be given in the iliotibial band, and the gluteus maximus muscle should be split to place then into interior and posterior belly. The interior belly as superior gluteal artery base, while the posterior belly is based on the inferior gluteal artery. Then we have the deep dissection, that is the gemini and obturator internus muscle, piriformis and quadratus muscle. These muscle will then, when you flip off these muscles from their trochanteric attachment, you can see the giant capsule very visibly, and it tells you about all the posterior structure, that is the posterior wall and the posterior column of the acetabulum. You see, if you need more exposure, then you need a trochanteric osteotomy, and this blue area is the further access to the posterior element with a trochanteric flip. If you need to open the capsule, then you need capsulotomy, then a T-shaped incision should be given in the capsule to see the joint directly, and if there is any visible, again the same incisions, superficial dissection, deep dissection. You can see all the 3 muscles, they are cut from their trochanteric attachment, flip the capsule, and you see now that dark brown area, you have a direct access through the Cocker-Lingenbeck approach to with this and this light brown area, you have access with either with a clamp or with your finger. The indication for this approach is, you see, that is the open reduction and internal fixation of the posterior wall and posterior column, the transfer fracture, that is juxta and infratectal fractures, combined fracture types in which the posterior column or wall need to be reduced under direct vision. These are the different indication for the Cocker-Lingenbeck approach. These are the multiple fractures, that is posterior wall, posterior column, transfer fracture, transfer plus posterior wall, and T-shaped fracture. All these fracture can be fixed with the Cocker-Lingenbeck approach. You see, this approach is associated with a number of, like it has, you can damage the sciatic nerve, the posterior surface of the quadratus femoris muscle. You see, extend the tip for this thing is to prevent the injury to the sciatic nerve, keep the knee at 90-degree flexion and hip extended during the procedure, while especially doing the deep dissection. And you see, it will minimize the chances of injury by using proper gentle retraction and release by short external rotator posteriorly to protect the sciatic nerve from traction. The inferior gluteal artery, it leaves the pelvis beneath the piriformis muscle. The superior gluteal artery and nerve, they leave the pelvis about the piriformis and enter the deep surface of the gluteus maximus muscle. You see, and this teeth ring limit upward retraction of the gluteus medius and block you from reaching the iliac crest. Injury can cause excessive bleeding, of course. Okay, excessive retraction and injury of the quadratus femoris may be avoided to prevent damage to the medial circumflex artery. Debride necrotic gluteus minimus muscle to decrease the chances of ossifications. You see this area direct axis, and the other light brown area have indirect axis. And if you need a more think trochanteric flip, you can see that this area also will be accessible through the trochanteric flip through a Lingenbeck approach. You see, this is again, you can see the steps of the trochanteric flip, given incisions, do superficial dissection, take a flip of the greater troch, and you see that these are the external rotator muscle, and you have put the flap interiorly, and you can see this area give you access to the dorsocranial area of the acetabulum. The posterior superior wall fracture, the transfer fractures, transfer plus posterior wall T-shape fracture, associated posterior column plus posterior wall fracture. But the most important indication for this thing is you see this trochanteric flip osteotomy, as you see that is the superior wall extension or a transtectal transfer fracture component you can fix with this approach. Again, you can see that you see it give you more access to the posterior element as well as to the dark area, and you can see the light brown area which have a direct or through clamp or digital access. Again, you can see that the area is more. The next approach is the ilioinguinal approach to the acetabulum. This approach was actually developed by Leutenal, which is based on cadaveric dissection to provide interior access for fracture of the acetabulum. The important thing that it provides exposure of the inner aspect of the innominate bone from the sacroiliac joint to the pubic symphysis. And the surgical approach requires development of the 3 wound intervals. Immobilization of the femoral vessel and nerve and spermatic cord in male or round ligament in female is the key element. It gives a direct articular reduction using the ilioinguinal approach are done indirectly. You can see this is the incision landmarks. This is a superficial dissection. You can do it. You can see as the iliacus muscle, the interior superior iliac spine, and the internal iliac fossa is visible. You can see when you do it, you have a spermatic cord here and femoral vessel somewhere here. It's already been, the anatomy is already been discussed in detail by Naveed. And you can see that this fascia, of external oblique is cut longitudinally. And this is the inguinal ligament, which is running along from the interior superior iliac spine toward the symphysis pubis. This incision should be given a bit above the thing. And you see these are the great vessel which coming from the pelvis into the inguinal triangles. You can see these vessel, these femoral vessel and thing. This is a cross section. You can see this is the iliopsoas muscle. These are the femoral vessel and nerve, and somewhere here is the spermatic cord. You can now see very nicely, you can see this is the iliopsoas muscle. These are the femoral vein and nerves, and this is the spermatic cord, and it will give you access to the different window which you can see it now. These are the different fracture which can be fixed with the ilioinguinal approach, the interior column fracture, the interior wall fracture, the interior wall and the hemi transfer fracture, the both column fracture in which the interior column need the transfer fracture and the T-shaped fracture. All fracture of the interior wall and interior column have access to this this thing. It is associated with interior plus posterior hemi transfer fracture, both column fracture, and some transverse or T-shaped fracture can be fixed with these thing. In dark brown area, if you can see here, you have a direct access to this area, while you have indirect access either through the your digital or a clamp access to this area. The first window you see when you give an incision and you elevate you see this is the iliopsoas muscle which you have reflected, and you can see this window can expose you from the SI joint up to this area. These are the femoral nerves and femoral vessel, and here you can see this is your this is the pelvic brim. You can see the pelvic brim here, and the first window tell you about the lateral exposure of the second window. When you pull the iliopsoas muscle laterally and the femoral vessel, you can see this portion of the pelvic brim which is now visible and exposed, and this is the second window. The third window you can see when you pull the vessel, the femoral nerves and vessel laterally, and you can see the spermatic cord, and you have this is the this give you access to the third window between the vessels and the spermatic cord, and here you get directly over the superior ramus. This approach is also associated with a number of problems like femoral nerve injury, femoral and external iliac artery, lymphatic, lateral cutaneous nerve of the thigh, inferior epigastric artery, the spermatic cord which contain the vas deferens and testicular artery. There is chances of damage to all these structure, but they must be protected, and damage can cause because damage to this spermatic cord can cause testicular ischemia and infertility. Heterotropic ossification, of course, much more common in the extended iliofemoral and Cocker-Lingen approach. The obturator nerve causes medial thigh pain and thigh numbness when it is injured. The Stupa approach, it is actually a modification which was introduced to manage a fracture of the interior column instead of the ilioinguinal approach to reduce the morbidity. You can see two incisions. Transfer incision is made approximately 2 centimeters above the symphysis pubis, just short of each external inguinal ring. The lateral window in incision is made along the iliac crest, starting 2 centimeters posterior to the interior superior iliac spine, and it follow the iliac crest. You can give a separate incisions. You can see these once you give an incision, transfer incision, you cut the subcutaneous tissue and rectus fascia are incised transversely. You can see the rectus abdominis fascia is split along the linea alba, and you see the transverse fascia is open superior to the pubic symphysis. This open the potential space of radius. This approach is also associated with a number of complications like obturator nerve and nerves and vessel. Corona mortis, these you see already been discussed that these are anastomosis, must be ligated as they appear on the lateral 1/3 of the superior pubic ramus. They are nearly universally present, but very significantly in size. The external iliac vessel, it exposed and retracted early in the exposure, must be mobilized to expose the iliac fossa and false pelvis. The bladder, the Foley catheter limit injury to the bladder. Placement of a malleable retractor interior to the bladder also help to protect. The iliofemoral approach and the approach named after Smith-Peterson share a similar skin incision, but different markedly in the deep exposure provided. You can see here, the incision is all given. You see this is the incision. This is the deep dissection. You see this is the superficial dissection. You can see the fascia is cut. The tensor fascia lata is cut along the shaft of the femoral vessel. You can see here the retractor is placed, and the interior portion of the acetabulum is exposed, and you can see the tensor fascia lata muscle and all these things. In dark area, it gives you a direct access to this area, while in light brown area, it gives indirect access to the indication for this approach is the fracture of the interior column, associated interior plus posterior hemitransfer fracture. The best candidate for this approach are those where the fracture pattern extends to the crest and there is a single large interior column component. Interior component of a T fracture is also an indication. The extended iliofemoral approach, that is the most extensive approach, extension of the iliofemoral approach posterior along the posterior part of the iliac crest is also given. You can see the incision is extended posteriorly and proximally to the dissection. You can already, this anatomy has been discussed, and the dissection, you can see the short external rotator muscle. You can see here, and you see this area, this give you a larger exposure to the most of the area of the acetabulum. The indication for this approach is, you see the transfer posterior wall fracture, T-shaped fracture, both column fracture with posterior wall or posterior column comminutions, sacroiliac joint involvement or very high posterior column involvement. The extended iliofemoral approach should not be used in aged or obese patient, nor in patients who are not committed to a long recovery process. Again, this approach is also associated with a number of dangers and complications like ossification, extended patient recovery period, and iatrogenic injury to the superior gluteal artery and vein, the sciatic nerve, the lateral femoral cutaneous nerves, and the perforating branches of the femoral artery. You can see again the Cocker-Lingen-Beg approach give you this axis. With trochanteric flap, you can see the exposure is extended on both sides. You can see this, the ilioinguinal approach give you this much access, some direct and some indirect. And the iliofemoral approach, you can see, give you exposure again in the dark brown and the light brown area. The light brown one is the indirect, while the dark brown area give you the direct approach. And you can see the extended iliofemoral approach. You can see now the exposure that is quite obvious and more. Thank you very much. Thank you, Masood.
Sir, thank you very much. Despite your technical power hiccups, thank you for managing. I think great job, quite comprehensively covering all the approaches and the exposures with each approach, their indications, and partly also covering the surgical aspect of them. I think any comments, questions from any attendees?
I want to ask Sayya Sahab. Assalamu alaikum, Dr. Nasir here, sir.
Ji, Nasir.
So previously, when we started doing in our residency time, and our Professor Khan Shadam was doing acetabulum a lot. At that time, we were using tri-radiate incision, and obviously that was an extended version of the Cocker-Lingen approach. And routinely, we were doing trochanteric osteotomy. So, what is the significance of tri-radiate approach, apart from these which you have already told? Because sometimes, obviously, you have to fix some transverse fracture from anteriorly as well as from posteriorly. So, what will be your preferred method?
The tri-radiate approach is usually, you see that is a more extensive approach and more dissection and morbidity is involved. I personally has not done any tri-radiate approach. If Masood you can comment on this thing. Hello?
So, sir?
Can I say something?
Yes, please.
No personal experience of a tri-radiate card approach.
Yes.
This is again what I learned from Azam, but have never tried that. I have tried same time anterior and posterior, or staged or sequential, but no experience with tri-radiate card. Like, ye needs up.
Can I comment? I have done only one, but after doing that, मैंने तौबा कर लिया, कभी भी नहीं करूँगा. Now you know the techniques and the imaging and all the things are so much advanced that we can do single approach dual fixation. And if we have some problem, we can do the dual approach. But you know, doing this extensile approach, it's not worthwhile anymore. I think. Thank you.
So
Nasir,
let's take Gigi. Go ahead.
Nasir, I may answer this question.
Yes, sir.
I've tried the extended iliofemoral as well and the triradiate. Extended iliofemoral is the most demanding approach, most mutilating approach. Triradiate, actually, when you start your work doing your surgery as a posterior approach, it's very easy to extend it, but again, it's quite mutilating, and I've stopped doing it. It is not a difficult approach, and it's easily done, but it doesn't, and it's very badly known for skin necrosis. But fortunately, I have not got any problem with the skin. But again, now, as Umair said, or I think Hanif said, there are so much good imaging facilities available and percutaneous work available, and it's not worth doing extended iliofemoral or triradiate now anymore. Thank you.
Thank you. Thank you very much.
Yes, I did one extended iliofemoral. It's very demanding and a lot of issues. Yes.
Exactly.
Yes, you're right. Yes.
I think the world is moving away from these extended approaches, and just as Sir Masood said, a combination of approaches or a sequential approach to the acetabulum by anterior and then a posterior approach, either in a flappy lateral position or full supine and prone position, is a much better approach, and you can deal with almost all fractures in this manner, except for perhaps for some old fractures beyond 3 weeks, where you can need extended iliofemoral approach. And one very important point is that if you are dealing with an anterior column posterior hamate transverse through an extended iliofemoral approach, it is important not to strip the muscles from both the iliac tables, because in this way the anterior column part is completely devoid of the vascular supply, and you can have a bone necrosis.
Yes.
Okay. In my personal experience, in my series of 150 plus bicolumn fractures, I never had to resort to an extensile approach.
One question from Dr. Umair. You are talking about the floppy lateral position. Can you elaborate on how we can manage the imaging in this position?
It's a very good question. In fact, floppy lateral, it is used in scenarios where you have to get a combined access to the anterior and posterior injury. There are certain fracture patterns where you can approach from anterior, you can close the NCN and then go through the posterior and then open and fix. But I had to deal with a T-type fracture which had a very large incarceration just below the femoral head. And the only way to remove that was with combined manipulation of both the anterior and the posterior column. So instead of an extended iliofemoral, what we do is that we put the patient on a radiolucent table in a manner that you can move him easily into a supine and then a semi-recumbent position. This is called floppy lateral. You open through, I open through modified stoppas as well as to the cochlear back, and you can flip the patient sideways 50 to 60 degrees on the table with convenience. You don't tie up the patient. The patient is mobile on the table, but you can manipulate from both the anterior and the posterior aspect.
You do the simultaneous?
This is floppy lateral is for simultaneous access.
Okay.
But the latest literature and even AO recommends that instead of floppy laterals, you should go for a complete supine and a complete prone approach while doing with the difficult injuries, because of better correlation with the anatomy and imaging.
Hanif साहब, ये floppy lateral इस तरह आप समझे कि the patient is lateral with the thoracic supports, thoracic anterior and posterior support. That's the top thorax is supported, and then you can rotate the patient into a semi-prone and semi-supine position by rotation on the lumbar spine. So this is the position we regularly employ when doing a hemipelvectomy for tumors also. So we have we need to go posterior, although incision is the same incision extending anterior and posterior, but position ke hisab se it is lateral with thoracic anterior and posterior supports. So lumbar spine is free to, patient is unstable at the lumbar area, and you can have floppy lateral, which is the name, and you can have semi-prone and semi-supine. And so working on both anterior and posterior sides. So, but मेरा issue सिर्फ lateral position में ये है कि like Dr. Umair, you also mentioned fixing that pregnant lady in a lateral position. उसमें तो आपने CM use नहीं किया, but visualization, radiological
Yes.
visualization in a lateral position. I think that was Hanif Saab's question also. Is quite
Lateral
difficult
position is
to
worst for
obtain
imaging.
the two images. Ji?
Lateral position is worst for image intensive, for imaging.
Exactly.
And
So
anatomical
very
purposes.
difficult to manage. I have tried that, but उसमें जुड़े views इतने कोई I could not. So I always go for
Sir,
prone
even for
or
transfers,
supine.
certain transfers and transfers with posterior wall, you can get best anatomical reduction in prone cochlear Langenbach only because of better correlation with imaging.
Yeah. So just another point of discussion: how many people have required a trochanteric flip in a Cocker-Langenbach approach? And if suppose
quite
we
a
are
few
fixing
times.
a posterior column, let me finish. Suppose we are doing a posterior column and a posterior wall. It may be an extended posterior wall. So, Gee, Dr. Umair, how many times have you required a
I have had
trochanteric flip?
experience. I use it quite routinely because of my experience in hip preservation surgery. We were doing GANs, surgical hip dislocations, and trochanteric flip osteotomy there. So it was an extension of that technique into the acetabular surgery, especially in cases where just you rightly mentioned that in patients with extended posterior wall injuries, or in patients where you are facing difficulty with the reduction of the anterior column, because a trochanteric flip, this allows you capsulotomy well into the anterior part of the acetabulum, the entire anterior rim, anterior wall, and as well as the root of the anterior column can be easily visualized if you do a trochanteric flip. And this is basically a kind of extended cochlear Langenbach approach, and your reduction of the anterior column. And also what it allows you is that you can safely dislocate the femoral head, and you can visualize the entire articular cup from the inside. And you do a direct reduction of the articular cup, and then you can fix it. So in cases whenever you are encountering difficulty with cochlear Langenbach, you can...
You do in prone position? You do in prone
this
position?
is possible only in lateral decubitus position, not in prone position. If you are planning a trochanteric flip, your patient should be in lateral decubitus.
Yes. True.
It's very difficult in prone to even dislocate the hip.
I think Dr. Ramsen has raised his hand. Maybe he wants to say something.
Dr. Ramesh Sen, please. Welcome, sir.
Good morning.
You are labeled as surgery events. I think वो मैं सही करवा देता हूँ. But anyhow, go ahead.
Please, I was just listening to the discussion on the type of approach, and my perception is that a lot depends on two things. First is our own experience, and second is the fracture pattern. Because many times we may be comfortable with one approach for a standard kind of a fracture with our experience, and then with our experience we can do little extended things also. But then we start learning some facts, just like Dr. Umair was telling about it, that there will be fractures which you require a better extension. And what I'm saying about the KL approach, we were doing most of the things with the KL approach and going for the second approach subsequently. But then we started doing this flip osteotomy, and we started progressing. Now we had this dome fracture. We tend to operate from KL. You have to do a lot of retraction for the abductors. And now we started using the Gibson approach. So doing that Gibson approach allows a very good retraction to access the superior part of the dome, and our fixations are relatively better off without much of the stress over the muscles around that area, and with small manipulation, just like lifting the limb up, putting the femur into the flexed position, you get a reasonable amount of exposure. But again, looking in the scenario of our developing world, lot many times we have got those fractures which are relatively late. And once you're operating on 2 months old injury, 3 months old injury, there is a lot of fibrous tissue which forms in the posterior fracture dislocations also, which is anterior into the joint. Now you need to access them. And that's one of my indications very commonly doing for flip osteotomy is to go anteriorly, clean up the area, get the head back into the position, and then get the posterior wall fragments back to their position. So likewise, depending on the fracture profile, the injury profile, you keep on varying. You know all the approaches, but then you have to be very selective about it, that for this kind of a fracture pattern, I'll need this approach. And probably initially we were always looking that KL approach is a single approach, but now the kind of a variety which is coming up is quite depending upon the fracture profile. So we are varying now in our approaches also.
Thank you. Dr. Umair, you want to add something here?
So just a single point. While doing trochanteric flip osteotomy, it is very important to preserve the deep branch of medial circumflex femoral, which is the main blood supply of the femoral head. So you make sure that you don't iatrogenically actually introduce a risk of avian. And to do that, it is important to let small part of gluteus medius to let it remain attached to the stable fragment of the trochanter, and also to preserve completely the piriformis muscle. The piriformis, because the deep branch of middle circumflex femoral runs just 1 to 1.5 centimeter away from its insertion into the superior part of the femoral.
Great point. Yeah, exactly. So, any other comments, suggestions from any faculty member? So if there are none, then we move ahead from approaches. I think the next talk was on scoring assessment methods, how to assess my fixation. And that was a new topic that we introduced this time. And a lot of times we need to assess what is our outcome, what are the criteria to assess the post-operative radiological outcome. And I gave this to Dr. Umair. I thought maybe the best person to dwell on this. So over to you, Dr. Umair.
Can all of you see and listen to me?
You can't see it now, Abhi.
Is my screen visible?
Yes, now it's visible.
Okay, I thank Dr. Masood for giving me a very interesting topic. This is a scoring method for acetabular fixations. I'm Dr. Umair Nadeem, working as assistant professor in the Department of Orthopedics and Spine Surgery at Gurki Trust Teaching Hospital, Lahore. Well, basically the outcome, the clinical outcome in an acetabular fracture depends, I think, much more than on any other factor. It's the reduction quality. Ideal is stable anatomical reduction. There are a number of ways of assessing your fixation power-up, that is, you can use power-up fluoroscopy, but this is not enough. There are other parameters, other variables that you have to take into account. So once you have done a fixation, there are various assessment tools for assessing your reduction and its quality. In my own personal experience, I think the results tremendously depend on the quality and the precision of that reduction. And when you start doing your surgery, even Mata has written about it, that in the first 40 odd cases, your reduction is not that good. And as you keep on doing the cases, you become more and more meticulous about your reduction and less about your approach and about your fixation. It is the reduction component of the surgery, I think, that is the most important, and that brings the clinical outcome in the patients. The outcome of an open reduction internal fixation of an acetabular fracture has other confounding variables that you have to consider. There is the complex fracture geometry, marginal impactions, the osteochondral injuries, and the chondral modifier on the femoral head and the acetabular side. And also there is a 3D interrelation of the steps and gaps that you have left behind. So this is still very much evolving, the acetabular assessment of acetabular fixations. The most renowned and commonly used method was first developed by Marta's. It is known as Marta's radiological criteria. It is most widely used. It is based on the concept of maximal residual displacement on the post-op AP and both the iliac and obturator oblique views. This maximal residual displacement is assessed in terms of two things. One is a gap and other is a step. A step is basically a displacement perpendicular to the articular surface, and a gap is a displacement along the articular surface. So according to Marta's criteria, if you have a maximal residual displacement of 1 millimeter, the reduction is considered to be anatomical. And this correlates with up to 90% of excellent clinical outcome results. And in my own personal experience, this is very much true. When you achieve a Marta 1 reduction, your outcome is also on the same lines. An imperfect reduction is when you have a residual gap or a step of 1 to 3 millimeter. A poor grade is when you have a 3 millimeter of displacement. The concept of secondary congruence has already been explained to you, so this is applicable only to the true bicolumn injuries. So if you have an anatomical reduction, most of the literature shows excellent clinical outcomes upwards in the range of 80%. Even in my own settings, and my friends, in all the surgeons that I have met, there had been a perception that you don't get good results with acetabular surgery. But this is not true in the literature. It has to do with the reduction quality. If you achieve the sorts of reduction, if you give the biomechanical stability, all the modern literature is reporting excellent results upwards of 80 to 90%. In my own experience and my published series, the results are in this range. So this is just for the practice of the residents. This was a true bicolumn injury with the APC opening on the contralateral side. This was a young patient. It's a true bicolumn combinated injury. This was fixed with modified Stoppers approach with a suprapectineal plate, antegrade posterior column screws, and also the fixation of the intercalary fragment with the screws. You can assess on the AP radiograph then in the dome there is no residual gap or a step. Again, you assess it according to Marta's criteria on the obturator view. You can also see this dome and cup here, and you can see if there is a gap. There seems to be a small gap here, but this appears to be less than 1 millimeter. Why I'm using the word appear? Because the radiography goes only that far. That's why this technique is involving, and there's more and more role of not CT, even 3D CT, which I'll be discussing later. And then this is the iliac oblique view of the same patient. Again, you can see that the dome is congruent, the head is congruent, and there appears to be no significant gap and step in this case. Also, there can be inter-observer variability in the assessment. So one might judge it according to one's own perception, and the other person might judge according to his own perception. So this method is not very objective, but in experienced eyes, I think it does correlate with your outcome. The other very important and a simple criteria is the use of hip joint center shift. And I also routinely apply it to my all post-op cases. There is a concept that if you have reduced all the columns and walls and all the 3D components of a complex acetabular fracture in an anatomical way, the hip joint center will be restored. Just like there's a concept of hip joint center restoration in total hip replacement, there is also a concept in acetabular ORF. Because it is said that the hip joint biomechanics, contact pressures, and even surface area impacts are highly influenced by the restoration of the hip joint center, and it also influences the risk of post-traumatic arthritis. Because even if you have reduced the cup very well, but the geometric hip center of the hip is not restored, the body lever arms, the forces that are applied of the head, and the shear that is generated is abnormal, and it can increase the risk of arthritis. There is a landmark paper by Hongfei Shi that describes all the techniques, and he described the measurements of the vertical and the horizontal axis. In general, if you have a shift of less than 2 millimeters of the standard deviation of the normal joint, it can give very good favorable results. They have actually compared the outcomes with this technique and the Marta's criteria, and the correlation came out to be that an anatomical reduction correlates with a shift of less than 2 millimeters. Briefly, I will be describing you the technique of describing the hip joint shift. You draw a horizontal line joining the lower halves of both the sacroiliac joints. And then you take its middle and draw a perpendicular. This is called the vertical line of the pelvis, the VA. And then you take the geometric centers of the femoral heads bilaterally, okay? And then you unite this with the VA. One line is called D1, the other is called D2. The horizontal shift is the difference in the length of the D1 and D2. And the vertical shift is that if there is a displacement or a gap between D1 and D2 in the cephalocaudal plane. Because in this fixation, the hip joint center was not disturbed, you can see that the D1 and D2 are equal and also they are collinear with each other. Whereas in this poorly fixed fracture, you can see the hip joint center is quite much shift. There is a cephalocaudal displacement, that is, there is a vertical adjacent shift. And also the length of this line and this line is different, which means that there is also a horizontal shift. Normally we have a supromedial shift and a kind of a protusio in poorly fixed acetabular fractures. I hope this concept is clear. Does anyone want to ask anything right here? Because I think it will be difficult for you to ask later on.
Yes.
Ji, Dr. Nasir.
It is clear.
Okay, thank
Very
you.
well.
So the next method that is also easy and easily applicable on the post-op radiograph. I am specifically focusing on the radiographic method for now because it is difficult in our setup to go for a CT in all the cases. So I think we should start applying this technique first to the simple radiographs, especially the Martas criteria, and then the adjacent. And this is another this is just in a recent paper that you can use a joint congruency measurement method. It is a very simple technique. You draw a circle along the superior head, superior contour of the femoral head, and then you draw a circle along the contour of your restored fixed acetabular cup. Okay, and then you draw or you mark the center of each of these circles. If the difference between the center of these circles is less than 3 to 4 millimeters, as is visible in this case, it means that it has correlation with good results. This is a very sensitive technique. However, this is not as specific. However, it gives less false positives as compared to the Martas method. In late 90s, Verbeek and the group, they also described this a CT method because it was thought that the radiographs, they underestimate the amount, the gaps and the steps, which is, I think, is very true because this is on radiographs, the assessment becomes quite subjective at times. And the quality of radiographs is also not good at times. So this relies on a standardized method of residual step and gap measurements employing a CT articular template. What you get is that you get a template of the normal hip contour, and then you compare it with the restored acetabulum for any residual gaps and steps. This uses 2D axial, coronal, and sagittal recreation in the 2D slices. The step is measured perpendicular to, and the gap is measured along the articular surface, and then it is graded as per in the Martas criteria. But what you are using is a 2D CT for this. It has Verbeek showed that it had a better correlation with the risk of arthritis, hip survivorship, and THA conversion. Like if a fracture was judged on Martas criteria, there was about 58 cases which converted to the hip. But when they were judged according to Verbeek et al. CT method, only 10 hips were converted to the hip arthroplasty. So this 2D CT method is objectively superior to the Martas method. Wherever possible, one must go with it. And now this is the latest. There is a concept that the acetabular fractures are very complex, and there is a complex 3D relationship of the various fracture components and the relationship to the articular surface in X, Y, and Z axis. So this 3D CT method was also developed. This is based on the notion that the 2D CT method underestimates the multi-directional attributes of these complex fractures. There are 3 parameters, 3 variables that you study with the 3D CT method. I will try to keep it very simple. There is a 3D step, there is a 3D gap, and this is very important and interesting. This is 3D total gap area. In step and gap, basically what you're doing is you're measuring the displacement, not only in one 2D axis, but in X, Y, and Z axis. Okay. The steps are measured again perpendicular to the articular surface, and the gaps are measured along the articular surface. Like in this view, this is a measurement of the 3D gap. You can see after restoration, there is no gap. The various fracture components are well aligned compared to this one. And then this diagram shows the concept of the 3D total gap area. Total gap area is basically a summation of all the areas of gaps and steps in the overall restoration of the articular cup. And this total area is described with the help of 3D reconstruction technique. So they also described this criteria for the 3D reduction. For the gaps, the residual displacement is less than 2 millimeter, the case is considered to be perfect. 2 to 5 for good, and more than 5 is moderate. For steps, less than 1 millimeter is perfect, 1 to 3 millimeter is good, and more than 3 millimeter is moderate. And the for total 3D gap area, if you have the 3D gap area of less than 100 millimeters square, it correlates with perfect reduction and perfect outcome. A residual gap area of 100 to 2 millimeter is moderate, is good, and more than 200 millimeters square is moderate. So these are the 4 methods that are currently available for objective scoring of your post-op radiograph after fixation. Any comments and questions?
Excellent talk. I think the main issue would be here when you're fixing both columns in, for example, a T transverse or a bicolumn, there will be metal around that area. So in a lot of times, even in an AP or in an oblique, you may not be able to see the complete rim of the source cell. And so the measurements, obviously X-ray measurements, I mean, may be difficult and may have a bias. So I guess the CT or a 3D CT approach seems more logical, and leave it to the machine to calculate the distance and the software to calculate the distance, rather than having us do it, and we can have interpersonal variations there. That would be my observation. Thank you.
That's very rightly said, sir. And also with the help of CT technique, what you can do a metal subtraction. So
exactly, that would be the main advantage. That would be the main advantage. Ian, you want to say something?
Excellent talk, Dr. Nadeem, Umair Nadeem. So I wanted to ask that the 2 mm step off and 2 mm gaps, which was initially described in the literature, I think it was overrated, right? As you said that, you know, that up to 3 mm we can go in acetabulum, right? Can you elaborate?
Sorry, I didn't get the last part of your question. Please repeat.
I want to ask that, you know, in literature previously it was mentioned that, you know, the gap should be up to 2 mm. So you say that, you know, up to 3 mm we can tolerate it is tolerable. So what is your
Dr. Hanif, you are right. Even I have read in literature in multiple papers that gaps of up to even 4 millimeter are tolerated. But what's the general notion and understanding that is that criteria are becoming more and more stringent. As the investigations and the objective assessments improve, so is the criteria. So I just told you that in Verbeek's technique, when 58 of the hips were converted to hip, only 10 were converted with the CT techniques. It means that in most of the times, all of us tend to underestimate the residual gaps and steps. So although it might be, one must set a personal criteria and personal challenge to oneself that no matter how good you fix, there is always room for improvement. And then when you achieve that improvement, the results show. I have seen in my own personal series that my results in the past 6 months are much better than they were 6 months earlier. And in those 6 months were better than the results in the previous 6 months. So I think this criteria is becoming more and more stringent and more tough with time.
Thank you.
As your experience improves, you tend to achieve better reductions.
Thank you.
Sure. Any other comments? Thank you, Dr. Umair. Excellent talk. I think next we move out from general talks about acetabular fracture into now specific fracture patterns. And I would like to invite our dear colleague from Singapore, Dr. Gavin O'Neill, to take us through anterior wall and anterior column fractures. Over to you, Dr. Gavin. Is it raining in Singapore?
It should be raining.
It's not raining at the moment now. About 2 o'clock rain. Yeah, the 2 o'clock rain. I'd just like to say thanks very much to Dr. Nadeem. As a very interesting talk, and I agree completely with his assessment at the very end when he was saying every 6 months he gets better and better. And so obviously, using these techniques are, force us to get better. But I think he just describes quite well someone who's doing lots of acetabular surgery. And to be honest, even comparing to the last time I was involved with your conference 3 years ago, I think the depth of experience that you all have really has come on significantly, and you're really everybody's experience is looking like a lot of people are way outstripping mine anyway at the moment. So it looks like Masood, your course is definitely achieving what it's supposed to do, which is great to see. So obviously you asked me to talk about anterior wall and anterior column fractures. I think if you look at the rest of the program for today, this sort of stands out to the side by itself. There's no real debate about the anterior wall and anterior column fractures. It certainly doesn't mean that we know everything about anterior wall and anterior column fractures. It just basically is because they're not very common. And in relation to this talk, it's about isolated anterior wall and anterior column fractures. So we'll run through the normal things, a bit of anatomy, radiology, mechanisms that are different from normal, a bit about the incidence and how we manage them. And so I think when you look at these two, and they've been lumped together because I think they're kind of beside each other on the classification, but they take up quite a large part of the classification when you're looking at it. They're 20% of the classification, but they actually make up a very small proportion of fractures. So the anterior columns make up only about 3 to 4% in isolation, and anterior walls maybe somewhere in and around 1%. So we'll look at these separate from everything else. I think, again, it's good for the registrars, and certainly something that took me a while when I was doing my initial training. When you look at this classification, we spend a lot of time memorizing the distinct groups of the different fracture patterns, when in reality, I think as we all get a bit more senior and more experienced, we realize that it's really just a continuum of different fractures. And even within the anterior wall and anterior column fracture patterns that are isolated, there's again another continuum of injuries within that. You can see in particular in relation to the anterior column, everybody will have a slightly different experience of what's most common in their work. I tend to find that the isolated anterior columns do tend to be higher anterior columns, and more recently tend to be in the slightly more elderly patients who have lower energy falls rather than the classic ones that are described in the literature. Again, whenever you're looking at isolated anterior column fractures, they range everything from what is borderline high pubic ramus fractures all the way through to tectal, transtectal, and in that region, and all the way up to the iliac crest, between the IIS and SAS, and all the way up next to the out above. When you look at the osteology of it, it's a bit unusual that anterior column in particular makes up the vast majority of the ilium. However, it makes up such a small proportion of isolated injuries. Now we know that the vast majority of anterior column, anterior wall injuries are associated with posterior fractures as well. But it's just quite unusual that it's so low the percentages, despite the anterior column making up such a large proportion. And again, when we look at the fractures at the top left, you're looking for small anterior wall fractures, and this would be my experience of seeing anterior wall fractures. They tend to be small. Most of them, to be honest, tend to be associated with other fractures. Most of them are minimally displaced, and I have to say I treat very few of them surgically. Similarly with anterior column, it varies on the mechanism of injury as to what the pattern is, whether it's a very low pattern all the way through to the high patterns. And I think a lot of this is really to do with the pelvic tilt. Whenever we look at a lot of the diagrammatic illustrations from the lateral view, we don't really incorporate pelvic tilt into things and direction of force. And whenever we do that, we find whether it's from a road traffic accident, a crush injury in a lorry, someone coming off a motorcycle landing on their knee, the vast majority of these forces are posterior and superiorly directed. Again, if people are falling from a height, the vast majority of these forces, the very high energy ones, are posteriorly directed. Whenever you're looking at forces that in isolation cause anterior directed forces, it's quite unusual to think of mechanisms for this. I think whenever people are osteoporotic and they fall onto their buttocks, or they maybe fall and land on an extended hip, or in particular when I was doing my fellowship in Melbourne, there was quite a few anterior wall and anterior column fractures in cyclists. It used to rain quite a lot in Melbourne, and whenever they were cycling along, their wheels would go into the tram tracks. They would flip onto their side and land directly on the lateral aspect of their hip or onto the lateral aspect of their ilium, causing an internal rotation force, which caused isolated anterior column or anterior wall fractures. So not a very common mechanism. And again, like a lot of the few of the talks this morning, there's some repetition. I think basically need to have a high index of suspicion. You know, if they have a relatively high energy mechanism of injury, they have a hip pain, even if there's only subtle or very limited changes on the x-rays. I think moving on to higher levels of imaging is very important, in particular in the young adult group. Just like we talk about marginal impaction and posterior wall fractures all the time, and the importance in prognosis and longevity of that patient's own hip restoring native congruity, it's no different really for these anterior wall and anterior column fractures. If they're associated with some marginal impaction, that needs to be identified and needs to be addressed as well. Another slight modification of these isolated injuries is whenever there's a separate or a free-floating quadrilateral surface fragment too, and similar to what was spoke about in the last talk, you can sometimes reduce the wall, reduce the column, but you need the quadrilateral surface to maintain that joint congruity, which ultimately leads to the longevity of the patient's own hip. So what's the incidence in total when they're almost always lumped together as anterior wall and anterior column fractures? The total is about 5 to 6% of all acetabular fractures, depending on what you read. And there really isn't very much out there that looks at them in isolation. About 3.5% anterior column and about 1.5% anterior wall. And in fact, whenever you tease out the information in most of these papers, they also have another subcategory of anterior column, anterior wall fractures, which make up about 10% of these injuries. It's very interesting that whenever you look at the demographics, though, you know, it's almost identical to most other fracture patterns. There's not any subgroup or other specific type of injury, and that's maybe just our lack of teasing out the mechanisms whenever we're categorizing these. So most of them are in young males, most of them are road traffic accidents, some are falls, but whenever we look at and talk about road traffic accidents, certainly where I live and have worked, you know, that can mean a whole range of things, from obviously driver, passengers, front seat, rear seat, pedestrians hit by a car, cyclists hit by a car, etc. So it's a very disparate group of mechanisms that we all lump into one. So I'm sure if we could tease that out, we would probably find there's specific mechanisms that really do have a propensity to cause these isolated anterior wall and anterior column fractures. One of the difficulties, and not particularly so much for the anterior column, but for the anterior wall, is no matter how good your x-rays are and your experience, I personally find it very difficult to sometimes see anterior wall fractures. Certainly on an AP pelvis, I find it much easier to see posterior wall fractures, as I think most people do. We're used to looking at them, but the anterior wall can just sometimes be a little bit more subtle. And even whenever we're looking at our due day views, again, you can see your anterior column very well, but the anterior wall, and certainly fractured anterior walls, can sometimes be difficult to pick up. And so I will always have a low index of suspicion or high index of suspicion and a low threshold for CT scanning these, even if it doesn't look like there's any significant fracture on the plane radiographs. And as I said already, I do this quite often for my elderly patients who do have lower energy trauma. And quite often you will pick up some of these injuries. Inevitably, they tend to be treated conservatively or with very limited fixation. So again, your CT scans, really making sure you have classified it correctly, looking for your marginal impaction, as we've discussed, and any unresolved or unrecognized subluxation of the head, no matter how subtle, secondary to your marginal impaction. That may significantly change the approach that you take to managing the patient. Again, these are the sort of classic ones that you'll see. You know, if you look at this as a 35-year-old gentleman, he had a large weight, I think it was about 160 kgs, fell in between his legs. You can see he's got a high pubic ramus on the left side, and then he's got an anterior column on the right side. And I think sometimes it can be a little bit subtle and difficult to distinguish between from a what we call, you know, a high pubic ramus fracture and then proper intra-articular displaced anterior column. You can see quite clearly on the right hip that his whole quadrilateral surface, his teardrop, has displaced medially, and actually there was quite a significant proportion of the joint surface that was displaced and unstable because he had bilateral anterior injuries. These are relatively straightforward to treat. It wasn't comminuted. Again, you can see it keys in very nicely. You can use either an ilioinguinal approach for direct visualization above it, lag screw fixation or neutralization, or a simple buttress plate through the same approach, or a stop approach, whatever is your approach of preference. When it comes to slightly more complicated comminuted fractures, such as the one on the top left, you know, a combination of open and percutaneous is often required to align the iliac crest to ensure the joint surface is restored, possibly some peripheral screws, some AIIS screws with some small plates as well. On the images on the top right, and the more simple fractures, although it's a large fragment, you can often simply use a Schanz pen in your SIS or to control the fragment. Sometimes you need to do a limited opening at the pelvic brim to debride the fracture and allow you to reduce things adequately. You can put in your peripheral screws and then your main fixation through your AIIS to your PIIS for your supraacetabular fixation. So who to treat is very interesting, especially in relation to the last talk where people were debating where the limit is about displacement. Whenever you read the series, and these are the largest one, only has about 30 odd patients in it with a relatively short follow-up, they actually accepted up to about 5 millimeters of displacement, both for anterior column and anterior wall fractures. If there was marginal impaction, they had a very low threshold for operating on them. They talked quite a lot about the relative indications, and in people who have these injuries in particular, if they have got other polytraumatized, if they're a polytrauma patient and they've got other injuries either in the same limb or in the other limb or upper limbs, and they need some help to allow them to transfer and mobilize early, then that would be a relative indication for doing that. Again, just like in the last talk, we really want to anatomically restore joint congruity to allow early mobilization and anatomic reconstruction of the joint. And the papers really show that of those that were treated surgically, they had to open about 75% of them, where they were able to do closed reduction and percutaneous treatment in about 25%. And that paper is about 10 years old now. So it may well be that that has shifted a little bit as well, just with new techniques and new imaging modalities that we have, in particular CT guided. So approach to fixation, you know, I think we've been listening to things about the approaches all the time over the last few days, and we'll hear a lot more over the rest of today. Ilioinguinal will definitely be your workhorse approach for this. If they're very simple and non-comminuted fractures, modified stoppers can sometimes be used, but you have very limited ability to direct your screws in the anterior acetabular region. People have used the others, but we don't, as we've discussed already, won't be using those very much. In terms of percutaneous, I do it reasonably often myself. It's okay using the 2D navigation, three-dimensional navigation. I have some colleagues who use that now, and it's incredibly good for very small fractures that you need very precise positioning of the screws, but you need very high-end equipment to allow you to do that. I'm not going to go through the whole approach. I'm really just going to talk about, you know, the middle window, and in particular for the registrars, the key when you're dealing with these injuries is looking at the middle window and looking for your iliopectoneal fascia. It really is sort of the landmark of where you'll find your fracture fragments, and it'll take you right down to the point at the anterior aspect of the joint where you can reduce things anatomically, provisionally hold them, and then do your definitive fixation. And so really just releasing your iliopectoneal fascia takes you right onto the exact area that you want to be on. you can visualize everything that you need to. There's one more paper. These are a few images just taken from another paper. I think people do also, we all like operating and we like being very proactive in trying to keep up with the Joneses, doing all of the percutaneous things. But this actually was taken from one of the recent papers that was published, and they were talking about fixing these types of anterior wall fractures. I personally don't do that, and I think the risks of, for a start, doing it well is very difficult through a closed technique. And the risks of causing, neurovascular injury is quite high, or even just misplacement of screws is quite high. And so they are showing images like this in the literature, but I think it's very clear to see that, they probably haven't even managed to get the screw into the fragment. So this has probably been done just off fluoroscopy, and it can be very difficult to make sure that you're getting your screw right in the right position. So I'm not sure this really is helping patients very much. However, when you look at variant patterns of this, and I think if you ask some registrars, they'll definitely think that this is some variant of a posterior fracture dislocation on the plain radiographs. However, you can see that on the CT scan, there's actually a lateral or a superior subluxation of the hip with some comminution of the lateral aspect of the joint. You can also see some impaction on the plain radiographs. And you can just about see there's a line traversing the whole way through the ileum up to the iliac rim as well. And so again, these need to be identified as being, anterior injuries and addressed appropriately with the correct approach and the correct planning for rigid fixation. So when you look at the outcomes, as I've said already, there are really very few series in the literature looking at this, especially anything that's got any longer term reviews. Most would say approximately 60 or 70% of the ones that they've seen in their department, they treated. So about a third don't need to be treated, and had relatively good outcomes, pretty much comparable with all other types of acetabular fractures. So radiological and clinical outcomes were good to excellent, about 75 to 78%, I think it was, in the short term, with minor to moderate complications in the 20% range. So I think in summary, their isolated anterior column fractures are uncommon but important to identify. Isolated anterior wall fractures really, I think, would fall into the rare category, but again, are important to identify simply from a prognosis perspective and a rehabilitation perspective. And on a very rare occasion, you may need to fix them as well. Road traffic accident and falls still remain the main mechanism of injury. And I say personally, I have more experience of elderly patients having relatively low energy falls that sustain your isolated anterior wall or anterior column fractures. Direct lateral blows, either to the hip or to the iliac crest, also can cause these as well. So just be cognizant of the slightly different mechanisms that may cause the fractures to develop. They can easily be missed in plain radiographs and just have a high index of suspicion for them with a low threshold for CT scanning. I think displacement, the papers say up to about 5%, but I think most people would say 5 millimeters. Most people would say 3 to 4 millimeters, especially if there's no gap, no step, that's okay. Gaps of 3 to 4 millimeters, I think, are probably okay in this patient population. Obviously, whenever they become anterior column fractures that have got steps in the weight-bearing dome, that takes have to be a little bit more proactive in reducing and fixing those, just like we do for all other fracture patterns. I think I'll leave it at that. Any questions in relation to that?
Thank you, Gavin. Again, great talk, quite comprehensive. The rare injuries that we see, especially isolated anterior wall, I may have fixed only 2 up till now in the last 15 years. Anterior column, yes, but isolated anterior wall are, I think, even rare. And as you said, the mechanism of injury is also rare. Not many people do biking around here in Pakistan. So unlike Singapore or Australia, but most of these are motor vehicle accidents resulting in a posterior side dominant injury. So any comments from anybody? Any questions? Any ideas? So thank you, Gavin. We'll just hold you on. I think you have one more talk in about some time. We will have a small change in the schedule. Dr. Ramesh has to leave, so we will bring him in the front now. He will take us through his approaches to posterior wall and column fractures, and we'll have some nice cases to learn from him. So over to you, Dr. Ramesh, and again, apologies for not giving you complete time yesterday. We were quite pressed for time, so I think you have time today. Please go ahead, take as much time as you want. Thank you.
Thank you. Thank you. Thanks a lot, Dr. Masood. I'm really indebted for the amount of time you have already given to me. And eventually, because today also, as we are getting late, I have got another commitments which are just standing around. So I'll try to comprise everything into this talk as such. So talking about how I look at these fractures here in this situation, as said about it, that we are in a situation when we have a posterior wall and a posterior column fracture, either in isolation or both of them can be combined together. Now, it's very interesting to see that why do we have these injuries as most common injuries? We need to understand the mechanism of a ligaments around the hip joint, where the hip is ligament, the capsule is stretched when we are standing, the capsule is fit, but the time when we sit, all the ligaments relatively get relaxed and hip has a tendency to subluxate a bit. And this is ability to subluxate at that point due to that laxity of the ligament makes it vulnerable to get dislocated. And during that dislocation, there is enough impact over the wall also and the column also that can share the load of the impact and get fractured along with a dislocation pattern. And this is very often as a dashboard injury, whether you're in a front seat or in a back seat. This is something when your hip is flexed to 90 degrees and where all this problem can happen in this situation. Now, the amount of flexion on the hip joint will determine the kind of a fracture pattern we are likely to have. More is the flexion, more is likely to be the kind of a down is likely to be the situation of a fracture location in that area. Less we are likely to get involved. So we have to appreciate one thing, that this is a pattern which is associated with the dislocation, and that creates a kind of an emergency that hip needs to be reduced early so that we can facilitate where these things. So now, understanding this reduction, there is an example I can just, it could be a very simple case that you flex and it dislocates. So you do not have to think much about this case, the quality of it. But if you go for the other situation, now this is the another situation where you are trying to check it, whether it is okay or not. And there it could be deceptive. Just you have a look. Now suddenly you get that kind of a jerk also. So these are the kind of situations which can develop in this kind of a situation where you need to see it over. Another issue we see is that sometimes we have got small fragment in the joint. Now, whether this small fragment needs to be taken out after the dislocation or need not to be taken out will depend upon, that's the way we look at it, how big or small this fragment is, whether it is making the hip incongruent, as Dr. Nadi was talking about the various lines, the kind of a congruency which is important, is that altered or not? Because these are the two situations. The fragment could be very small and it doesn't affect the congruency lying in the fovea, or the fragment could be a little bigger, which makes the hip, which is actually in the weight bearing area, makes the hip incongruent. And that is a situation where you will have to get in, have to remove as a part of this thing. Now, depending upon whether you have got a arthroscopy available or not for this thing, and depending upon the size, you can intervene in this kind of a situation. Now, when we look at the posterior wall, it could be a small single fragment, it could be comminuted fragment, or it could be having an impaction along with it. And likewise, Depending upon it is a pure wall, it goes down to the column, and it is a combination of the column and the wall. And the classical approach we always talk about is given by these two gentlemen, and all we have already talked about it. And this is a standard approach in the day of today for these standard fractures, whether this is wall or whether this is column. There is always a perception whether I have to do in a lateral position or I have to do a prone position. Now we have got a variety. Either we are talking about wall or we are talking about a column. And we are talking about. So my own perception is that when it is a column fracture, when the gravity is likely to counter me, or when it is a transverse fracture where I have need a good imaging for going to anterior column reduction and fixation, I want to have it in a prone position. But when there is an associated dislocation which is still present, requires manipulation for reduction, obviously it's very difficult to do in a prone position. Or whenever there is a trochanteric flip required, as we had just discussion before, and also that whenever there is a femur head fracture where the fragments, some of the acetabular fragments have been dragged into the joint and we have to remove them out, or a superior dome is there, we might prefer the lateral position, which permits the trochanteric flip also, and we can have a reasonable amount of access in this area. So for posterior wall fractures, I try to be with the lateral position, while for the column fracture, I try to be in a prone position. This is a study of transverse fracture. However, they have not found much of the difference in the morbidities between the two groups, whether you do a lateral position or a prone position. But personally, I feel for columns, the prone position is better. Now, there is a very standard dissection which we go through it. Standard, we have to take care of the vascularity, and so our incision to the muscle. Then, as we go inside, we have to take care of the capsular attachment of the fragments and the muscle attachment. Now, it's very important. While KL can be okay, but now if this is the situation and the fragment is superior, going purely by the KL approach might hinder us from reaching up to that fragment which is superior, and this is the kind of the complication we will get if our access is not complete, and which can eventually lead to a head destruction also. So we have to be careful about it, and that is the reason we use trochanteric flip in this kind of a situation. The other modification sometimes we do when we do not want to, when we just want to go to the superior side only, we use a modified Gibson approach where we go take away whole of the gluteus maximus posteriorly from its attachment over there with the straight incision, and from there we tend to reflect it back and we get a good area where we don't have a proximal restriction of access as we have got in a KL approach, and that way we can have a reasonable access. And in this also, if we want to go anteriorly, we can do a flip osteotomy and reach anteriorly to the level we need to go in for. So this is one of the variations we may be able to have it. Going anteriorly, we may be able to get a better of that area. Now, next things comes fracture reduction. Yes, this pin into the greater trochanter is a help. I do use it oftenly. Sometime in old cases, we have used this kind of a distractor also, but most often we don't use it, we don't need it in acute case. Now about the standard posterior wall fractures, we understand the images of iliac view and obturator view, how good they are likely to show, and the CT scan as picture. So at that stage, depending upon whether the fragment is single fragment, comminuted fragment, or marginally impacted fragment, or it is, we need to define it out. As I said earlier, our care to the attachment of these fragments have to be very, very carefully done. We need to orientate all the fragments to the orientation of the head, and by using ball spike. Question comes, are single screws sufficient to hold this fragment? Yes. I have rarely used, but this is one of the cases where I had used a single screw without a plate. My perception at that stage was that it was a big one fragment from proximally to distally, and I could put screw into 3 different directions. But this is usually not a picture, and this is not the ideal way to hold it. We have to go to a buttress this fixation with the plate, and that is a standard which we do in all our cases. Now there is a issue that passing a screw in that area in between is sometimes difficult through these holes, because there is enough danger that we might get into the joint. So my trick from last 15-20 years have been to get into the notch of the plate and to pass a screw relatively obliquely, so that we don't have any chance of getting into the joint. The trick which I use at some time at this place is I pass a K-wire in through the intact capsule into the joint, and this gives me the direction that I have either to be parallel to it or obtuse to it, so that I don't get into the joint in this kind of a situation. So that is my trick which I have been using for quite a long time in this area. Now, as I said, we have to be careful about getting the fragments there, getting them reduced there, and then to take about the positioning of the wall, the amount of comminution to put a one plate or to put two plates, because we are very near to the joint. So as a protocol, our perception is that we must, after the fixation, before closure, to have this view, so that we define that none of screw is entering into the joint. And simple trick we use is that we keep a screwdriver in the screw which is to be mentioned, because now it is giving us a direction, and orientate the CRM in line with it. And when we have to take a snap, we take this screw out, and we get a beautiful image for the screw we are looking for. And this way, we can know that whether any of our screw is getting into the joint or not getting into the joint. Now the question is about impaction. Yes, this is a situation where we have to be very careful, and there is a beautiful description that when the wall fragment is bigger, you don't get impaction. When the wall fragment is small, you are likely to get impaction. Just like here, wall fragment is bigger, so it is pushed out and it is pulled in when the hip is reduced. But when it has dislocated with a small wall fragment, and then while getting back, this presses over this very fragment and causing this impaction, which when we are looking from this side faces us only. And that is what is important now to reduce this impaction in this area. And definitely that requires specific steps. Now it's very important when we are taking this fragment back over to the head, we go into the tissue, because there could be a compression here, but we have to take enough of the bony tissue along with it, and thereafter to fill the graft into this area so that we can pack it up. Because if this is very, very thin, it is difficult to hold in that position. And then if there are unstable, bigger fragment, we can use a so-called lost K-wire technique, or a small screws also to hold that fragment. This is a miscellaneous lost K-wire technique, that you put a K-wire, it is a threaded K-wire, and we cut rest of it and subsequently put rest of the positive wall fragments over it, and that way you can hold the small fragment and subsequently manage it. And when we have got a comminution, we all understand there is a good advice of using a kind of these plates over this, and this is a standard AO direction to use a spring plate. Yes, this can bite. Personally, I have been using this Alice plate over here. My perception was that there is a lot of comminution, so I do not want to put 2 or 3 plates, because any plate is likely to get more devascularity. So I was just putting one plate, and its arm, this thing was allowing more purchase into this area. And once I have done it, then I used to put a plate over that. So this gives to give a better fixation with this Alice plate kind of a thing. And this is the image which you can see that I am able to reduce the rest of the things. Now, this is another case of a wall fracture where you can see the outcome of this case. Now, it's very important to point out one thing. Dr. Umair Nadeem has shown beautiful description of radiological assessment of these joints. Now, a typical problem with the posterior wall is, rather, they are easiest to assess for a reduction on the table for the quality of reduction we have achieved. Technically, they are the most common, they are the easiest, but as per the literature, the outcome in spite of a good reduction are worse in them, because it is not always the bony problem which brings the degeneration. Many cases, it is the badly injured cartilage also in that area, whether it is towards the femur head side or towards the acetabular fragment size, the cartilage is bad. That is also likely to manifest subsequently in the degeneration in this kind of a situation. So we have to keep on observing these patients for that period of time where the degeneration is likely to see. And there is one thing which is said to be that if after a year or so, or after 2 years, you want to assess the long-term outcome, just like what we do in a knee joint also, for the hip joint also, you can take a weight-bearing X-ray of the hip joint and assess the difference in the joint space on the either side. And if it's more than a centimeter difference, we are probably looking for the early changes of degeneration coming into that hip. Now, another question comes, if this injury is presenting late, which is not uncommon in our scenarios, because the patient reaching the hospital to a center where it will be done might be missed by a coax or by a place where it is not done for many reasons. The question comes whether I should do or not. Yes, posterior wall fracture and posterior column fractures, if they do have a sizable kind of a bone available with their articular surface, delay does not matter to an extent. Let's say a month delay, 6 weeks delay, 2 months delay. And technically speaking, let me tell you, last year we operated a case which was 1 year delay also. And we could get a good outcome in this kind of a situation also. So it is the quality of the bone which is left out when we say it is reducible, or so I always label it the reducibility of the situation, the reconstruction ability of the situation. Now, this was a 6 weeks old injury, did this reduction, and you can see his 11 years follow-up. He's still able to have all his activities maintained as long a period after that delay. Now, talking about column fractures, yes, now a significant amount of impact has been sustained with the medially injured column. Now, the extra thing which comes here, and rather more important, is due to this column fractures over there, whether it is a transverse pattern or pure posterior column, there is a problem of this rotation which can happen in this column. Now, this rotation now needs reallocation of the rotational component. So you need a pin over here, Shan's pin into the ischium to derotate it. Till we do not derotate it, it cannot be reduced appropriately. We may, in addition, use a hook for pulling it up using Shan's pin. So we create 2 holes over that posterior column to get it back into its position. And once we have been able to get both these together, we can use this kind of a situation, a screw up and screw down, and can use one of these clamps to get that reduction. Once we achieve that reduction, thereafter we can put a plate over that to maintain that reduction. Now, next, because we are dealing with the column, there could be associated wall also. So most often column is less comminuted, wall is more comminuted. It is very uncommon. I have very few cases where wall was less comminuted and column was more comminuted, where I had to reduce the wall because the column was not reconstructable. There were so many small fragments, but it is a rarity in comparison to what we mostly see, that column is less comminuted, or there is just 1 fracture line or 2 fracture line and wall is. And in all those cases, we need to reduce the column first and thereafter to go over to the plate fixation of the wall. And this is here, you can see it out. The column is reduced and thereafter the plate, this wall is to be reduced, and this way we can go for the subsequent wall fixation in this situation. And this is the classical example. You can see a posterior wall column fracture displaced and fixed subsequently by the plates over there. Now, when the combination is there, so our reconstruction is a very, very standard reconstruction in this kind of a situation with the follow-up. You can see it over there, and these are the classical. Now, an important issue comes that if there is a sciatic nerve involvement. So the protocol with me is that whenever I get a patient with a posterior wall injury, always look for the sciatic involvement and document that, because this documentation sometimes can save us from a bigger legal issue if we have missed documenting it beforehand. Because some of these cases, the literature says 33% of cases will never recover 33% will partially recover, and only 33% might fully recover. So this is a situation where our documentation is very important. Now question comes that this was a case where dislocation was reduced, but sciatic was present. Now whether to go in or not. Now once the sciatic was not showing the kind of a recovery at a time, 4 weeks, 6 weeks, now you cannot expect more. So what I did, I just went in, and this was the CT scan picture, and sciatic was actually entrapped in this piece, the sharp edge over here. And so I had to take this sharp edge out, reduce this fragment back, and then I could place, and eventually that patient appeared. This is another patient. Another situation comes to us. This patient came to me after about a year of the sciatic nerve injury, after another hip dislocation, which has been reduced closely, and femur has been fixed, obviously. Now the question comes, should I again explore it or not? We all know that sciatic nerve injury takes time to recover, if it has to recover. But if it has not recovered till 1 year, you're always in plus minus. You consult the patient, counsel the patient, and in this case, eventually he said, I want it to be explored. I don't want to take a chance. And when I opened it up, yes, there was a lot of conduce, there was a lot of fibrosis. I just did neurolysis, and in the subsequent time, he actually improved. I don't know whether it was the natural recovery which was otherwise happening, or my decompression at that stage helped. But I think this is one area where we have to make a careful decision in this situation. Another issue is about DVT. In our Asian perspective, it has often been talked about that DVT is not an issue in Asian population. And this problem of giving this thing is taken, but we have enough now evaluated it and published it that the incidence is as common as in a Western population. We studied about 52 cases of these acetabular injuries and evaluated them by CT angiography at 7th day, and then subsequently followed for 6 weeks, 8 weeks, and by duplex ultrasound and other this thing. What we found on the 7th day, because as a protocol, we were not giving them any chemical prophylaxis, we were giving them the physical prophylaxis, but 10 out of the 52 cases had silent pulmonary embolism findings. It is not because that we can actually prevent all of them, but having that incidence. Now what happens to this 10 cases, 11 cases? The literature is clear that 1 out of those 10 cases we would be losing in the due course of rehabilitation. And that is the danger. I remember to have lost a patient at 4 weeks in that period when we were not giving prophylaxis. We know that prophylaxis may not 100% prevent it also, but this is important. And I have further found it out that in patients where we had a cocker leg and back approach, the incidence was a little higher, because if we are operating these cases in a lateral position, now the veins in the hip are already involved, injured due to the dislocation time, and then patient is placed in that position for that period of surgery, the chances of sluggishness of blood flow is higher, and probably that is the reason we got more chances getting it over there. And there could be cases where the time when patient reaches you, already there has been these findings of embolism over there, and now you have to take extra care to put a filter and then to operate upon these cases, because you need to have them settle down and then to have a patient who is comfortable afterwards. Another, because we are operating these cases for dislocation purpose, reducing this dislocation, that it is the AVN or avascular necrosis as a problem. Now, in this situation, if we are looking that it is surgery, surgery is not the primary factor which causes AVN, it is the dislocation. There is always a query whether a pure dislocation gives more chance of AVN or a fracture dislocation. Yes, we understand if it's a pure dislocation, the hip is likely to be rotated much more medially, likely to stretch out our vessels which are going from to front to back, and cause more time of ischemia as compared to a fracture dislocation, where the internal rotation may not be that much, the stretch over the vessel may not be that much. So it's important to perceive that the dislocation, pure dislocation, leads to more chances of avascularity. And now the question comes, is 6 hours or 12 hours? Our perception has been that we have studied these cases also. We find in our population 12 hours have been the proper timing when the chances have increased for the AVN as compared to 6 hours. I mean, but it's my own personal these things. When we were not looking for AVN, we were looking them when these come. This was one of those cases operated by one of my boys who did it the reduction, put up these screws because he found the hip was stable. But this case got some changes, and we got nuclear scan done. We did nuclear scan, and then we found the nuclear scan showed positivity. We thought that these metal screws will not allow MRI. Eventually, we used, at that stage, started using titanium plates and titanium screws also to get an MRI done. But in this case, we did nuclear scan, and once it was there, we did a core decompression. And after that surgery of core decompression also, whether that hip returned to normal and he's having his routine ability. So the issue is that we should be timely evaluating it. Now, there is a question, how early AVN can develop in after a dislocation or a fracture dislocation. There is a series in the literature which says that this happens there, but we also studied and published our paper where on the table, whenever we were operating upon neglected cases, we did the aspiration from the area of the superior dome and from the central area, compared the aspirate. And what we found, if we use a 50 cc syringe with a 18 gauge needle and give that negative pressure of 50 cc for 1 minute, the amount of aspirate we get, if it is more than 1 cc, it is a viable head. If it is less than 1 cc, it is likely to be a non-viable head. Because we evaluated this as a part of a research project and then evaluated these patients for 6 months to find it out eventually by a regular MRI, whether they have got it or not. And that is what we published way back in 2010. Then if we know that it is likely to go for AVN, what we can do? Now we were working on the so-called autologous bone marrow concentrates on these cases also. So we were using these cases also, and that is what we have published also in Journal of Arthroplasty, that whenever you start looking at now our recommendation is that after 3 months of this fracture dislocation, we must get MRI. Now, MRI changes will be seen at 1 month also, 2 months also, but there are non-specific changes which eventually settle down after 3 months. And at 3 months, we are very clear whether it is a AVN or it is not going to be AVN. And if it's going to be AVN, we try to put this kind of bone marrow aspirate after drilling, though the etiology is different. It is acute ischemia as compared to a non-traumatic AVN. Then we studied another thing. How is the outcome of AVN after the trauma of dislocation? I'm not talking about fracture neck femur, trauma of dislocation vis-a-vis non-traumatic AVN. And what we have published is that while in a non-traumatic dislocation, in an early diagnosis, we can anticipate and deal with and manage, get a good outcome in 70 to 80% of the cases in a stage 1. In traumatic AVN, this success rate is not more than 50%. So because the primary type of etiology is different, the outcome is also different. Our positive outcome after this kind of a installation and core decompression in traumatic AVN is not very high. And that is what we need to counsel the patient at the time of injury also. Here there is a case, you can see these cases have actually recovered in that. And this is what I have published subsequently. Anyway, another issue which we have to be wondering about is the heterotopic ossification. Now, this is a patient which was operated, he was operated in Italy probably, and he came with a big ossified bone in the backside. And now this was restricting his ability, his hip was stiff. So we just went in, took out all that, this thing, gave him radiation, and he was, I forgot to show that slide where he was completely comfortable after the surgery. Here is one of my own operated case, which also developed a heterotopic ossification, but she did not have that level of a disability in sitting, squatting, and walking. So in spite of a big shadow seen over there, we did not operate upon here. So we know the grading that, and what is important remains when the patient needs it. So we only operate when the patient needs it. Here in this case, it was not needed. So our protocol has been that all those cases where we have got the kind of a situation, head injuries there, massive lacerations are there, repeated manipulations are there, we tend to give them kind of this is this same thing which I have shown earlier also, that inadequate fixation can give us this problem. Anyway, the other problem could be sometime idiopathic kind of a osteolysis, where your first reduction seems to be okay, subsequent seems to be okay, but head gradually disappears in spite of a good acetabulum also. Now there are various perceptions about it. Some say it is an implant which is within the joint which causes it. Some say it is a kind of a low infection for some reasons, but it is very typical. It's not a common thing. 1 in 1,000 cases. I had just I think 2 or 3 cases with me where we could not get the cause of these slices and they had totally disappeared in this kind of a situation. We have seen that when we see the outcomes of these cases, this posterior column fracture and posterior wall fracture make us the poorest outcome. And within that, then further we have evaluated them, that what is the single most important factor. And this graph will show, this is what we have published also, that maximum amount of importance must be given to the delay. 10 days, 14 days is the maximum limit. If we are getting more delay, this is likely to affect our outcomes. And that is what we have published regarding predictors of the outcome, and subsequently in using the WHO quality of life score, that the most important issue is the delay, which is not uncommon in our part of the world. So my carry home message is that these wall fracture and column fracture can be simple, can be comminuted, and depending upon, we need to define which approach we use, where we are comfortable with, whether we stay with KL approach, we use a Gibson, we use a flip osteotomy. And I'm sure we are all with Dr. what Umair told, that it is the reduction quality which is likely to help us in knowing the outcomes also. Though, as I said earlier also, posterior wall fractures are most common, relatively easier to reduce and stabilize, and still the outcome may vary due to other factors also. And there could be the fragments in the joint which could be small, neglected, or not cleaned out, could give that kind of an issue. Thank you.
Dr. Mesh, excellent overview of these very common injuries, and as you said, sometimes mistreated, maltreated. A lot of the general orthopedic surgeons tend to operate on posterior wall, sometimes column injuries, and that is another reason for a poor outcome at the end of the day. They think we can manage, we can handle, although these, as you have mentioned, are very specialized injuries, need special understanding of the injury pattern, of the classification, as you have already mentioned. Actually, you have covered my debate, which was supposed to happen before your talk, on the classification of posterior wall and column, and then whether to use screws only and whether to use a single plate versus a double plate. Anyhow, we'll go through them. But obviously, you've covered the merits of each and everything. There was a time when I also perhaps fixed my first or second posterior wall fracture with screws only, and had no idea how to bend the plate. So I thought this is stable enough, and we would just put him supine and don't mobilize him. So I think that's not the case in today's world. We have to have very strong fixation with a buttress plate, at least one in case of a posterior wall fracture, and mobilize them very early. The case of double plate, I think if it's, as you have alluded to, in case of a combination of wall and column, a double plate has a strong merit and should be used along with lag screws. So 3 fixation levels: lag screws, single buttress plate for wall, and a neutralization plate for a column. And sometimes you can have lag screws for the column also additionally, as you have mentioned. So lag screws for the wall as well as the column if possible. So any comments, queries from the group? Very comprehensive discussion. Also touching on DVT and heterotropic ossification problems, which sometimes we encounter in late fixation patients and are very difficult to manage. By the way, just to add, my patient, one patient had first recovery from his sciatic nerve injury after 4 years.
Okay.
So this is how late. This is. I was also surprised. I told him, "You're not going to get it back. I think it is 2 years, 1 year, 2 years, 3 years." And then in the 4th year, he started having toe motion, and so it was a T-type, presented late with head injury. He had sciatic nerve injury after the accident, and when we operated, it was structurally intact. So we were waiting. I don't know what is the experience of other people, but I think you very nicely touched on this issue of nerve problems, obviously very common with wall and column fractures. Dr. Dixon, who never sleeps, has made a comment. Posterior wall, but the worst outcomes with Latourner, I believe it is reduction of posterior column is the main factor. So Latourner, the father figure, Dr. Dixon is quoting him, absolutely true. Reduction has to be perfect, and then fixation has to be strong enough to bear mobilization. Any time you would still use traction postoperatively, Dr. Sen?
No, I don't think that the last 20 years we have ever used traction after the surgery. Actually, the patients become so comfortable after this posterior column fracture. I remember one of the patient, actually, when I went next morning in the round, he was walking around. I mean, it was this thing, we had to really tell him that this has not been stabilized to that extent that you can put full weight bearing on the day one also. But definitely all the patients who understands it, they're all ambulatory, second day, third day, fourth day, non-weight bearing. My personal perception is that for 6 weeks, I don't allow them ground touching, because the difference between a touching and putting weight is sometimes not understood by the patient. To an intelligent patient, you can always tell. My second is that at 6 weeks, they must be sitting cross-legged. What we have seen that if you don't ask them to sit cross-legged, they're apprehensive about it. And eventually they never get the hip range of movements. And this restricted range of movement will eventually be affected in one of the degeneration they can develop. So I personally make it ensure, because our patients, some are very, very apprehensive about understanding this injury. So they don't have that level of rehabilitation perception also. So you have to enforce that they are having full cross leg sitting at 6 weeks, all of them. You can put them on a ground touching right from the start also, but understanding patient to patient's perception is also very important in giving that advice.
You said, you used the word, I think, lost K-wire. Is that, am I correct? So lost K-wire, obviously, when you are doing a disimpacting a wall, my colleague, Dr. Naveed, and myself have used very small Herbert screws now. In a couple of cases, 2 millimeter and 1.5 millimeter Herbert screws, which are cannulated also. So very small K-wire, and then you pass the screw over a bone graft or through the fragment if it is thick enough. And Dr. Naveed may be able to show a couple of cases if we have time at the end of the day. Okay, we have some comments. Dr. Hanif, go ahead.
Yes, sir. Very nice talk, Prof. So my question is that you are recommending, I think, MR after 3 months of the posterior fracture dislocation to see the avian. So how sensitive it would be in despite of having the metal inside?
Yes. Now, because this was my project 20 years back, I had worked a lot on these post-traumatic avian and the avian per se. There are MRI machines which show a lot of metal in this area. And at that time, if I don't know whether it was in Pakistan, in 1999 and 2000, we started getting titanium implants from the Synthes company at that stage, because we were apprehending that MRI is likely to give us a problem. But now the MRI machines have developed so good. And our technology has become so better that in spite of, because I do a lot of femur head fractures also, where I wanted this to be done, and the femur head has got the metal screws also, still the MRI machines are able to show us about the avascular changes within the head. Maybe one machine may not show, the other machine might show, but there are good possibilities that MRI can depict us the avascularity. And this is my protocol. And this we have published accordingly by looking at about 25 cases for a 6 months period by regular MRI at first month, third month, 6 month, like that. So we have found it out that there are some changes which are there on the first month also, second, but they disappear. The third month changes after the 12 weeks, they persist. And these are, we take it up that these are the changes which eventually are correlated to the AVN subsequently.
How about the doing a bone scan? Do you think it's not better to evaluate?
The problem with the bone scan is that the segment which is affecting it is at a very early stage. You may be, I told you some of the cases I was using now. Now let me tell you further. We have published one of the first paper on using 18 fluoride PET scan, PET CT scan for this AVN only, and that is equally sensitive to MRI. We have published subsequent papers also of these things, but that is the level of sensitivity which we get by 18 fluoride PET CT, not by the standard nuclear medicine scan.
Okay, only last question. What is your protocol for DVT? What do you give on first post-op day, and how long do you give?
Yeah, as soon as the patient is with us, either we are operating him if he is fit enough and thereafter start, but if there is likely to be a delay for some other reasons, and if it is safer to give, we give them heparin, so that as early as patient is fit, we can take it off and put him on the surgery. After the surgery, within 24 hours, the patient starts getting it and injectables till about 12 days or 14 days. Thereafter, we have been giving the oral ones for next 2 weeks or 3 weeks till they are properly mobilized. Once they get full mobilities, then they are off. We have been using in relatively less cases aspirin also, though we know that aspirin is something which satisfied us, and maybe it might satisfy the professional this thing also, but working in a corporate sector, it is essential for us to give this protocol in the way they have told us.
Thank you.
You have your hand raised also. Go ahead.
Oh, okay, sorry. Thanks.
Dr. Umair.
Nice, wonderful talk. I've had experience with fixing the posterior wall up to 3 to 4 months after the injury. You said very rightly that if the cartilage is intact and you fix it, you can also get very good results. And it has been so in my experience as well. What is the role of capsule? I think in fixing the posterior wall, the early surgeons, they don't realize the importance of capsule, that how much it is important for the vascular supply of the fractured fragment. So if the capsule is intact and the blood supply is intact, I think one must fix the posterior wall, even if it is a delayed presentation, because even when we go for THR, if you don't fix the posterior wall, you have a very large segmental posterior deficit. Then you have to go for KGs, acetabular augmentation or oversized cup. So even if the patient develops arthritis, AVN, I think there's a rationale for fixing posterior wall because it makes the future THR easy and a primary cup can be used. And the second comment is that you presented a very good technique of lost KY technique. I like the word. There are also biodegradable pegs available for this, which you can use.
Yeah, let me start from your last thing. I had used these biodegradables also because we were having some Danish company which was providing us. What happened was they had screws also, they had plates also, and they had polypins. So polypins were from Synthesis company also, but somehow these are not available. Now I think Arthres company is providing some of these things. The problem was that whenever these biodegradable were in touch with the synovial fluid, they used to have a lot of fluid generation into that area. So if they are exposed to a synovial area, so thereafter we stopped using those things. Now going back to lost K wire, I mean, that is something which is now in the literature also. It is not something, it is that is my idea. It is already there in the literature. Regarding the delay, now it's, I use the word called reconstructability. And this reconstructability, I look for the size of the fragment and its articular surface. If I feel I can relocate it to a stable position, and the hip joint, another thing which I have seen is that if hip is mobile in a dislocated position, the outcome subsequently is very good. But if hip is stiff in this dislocated position, the outcome is bad. And the second thing, I don't know whether Kyle Dixon remembers, we had this discussion in Karachi last time, probably 4 years back or 5 years back when we were together in Karachi, that why you are using the inferior, why you're cutting the inferior capsule in those neglected dislocation cases. And I think whether he remembers or not, I told in dislocation cases, because hip has gone proximally, the inferior capsule is contracted a lot. Until you don't release that inferior capsule, you have to pull it down. And in that situation, I am not talking about superior capsule, posterior capsule, inferior capsule must be cut at that place so that hip is pulled down. Now regarding the superior side, that capsule is vital. And the surgery, the quality of surgery lies in keeping that vascular attachment to those very fragments, because we are not only talking about avascularity of the femur head, we are talking about avascularity of the acetabular fragments also. Otherwise, these fragments are sometimes absorbed and only plate remains over supporting that area. Now I have an experience about 280 post-acetabular THRs, and I have seen the benefits of previous surgery and having a lot of neglected fractures also, the problem of reconstructability in those surgeries also. And incidentally, I do have some cases for discussion, but I don't think I'll have now time left for me to be here with you for the subsequent discussion time, because I have lot many appointments, 3 more meetings to go in for. So I may not be able
thoughts
to
on
go.
delayed THR reconstructions of acetabular fracture.
Yes. So in those delayed THR, the problems are that you have to reconstruct it. Now I do have a case here also where only the posterior column was there and it is displaced medially also. So you have to create column also, you have to create a wall also, only then your cup is likely to fit. And the boy is 18 years old, where you want to do something. And so these are the cases which pose a significant amount of problem if the primary reduction has not been done. So I personally feel, because it is easier to do out of all the acetabulum surgery, we must be able to attempt good reduction and stability to the posterior column and wall, so that our subsequent management, even if it gets complication, is still to the better line of management.
Dr. Naveed, you have your hand raised. Please go ahead.
Yeah, I mean, sorry, just I just wanted to comment for trainees. I mean, when we are talking about repeatedly, it's not just for posterior wall or column. When we talk about timing or surgery related with the poor outcome, so it is actually, it's a direct relation of your ability to reduce. So maybe posterior wall or column or any acetabular fracture, in the original studies by Mata and I think Mayer's study, they have correlated their ability to reduce with the timing. As the time passes, they are not able to achieve a good reduction, and that's obviously reflected with the outcome. So you have a poor outcome if you're not able to reduce it well. So that's how the timing is reflected with the poor outcome.
Point taken. So Dr. Kyle has commented that we must leave the capsule to posterior wall for blood supply, but also repair the labrum as well. That brings us into a new domain. Dr. Sen, your comments on labrum.
Yes, we have done some kind of a labrum fixations also. Whenever this happens when the fragment wall is very small fragment, and it's primarily a dislocation with the labrum avulsing out or with a small fragment. So we have done the labral fixation in those cases, and Dr. Kyle is that's a very right perspective. We must respect that area and we must put it back. Rather, I had a slide to show, but I forgot to put up that slide over here. Yeah, that's very important area.
So Dr. Ramesh, are you proceeding to your cases or?
I think I'll be late for my next meeting. So, and I have to subsequently travel around a lot. Today I have 7-hour journey and then 2 more meetings in the evening also. So probably I will be late everywhere. So I'm sorry, but
you're proving younger than Dr. Kyle. You also seem not to sleep and work a lot on Sundays.
No. Incidentally, this
Anyhow.
year I am the president-elect for Indian Orthopedic Association. I'll be taking over as a president in December this year. So lot many meetings are right now going over. Yeah, so that's my perspective.
Before you leave, Dr. Sen, we can have a group photo.
Please, if it's possible, I'll be very happy.
Dr. Kyle, I know you are awake. If every panelist can put on their cameras, we can have a group photo before our colleague Dr. Sen leaves. Dr. Sen, thank you very much for your contribution. I wish we could we had more time for interaction with you, and I wish we could have some physical meetings also. That would be more interactive. We can, because time there, we can sit off in off hours and also discuss key issues. Can all the panelists please put on their cameras so that we take a group picture? Sharif, Chimsi, can you do that?
Dr. Intikhab had given me the opportunity to be with him at some time back, and I'm very happy to see Dr. Umair, this Umair's work also. It is excellent. I have been seeing it quite often. It is an excellent work. I really appreciate it a lot.
Umair is our youngest faculty, I think, and most promising.
Very bright. I have been seeing him for last 2 years now. I am seeing him for last 2 or 3 years. It's fantastic work, excellent work. And so
discussions with Dr. Ramesh.
Thank you. So, okay, I am happy to see Dr. Kyle also, Dr. Intikhab also. I'm too happy to see you also. Too good. So,
Sharif, are we done? Okay, just tell us when we have to smile. Okay, Sharif says smile. Okay. Javed Saab, aap reh gaye hain. Dr. Javed, are you online? Dr. Harun, please open your video. All right. Sharif, once again. All right, thank you. So, thank you very much, Dr. Sen. Good luck to you as the new challenging job. And it was a very big effort, a lot of good contribution from your side. Thank you very much.
Thanks a lot for all the opportunity.
And we look forward to continued participation in future courses also.
Surely
हम आपको तंग करते रहेंगे.
Always welcome, always welcome. हमेशा हम इंतजार करते रहेंगे. Bye, Kyle.
All right, sir.
Bye, Dixon. Bye, Intikhab ji. Bye, Dr. Masood. Bye, Umair.
Bye-bye. Bye-bye.
Bye.
All right, let's proceed with our program. And I think a lot of it has been covered by Dr. Ramesh already. And we wanted to have some more details on posterior wall and column. So if I can just take you through my few slides on posterior wall and column, right? I think Dr. Shoaib is unable to join, but we have Hanif Saab, and then I can take up double plating, just very few slides. So I think in the interest of time, we do it very quickly. We've already learned what is a posterior wall fracture. This is shown here. A posterior wall fracture has articular surface. It's on the posterior side, appears like this somehow. There are very variable appearances, and I will show you. And as Dr. Ramesh said, they can be totally confined below the roof. We can have a postero-superior fracture. We can have a postero-inferior fracture also. And then special forms in which we can have an extended posterior wall. can have an horizontal extension of the fracture line as well as an incomplete transverse fracture along with posterior wall. So a typical posterior wall, this is how it would appear with or without a hip dislocation. This is the iliac oblique view, but more pronounced on the obturator oblique view, like a seagull sign that's traditionally mentioned. And sometimes on an AP, it may be totally, we may totally miss it unless we draw the lines very carefully, as is visible on this view on the left. But if you do proper obturator oblique, you can see the displaced and big posterior wall fragment. So be aware of this. You'd have to draw your 5 lines that I mentioned in the morning on every patient where you suspect a acetabular injury, and just getting very simple oblique views which don't cost much also. Without getting a CT scan, you have much more information now with which would change the total management plan. So we can have, as I mentioned, a singular fragment, multi-fragment comminuted posterior wall fracture without marginal impaction, and a posterior wall fracture with marginal impaction. As Dr. Ramesh said, here you have to be very careful and see that that is mostly visible in a CT scan, and the place of marginal impaction has to be ascertained and then addressed. So posterior-superior fracture, and they which have a more of a superior element, including the posterior wall, whereas we mentioned we may have to use a trochanteric flip surgery and be able to retract the abductors more adequately for better exposure and subsequent fixation. And then on the opposite side, we can have a postero-inferior fracture also. So I'm just throwing in the various pictures, X-ray depictions of these various combinations and the extended posterior fracture, right? So basically a classical posterior wall, and then you can have combinations, as I mentioned, just to recap, a superior and inferior variety, and a comminuted variety, and a variety with impaction, and then this extended posterior fracture. And posterior column, when the whole column is broken with or without the wall, that is how it would appear on the AP, but mostly on the iliac oblique views, as is shown in this picture on the right. So special forms of posterior column, again extended, where it is detaching the teardrop and including the quadrilateral surface. It can have a high posterior column and an inferior posterior column, and then in pediatric patients you can have a epiphyseal separation with the posterior column. So typical posterior column fracture, which would appear like this, with the iliopectineal line would be intact, ilioischial line would be disrupted. This is how it would appear on the X-ray. So extended posterior column, these fractures approach the limit of the posterior column. Proximally, an enormous fragment of bone is detached. Viewed from the outer side of fracture line always includes the angle of the greater sciatic notch. That's how they would appear, with a detached teardrop, taking all the quadrilateral surface with them, with or without comminution. Epiphyseal separation, where growth plate is open. That's another variety. And then the last one is second last one is partial superior, and the last one is where you have an inferior extension or a lower posterior column. So there is a simple posterior wall, simple posterior column. They can be combined with each other, and then you can have their varieties, which we as specialized acetabular surgeons need to realize, diagnose preoperatively, and then have an operative plan for them. Thank you. I would just stop here. And next in line was Dr. Shoaib, where the debate was to show us the merits or demerits of lag screw fixation only, but I guess there are issues of power and electricity there in his area. He sent me a message, so we can go on with an EFSAB, a lag screws fixation with single recon plate. Go ahead.
So, Assalamu alaikum again. Can you hear me?
Yes, sir. We can
Yes,
hear you and
yes,
see your
yes, thank you.
slides. You go ahead. Nifsab? I think we lost connection. Let's give him a minute. He may be reconnecting. Saad, can you privately call Nifsab? Sharif? So any comments? Meanwhile, we have a small break, technical break, I think. Dr. Kyle, you want to make any comments so far on the discussion we have had? Any pertinent points besides the ones you have written in the chat box? Sharif, contact her. Any question from the participants? Any comments? Our residents? The discussion so far. We've taken you through anterior wall, anterior column, and now on to posterior wall, posterior column, right? On the elementary part of. And in the morning, we discussed anatomy and radiology and the approaches and the indication for surgery and how to assess fixation post-operatively. Any questions on that? Any comments? So if there are none, I can have.
Can I ask Dr. Masood, Nasir?
Ji, sir. Ji, go ahead.
Sir, as we see that obviously with time, people are going more towards more and more anatomical research, reduction, and very, very stringent criteria for intra-articular reduction of the acetabular fractures. So the technique of putting percutaneous screws after reduction under fluoroscopy. So what do you think that the future of this technique will be in acetabular surgery? Because obviously, if we are doing screws, we won't be able to reduce the fractures like that as is required right in the criteria.
नहीं वो मेरी opinion तो उस पे ये है कि unless they are reduced, we can't fix them either percutaneous or open. First thing comes first, which is reduction. So जैसे ये clamp है, I'm forgetting the name. For use for reduction. So if you apply that across the acetabulum, and just like a Mata clamp with the one limb longer and one smaller, just forgetting the name, if you reduce it well, if you think reduction is okay, so fixation, more and more innovation would come once you get experience, and no harm in doing percutaneous fixation for column fractures. I think it is coming for column fractures, not yet for wall fractures. It is coming for pubic rami fractures, yes, and for column fractures. But posterior wall, I haven't heard about percutaneous fixation of a posterior wall fixation. Maybe anybody from faculty panel can elaborate more, but certainly on column fractures, not on wall fractures.
Actually, in my opinion, the percutaneous fixation is actually increasing the indications.
Is what? Dr. Naveed, can you repeat?
Just let me take my headphones. आवाज speaker पे नहीं है.
आपकी आवाज क्लियर नहीं है डॉक्टर नवीद, क्या कह रहे हैं? Okay, I'll just finish my couple of slides, part of the program, double plate fixation. You already know that. Indication for double plate, I think most common and well understood indication is what? Yeah. Just a minute. Most common indication would be a combined posterior wall and column fracture. One plate will have a role of buttressing posterior wall, and the other would support the posterior column. And also where you have extended posterior wall or a multi-fragmented posterior wall extending or encroaching towards the column. This was a study, let me put it on full screen. Fragment-specific fixation published in 2021, where they did fragment-specific fixation of each and every fragment of the posterior wall. 46 patients, 33 simple, 13 associated fracture types, Coker-Langenbach, anatomical reduction in 89%, imperfect reduction in 8, and poor in 2. So with a versatile yet a strong enough construct, Their conclusion was in limited soft tissue dissection, fragment-specific fixation yielded very good results. So we are seeing a newer method of fixation, just as we now have them in distal radius, fragment-specific fixation. Okay, and this study in 2021 again of a new H-shaped anatomical titanium plate for posterior wall and column. 46 patients studied over last 7 years. Conclusion was fracture involving posterior wall and column. The new H-shaped plate, which is titanium plate, anatomical, can provide stable fixation, satisfactory reduction, and good recovery of hip function. And then in 2017, there is study where they studied posterior column for fractures using a W-shaped angular plate. So they had 4 categories, as you see on the picture. 1 single large plate, 1 single large plate with lag screws, and 2 plates, and the third picture from on the right. And then the last picture on the right is the W new anatomical plate. So they studied, this is a cadaveric study with biomechanical analysis. 20 embalmed cadavers, constructs were mechanically loaded and tested. So final stiffness was not different between 2 reconstruction plates and W-shaped acetabular angular plate. So the double plate and W-shaped plate fared almost equal, both of which were superior to a single reconstruction plate and a combined plate and lag screw. So following the fixation of W-shaped acetabular angle plate, strain distribution was similar to the intact condition around the acetabulum. So I won't dwell into these things, but as Dr. Sen also mentioned, we fixed the column first. These are techniques to fix the column. If we require a lag screw for the column, we do that. And then a neutralization medial plate along the column. And then we obviously fix the wall, disimpact if required. These steps, we won't go into them now, fix them temporarily with K-wires, with lag screws, and then finalizing the neutralizing plate as this is how it would appear on the final X-ray. So much so for double plating. Dr. Hanif, are you back? Dr. Hanif, we called, he had some network issues. We can't fight them. This is a pitfall of a virtual course. Anyhow, we would move further. Dr. Shoaib is also not available right now. Dr. Abul Hakim, are you online? अगर नहीं हैं, डॉक्टर अबुल हकीम भी नहीं है, तो हम अपनी वर्कशॉप पे जाते हैं. So वर्कशॉप पे जाते हैं, which is नहीं, उससे पहले वीडियो देख लेते हैं. शरीफ, वो वीडियो चला दें posterior wall and posterior column की, और उसके बाद वर्कशॉप पे जाते हैं. वीडियो उधर से आप चलाएंगे या इधर से? So
The first exercise of the fracture of the posterior wall is performed through the Coker-Langenbeck approach. For the Coker-Langenbeck approach and this fracture, the patient is placed in a lateral position on a standard table. The surgeon stands behind the patient. The head is to the left, the foot is to the right. The gluteus maximus muscle is reflected posteriorly. A Hohmann retractor is placed into the lesser sciatic notch, retracting the obturator internus muscle and the sciatic nerve posteriorly. The sciatic nerve must be palpated to make sure that the tension is not too great. A second retractor can be placed into the greater sciatic notch, retracting the piriformis muscle. A Hohmann retractor can be placed with a tip driven into the inferior iliac wing. Care should be taken not to stretch the superior gluteal nerve. The entire retroacetabular surface is now exposed from the superior portion of the ischial tuberosity to the inferior ilium. The quadrilateral surface and pelvic brim can be accessed by palpation through the greater sciatic notch. The interior of the joint can be visualized by performing a capsulotomy along the rim of the acetabulum. For this exercise, we'll use part of the 3.5 instrument set. To hold the fragments in place, we use a periosteal elevator, an osteotome, and a bone-holding rod with pointed ball tip. The template serves as a model for bending the plate with the bending pliers for reconstruction plates and the bending iron. The bone is placed in a vise as if the patient were in the lateral position and the surgeon standing behind the patient. After performing a Kocher-Langenbeck approach, the surgeon has a view of the posterior column of the acetabulum and the retroacetabular surface, which is seen to have a defect where the fracture of the posterior wall is. Two fragments of the posterior wall, which include a portion of the retroacetabular surface, are seen attached to the hip capsule. We can see the fractured cancellous bone surface where these fragments came from. An impacted segment of the cartilage of the posterior wall is visible in the fracture site. The femoral head is distracted from the acetabulum to visualize into the joint. The joint is cleaned and intra-articular free fragments are removed. An intra-articular free fragment is seen to be covered partially by articular cartilage and to be made up entirely by cancellous bone. This fragment should not be discarded and should be included in the final reconstruction of the joint. The femoral head was reduced into a congruous position with the acetabulum and used as a mold for reconstruction of the posterior wall. An osteotome is used to elevate the impacted segment of cartilage and cancellous bone. Bone graft can be obtained from either the pelvis or proximal femur and is usually necessary to buttress a defect following elevation of the impacted segment. The free fragment, including cartilage and cancellous bone, should be carefully examined for any keys to its proper position and orientation. Its correct position will also be determined to a degree by trial and error. These two fragments of bone that have been repositioned will not be directly internally fixed. They will, however, be held in place by the overlying segments of the posterior wall and the implant applied to the overlying segments. The fragments of the posterior wall, which comprise a part of the retroacetabular surface, are now reduced into place. It's usually necessary to reduce both fragments simultaneously with one's finger and also with the help of the ball spike. A periosteal elevator can also be used. A lag screw is placed into each fragment near the rim of the acetabulum. The screws must leave adequate room for the plate, which will span the fragments. With the patient in a lateral position, the 2.5 millimeter drill bit is directed vertically in order to avoid entering the joint. After drilling both holes, it's often advisable and quite instructive to redisplace the fragments of the posterior wall after drilling the hole in order to make sure that the screws will be outside the joint. The depth of the holes is measured. Now that we're satisfied with the hole positions, the fragments are over-drilled with the 3.5 millimeter drill bit for placement of the 3.5 millimeter lag screws. Insertion of the corresponding length screws. It's sometimes best not to fully tighten the 3.5 millimeter screws at this point if obliquity of the screw direction to the fracture plane causes a displacement. Fixation is completed by application of an 8-hole straight 3.5 reconstruction plate which spans the posterior wall fracture from the inferior ilium to the ischial tuberosity. A straight plate is used because it's more flexible than the curved plate. However, it's contoured into a curve that parallels the posterior rim of the acetabulum. A curved 3.5 reconstruction bending template is often helpful in contouring the plate. In this case, one screw hole will be completely above, as well as below, the posterior wall fracture segments. The distal end of the plate will be sharply upturned on the superior pole of the ischial tuberosity. The first step in plate bending is to bend a plate on edge and establish its curve. This curve should roughly parallel the rim of the acetabulum. The concave and convex contours of the plate are then bent in the normal manner using the reconstruction plate bender. Multiple small bends in the plate establish a smooth, rounded contour. At the moment, the plate is slightly under-contoured, so that with the lower end of the plate fixed to the bone, the upper end of the plate is off the bone by 2 or 3 millimeters. The final bending of the plate will actually be done by the screws, which bend the plate across the posterior wall and ensure that the plate places pressure against the posterior wall fragments. Place the screw into the hole that lies in the concavity of the plate, just above the ischial tuberosity. This is a 3.5 millimeter screw and a 2.5 millimeter drill bit. Measure the depth with the depth gauge and insert the screw. The screw is incompletely tightened to allow positioning of the plate. A 2.5 millimeter drill hole is drilled through the upper screw hole at the upper extremity of the hole in order to create a compression effect. Measure the depth and insert the screw. Tighten the screws at the two ends of the plate alternately to complete the bending of the plate and tension it over the posterior wall fragments. Always take care to direct the screws away from the joint. Another screw at the upper end of the plate is inserted. A final screw is directed distally into the ischium. The lag screws in the posterior wall may now be fully tightened if they've not been previously. The final reduction is typically not visualized because the hip capsule is left attached to the posterior fragments to preserve vascularity and hip stability. In our fracture model, however, we will now open the hip capsule to visualize the final reduction.
Thank you. We will now move to the workshop table. Sharif, can you give me color mic? We have this model. We have this model of posterior wall fracture. If you now have a look, we have created almost the same model as the video, a wall fragment which is split into two halves almost. So I will later on also show you a video about the various clamps. For now, we would be using this thing which is called a picador in my hand, right? And the exposure has already been alluded to by Dr. Ayaz Khan of a posterior Cocker-Langenberg approach. And for this, it is important that we hold the, I think you have to, yeah, this may be better. So we have to have two Hohmann retractors inside. The one is in the greater sciatic notch, and as you dissect the obturator internus, which is the tendon below the gemelli, so you have to dissect that. That's a white, shiny, bipennate muscle below the gemelli, and that is usually in my direction of my drill bit. Take it as a Hohmann. And this is the lesser sciatic notch. So this is how you will expose the posterior column with two Hohmann retractors, and one in the greater sciatic notch, which is here, and one in the lesser sciatic notch. After you identify the obturator internus and just follow the obturator internus very bluntly with your finger beneath it. So that's exposure part of it. And then obviously the other details, you can may or may not like to have retractor here, retracting the abductors up till this level, the gluteus medius. Now to fix the drill load 2.5 volt. The individual fragments, as the video showed, we would use K-wires. We don't have here for the workshop, but we would try to go through and we don't have a femoral head covered like we do in the video. So what I would do is try to pass. The patient may be supine. I do it supine, and how can we have lateral exposure? I think this would be okay. Prone. I mean not lateral. So we would start here. Have the fragment reduced by a parallel K-wire maybe first, and So just imagine I'm using a K-wire, right? And I'm inclining my hand, and very good technique that Dr. Ramesh mentioned, we can utilize it now. Just imagine this is a K-wire, you can hold this. Imagine this is a K-wire beneath the fragment into the joint. Okay? जो Dr. Ramesh ने भी बताई, which he says he uses very frequently. And then with my picador, I am reducing the fracture fragment. Okay? And usually during surgery, once I'm through both the things, I would have my finger inside the greater sciatic notch to feel the drill exiting, right? And as Dr. Kyle also mentioned, I would, which I also practice and learn from him, how to use the drill in a vibratory mode and to have it move to and fro to detect when is the far cortex reached and when are we across the far cortex. So now we are across the far cortex, and I would bring my drill back. And at this point, it's important that we disengage and we see the hole. And if you can see the hole and see, we can't see the joint in actual life patient every time unless we dislocate, but at least we can see the hole which is here and which is not going inside the articular surface, right? So then I would replace the fragment back. I would replace my picador depth gauge and measure at the same. So I would 50 ये 40 करेंगे. So Arif, right hand put it. So the direction of the screw has to follow the direction of the drill bit. And most of the time I would also use a washer here just to have a broader compression area. So if you see, one person is holding the reduction and one person is putting in the screw, right? So again, I would check if the screw is long. Sometimes they can be, and it's just the right size, just exited from the medial wall. Okay, that component of the wall is fixed. We would now go to the other component, that other half, and reduce it, and then try to pass a drill bit. So Dr. Arif is our instructor. He would have a go at the wall fragments. You have to be in the middle. First have an engagement, and then you slope it in the line. And Dr. And you can use the same method with Dr. Santor. Put a wire and penetrate the capsule. No, you are exiting here. You need to exit here. Change your direction. Yeah. Put your finger in the greater sciatic notch so that you know when to exit. Okay, are you out? Yes. Okay, and remove the drill. We will disengage the fragment once again. If possible, remove the K-wire also. Remove. And keeping the periosteal attachment, just consider this rubber band as the periosteal and capsular attachment. And now you see the hole. Can you? Yeah, you can see the hole in the camera. And if I bring it closer, see, we are within the wall of the posterior column and not into the articular surface. Just imagine we can't see the articular surface, we have the head. We would reduce, put it back, pass K-wire, measure, and pass a screw. वही size ले लें. What is that? So I've used comfortably full threaded screws, 3.5 here, without even over drilling the proximal cortex. And certainly a washer is desirable. So a lot of times the window may be very little, small, to see the drill bit. A lot of times you may lose the drill bit hole also, क्योंकि यहाँ पे सारा एक periosteum coverage और capsular coverage होता है. You don't have to dissect it out, as we have emphasized, everybody's emphasizing. Just make small puncture hole in that capsule for the K-wire, for the drill bit, without doing big time dissection, and use picador to hold your reduction. You can disengage once you have made the drill hole to see whether your drill hole is in the right direction, you are not entering into the joint, and then you have passed your 2 screws. Now if you see, these are our 2 screws which have not entered into the joint. So in a sawbone model in workshop, you can have that luxury. The next step is the plate. So as we have 7-hole plate is big enough. We can even use a 6-hole plate, but let's try a 7-hole. Next thing is bending of the plate. So ये bending एक दफा सीख लें, जो उन्होंने वीडियो में भी बताई. So the ischial part of it has to be bent acutely at almost like right angles to each other. Sorry, ये ठीक है. And then the distal part of the plate has to be bent in opposite direction to match the contours of the ilium. तो usually पहले हम करते थे उससे आप क्या कहते हैं, एल्युमिनियम की टेम्पलेट से भी कर सकते हैं. हर एक का दायरे कर्व फर्क होता है, बट अब आप देखें, अगर मैं आपको ट्रांससेक्शन में दिखाऊं तो ये प्लेट ऑपोजिट बेंड है. यहाँ से डायरेक्शन ऑफ द इन द ischium and then opposite for the ilium. Now we can even curve it according to, if required, कि हम उसको side curve भी दे सकते हैं with this plier. With, you must also know how to use this plier. इस चीज से हम उसको side curve भी दे सकते हैं if required. मैं आपको दे के दिखा देता हूँ थोड़ा सा. तो अब ये इस डायरेक्शन में भी, सॉरी, प्लेट कर्व हो गई. आप देखें, इस डायरेक्शन में तो थी, ये कर्व मैंने किया, और अब ये इस डायरेक्शन में भी थोड़ी सी ट्विस्ट कर दी है मैंने, राइट, टू मैच दी sometimes I hardly do it practically in a patient, but अब ये देखें कि हमारा ये थोड़ा सा उठ रही है काफी प्लेट. If you can see that, so we can bend it more. थोड़ा सा, बाकी तो वो स्क्रू भी खींच लेगा उसको. Okay, so we are here. Yeah, okay. Now the placement of the plate, this is a case of only posterior wall. So I'm placing the plate on the edges of the posterior wall. Sometimes the screws may come under the plate also. ठीक है जी. चलें, let's give me a drill. So 2.5 bit again, as he's mentioned. So I am managing my drill to and fro. I can't feel the posterior cortex here. So we have to emphasize it again and again कि हमारा pelvic acetabular surgery में बहुत दफा far cortex नजर नहीं आता. You have to have it in mind. 40 दे दो या 38 दे. 38. तो यहीं पे नर्व भी होती है, आपने उसको अंडर विजन रखना है, और रिट्रैक्शन खाम बहुत ज्यादा नहीं करनी, क्योंकि जितनी आप रिट्रैक्शन करते हैं उतना ही नर्व को भी आप डिस्प्लेस करते हैं. और प्रोन पोजीशन का फायदा ये है, और उसमें जो सबसे इम्पोर्टेंट बात है कि हिप को एक्सटेंडेड रखना है और नी को फ्लेक्स थ्रू आउट द प्रोसीजर. चाहे उसके लिए आपको एक सेपरेट बंदा स्क्रब कराना पड़े, या नी को आप कंटिन्यूअसली फ्लेक्स किसी हम मेयो स्टैंड से कर लेते हैं, उस पे पिलो लगा के उसके ऊपर ड्रेप्स डालते हैं, और हिप fully extended होनी चाहिए. So if this is the patient, he is supine, hip automatically is extended, but then you have to flex the knee throughout the procedure to 90 degrees, very essential to relax the nerve, ताकि आप उसके नीचे से retractor डाल सकें. अच्छा, ये एक हो गया. लें ड्रिल लें आप. So now we will use the second last screw, and direction is again towards the sciatic buttress area, right? So that drill will be directed distally and laterally to achieve that. अगर मैं सही दिखा पा रहा हूँ या नहीं? So this drill उधर कैमरे में drill is directed distally and laterally. ठीक है जी? अब ये okay. Again, carefully knocking it in and out to reach the far cortex and stopping as soon as you make a hole in the far cortex. हो गया? क्या? Depth gauge. क्या हुआ? Drill पूरा नहीं हुआ ना? That's what happens. This is a good practical example. So depth gauge can also tell you whether the hole was complete or not.
45.
यूजुअली आराम से 35 to 45 के स्क्रूज इधर आ जाते हैं अगर आपकी डायरेक्शन ठीक है और ऑब्लिक है तो आप अच्छा खासा बोन कैच कर लेते हैं. मस्ट कैच बोथ द cortices. Again I use fully threaded 3.5. Sorry.
So I think one practical tip is that when you're drilling, you always put your one finger in the sciatic notch, and with one hand you do the drill so that you can feel it all the time and you are in good control as well.
One hand in the sciatic notch और दूसरा सर दूसरा क्या
One
क्या
hand, no, one hand drilling and the other finger in the sciatic notch, and at the same time, so you're drilling, so you can feel, yeah.
जी बिल्कुल वो just a finger can go in there,
Yeah.
yes. Lot of times
That's a one tip.
Exactly. That would help to know the exit of the drill bit. If your finger can go up till that point, that will be another way to stop as soon as you exit. 40 ले लो 35. So, जैसे मैंने कल भी कहा था pelvic acetabular surgery और हर जगह ही प्लेट के एंड पॉइंट स्क्रूज के एंड पॉइंट्स होने चाहिए. वो इंटीरियर फिक्सेशन में कल हमने कहा, आज भी दोबारा कहते हैं कि स्क्रूज के एंड पॉइंट जरूर होने चाहिए, लूज स्क्रूज छोड़ के बाहर ना आ जाएं. That is 100% invitation to failure. तो फिर आप ट्रैक्शन पे जाएंगे और फिर नॉन वेट बेरिंग पे जाएंगे, बेड रेस्ट पे उस मरीज को हिलने नहीं देंगे. Those are things which would not bring good results to you. So as you see here, we must have, मैं दोबारा आपको दिखाता हूँ, we must have an end point of all. I should not be able with all the muscular power that you can use, they should not be loose. They must have an end point like this. Right? चलें एक आखिरी ये रह गया. स्कीम वाला at least 4 holes, 4 screws two above. और इसमें ये मुश्किल होती है कि आपको हाथ लेटाना पड़ता है तो यहाँ belly होती है, sorry बटक होता है पेशेंट का. So as low as you can go with the bit, so that आपको screw बाज़ दफ़ा 60 का 80 का भी मिल जाता है. You can traverse the whole of the ischial tuberosity to have much better purchase. और बाज़ दफ़ा तो आप बड़ा पेशेंट एग्जिट कर दें तो 70 का 80 का स्क्रू भी मिल जाता है आपको यहाँ पे. चलो मैं ये करूँ. एग्जिट हो गया?
हाँ सर.
किधर हुआ? So if you can see, let me show the proof. if you can see, Dr. Arif exited here, which is also okay, not bad, but we can still change the direction. So if this measurement is hardly 40, we can, Dr. Arif, can you try again? I have a much better pass. Usually 60 or 70. Length can also be changed. So we will make another pass. That's the पीछे तो दोबारा So now we were having some protrusion on the inside. We're asking our instructor to change his direction of the hand. क्या हुआ? देखेंगे तो ऐसे है ना, आप ऐसे देखें, ऐसे करें। हाँ जी। Let me. चलें. Dr. Arif has a tendency to exit, so he's in a vacation mode, no problem. Most of the residents are when they come to a workshop. Now we have channels which we are not able to bypass. Darling. That's okay. So we have a 60 screw length. 60 है? 50 दे देंगे तो दे दें हाँ चल ये 60 डालो. So this luxury you won't have in a live patient when you're doing, so you have to make your best shot, right? Best judgment, and that comes with the trick that we emphasized yesterday, Dr. Kyle emphasized in the evening, with directing your drill bit, rocking it front and back, and make sure that your direction is your drill is exiting where you want it to exit. And obviously that comes with experience. Chale, ye ho gaya ji. So we have now, if you see, 4 screws, 2 in the proximal part, 2 in the distal part. We have a buttress plate over the fragments. So the only criticism is we could have been more over the fragments. We are moved away. Actually, we went in the opposite direction. That was a error. So this end of the plate should have been closer to here, right? That is a criticism of this fixation. So in actual life, when you're doing it, we need to buttress the posterior half. We are covering it, but not effectively. We should have been at least 10 millimeters more posterior in this direction. But anyhow, the principle you have to learn in this workshop is lag screw fixation, how to do proper lag screw fixation without entering the joint, how to bend your plate and then fix your plate over the fractured posterior wall. Any questions, comments? चलें अब हम एक टॉक कर लेते हैं. So talk, Dr. Awal Hakim is online about classification of transverse and T-type fractures. Dr. Awal, are you online?
Yes.
Go ahead.
Yeah. Okay. Can you hear me, sir?
Yes, sir. We can hear you. Welcome.
Thank you, sir. Thank you. Screen. This one.
जी, we can see your slides now. Full screen कर लें.
Okay. Can you hear me?
जी जी बिल्कुल. इसको वो full screen mode पे करना है. नहीं वो ऑफ हो गया, अनशेयर हो गया. Any questions from the residents about fixation? Yes, we can see you now on full screen. Please go ahead.
Thank you, sir. Thank you. So basically, we have done with the interior wall and interior column and posterior wall and posterior column. So in the next session, we will be talking of transverse fractures and T fractures. Is it clear?
Yeah, go ahead.
Okay, so basically it's a just repetition. I just want to finish it early as Professor Masood has some concern regarding time management. So it's a normal anatomy and it's a column and wall theory. Their interior column and posterior column. It's all discussed all the day. And it's an inverted Y with interior column a bit lengthier and posterior column a bit short. And there is a junction that which is called a sciatic buttress as well. So basically an interior long column and a posterior short column. So we are now into the fracture classification, which has been already discussed. And we will be discussing the transverse fractures, the fifth one, and the elementary fractures. And the transverse associated fractures, we will be talking of T-shaped fracture, which is the first one, and the associated fractures. So basically, it's just an algorithm of how to differentiate between T-shape, both column, and so it's a bit different from the previous algorithm. When once you identify an acetabular fracture, just look into the obturator ring disruption. If it is disrupted, then it can be a T-shaped fracture or a both column fracture. So the differentiation will be on extension into the iliac wing. If it is extended into the iliac wing, that will be a both column. If it is not extended and the both iliopectineal line and ilioscale line disrupted with disruption of the obturator foramina, it's a T-shaped fracture. On the other hand, if there is no disruption of the obturator foramina, look into the posterior wall. And if the posterior wall is fractured, it's a isolated posterior wall fracture. If the posterior wall is not fractured, then it's a transverse fracture. So sometimes that will be a transverse and posterior wall fracture. That has been discussed in the morning. Radiographically, we need a proper epi view and two Jude view, the iliac oblique and the obturator oblique view. And sometimes we need an inlet and outlet view as well. And nowadays, a CT with 2D and 3D reconstruction, we can better see the fracture line and configuration. Basically, the transverse fracture are usually define the fracture which divides the acetabulum into two halves, the superior and the inferior. So basically, the iliopectineal and ilioscale line both will be disrupted, and the acetabulum will be divided into a proximal and a distal segment, the ilium and the ischium and pubis segment. The T types are further classified on the basis of location of the fracture line. So if the fracture is superior and goes through the superior dome or the articular cartilage, it's called a transtectal, above the cartilage fossa through the articular cartilage. If the line passes through the articular cartilage and cartilage junction, it's called juxtatectal. And if it is passing below or through the cartilage fossa, it's an infratectal fracture. The basic idea for further classification, the proximal the fracture line, the more notorious the fracture will be. And it will be probably more in favor of surgical intervention. The complication will be more comparatively as compared to the lower line. And the impaction of the marginal impaction of the or central impaction of the acetabulum or sometime of the femoral head will be there. So it's more associated with the post-traumatic arthritic changes and needs more aggressive approach to deal with the transtectal fractures. Basically, in this slide, it's a roof arc angle, which was first described by Mata and Joel in 1986. The idea is to draw a vertical line through the center of the hip or to the center of the reduced head. The head must be reduced first. Then you draw a line, a vertical, a triangle to the center of the hip, and then draw another line at 45 degree on AP view, on iliac oblique view, and on obturator oblique view. So it's very simple. The AO pupils describe it that if it is outside the 45 degree on all these three angles, so probably the fracture is more in favor of conservative treatment rather than surgical intervention. But it's not the only indication. It's a relatively one consideration. There are other indications as well. One should always consider the other indication as well. This is the same about the roof arc angle. A study in this slightly different values in 1999, this was basically done by the Warha, and the angles were slightly changed from that Mata et al., which was described earlier. A 45 degree on the medial roof, and interior is 25 degree, and posterior is 70 degree, but this was just a mechanical force and stability-wise study. How the transverse fracture will look like on CT. So if you look on the CT, the fracture line will be a longitudinal, a sagittal one, rather than a transverse one. So remember this, that on CT, you will look a fracture line which will not be a transverse one, rather than it will look like a longitudinal or sagittally placed fracture line. So that's important. Now we are coming to the T-type fracture. So T-type fractures are usually transverse fractures which has extended through the obturator foramina, and it looks like a T. If you look into a transverse fracture which extends inferior limb into the obturator foramina, it's a T-type fracture. I remember this extension can be very anterior or very posterior through the pubis or through the ischium. So anyway, it always called a transverse fracture, and technically it's very important that every transverse fracture needs to be fixed because it's mechanically unstable and needs stabilization and fixation. On CT, if you look on plain X-ray, the transverse, and if you look into the inferior pubic ramus, there will be a fracture line anywhere, and that can be into exiting anteriorly or posteriorly. And if you look into this forces, they are acting like it's moving in a direction and adding further force to displace the fracture. On CT, again, a transverse fracture will look like a longitudinal or a sagittal one, and the lower limb extension into the obturator foramina will look like a transverse fracture on the CT section. There is another variant, it's a reverse T, and if the T is extending into the iliac wing, it's a very rare condition, but in literature it is mentioned that there is an inverse T, fractures are there, and the T, the fracture line extends into the iliac wing rather than extending into the obturator foramina. So this was a very brief to save the time for Professor Masood Umar to continue with this session of transverse and T-type fracture management. Thank you. And any question if?
Thank you very much. Excellent overview. What is the difference between a transverse and a T-type? And if there are any questions or comments, we can take them. Thank you, Dr. Hakim, for being in time. It is just my request, not only to you, but to all speakers. Any comments, questions? So we will have the debate on difference between transverse and bicolumn. When we come to bicolumn, Dr. Nasser will do that. Meanwhile, we can start with our third debate, which is on the fixation part of this T and transverse. We have I have grouped them together into two brothers, transverse and T, although they are different, as Dr. Hakim has mentioned. So Dr. Kazim Najad will take us through fixation of transverse oblique T types through posterior approach, and then we will have Gavin talking us about their fixation through anterior approach. Over to you, Kazim Bhai. Dr. Kazim? Dr. Kazim, are you online? Gavin, are you online?
I am online, sir. Dr. Nasir here.
No, Dr. Kazim.
Kazim.
Kazim की talk है ना?
जी काजिम की talk है, Gavin की है. Call कर लूँ मैं?
Yeah, I'm here. Yeah, I'm here.
Oh, Gavin, meanwhile you can start. While Dr. Nasir, please Kazim को privately call कर ले.
Yeah, sure, no problem. I can go first.
Gavin,
okay.
You have to take us through anterior approach of transverse in T-type. Please go ahead.
Okay, just give me 1 second. I'll just share my screen. Okay, thanks again, Masood. So I took this to mean that essentially you want me to convince all your registrars that we should be using anterior approaches for all these and to give them the good reasons for doing that. And I assume your colleague Kazim will come on and try and rebut everything that I say. So, so the title of my talk for this afternoon was to convince you that transverse and T-shaped fracture should always be fixed through an anterior approach. And I just added this last little bit in myself that you'd be crazy to use any other approach, and you'll soon find out why. So the aim of the talk really is to clearly demonstrate that the anterior approach is the best approach to visualize, reduce, fix transverse and T-shaped fractures. I'll clearly demonstrate that the posterior approach is inferior to any anterior approach to visualize, reduce, and fix any transverse or T-shaped fracture, and will clearly demonstrate that the short and long-term outcomes is superior for anterior approach treatment of these types of fractures. So I'll not repeat things too much. I know we've gone over things a few times today already. Okay, so the similarities, as already been mentioned, between the transverse and the T-shaped fractures, apart from them both beginning with a T, are very limited. They're very different types of fractures, and obviously, apart from them being together and side by side on the fracture classification, there's very few other similarities. Helps us remember the change from one to another. They're very common injuries. They make up about 18 to 20% of all acetabular fractures. So it's an important group to look at and deal with appropriately. And for the registrars that are here, and maybe who haven't seen this from yesterday, the main fractures we're talking about and identifying them radiographically is really the ones that we see and differentiate between whether there's obturator ring disruption or not. And obviously, if there is obturator ring disruption, but no extension to the iliac wing, they're T-shaped fractures. If there's no obturator ring disruption, fundamentally, they're transverse fractures. And again, you've just seen this here. Their transverse fractures are elementary, and there's a single fracture line. It does go through both columns, but a significant proportion of the joints usually still attached to the axial skeleton. But they are often truly not transverse in nature, and quite often, and especially whenever you get the transtectal injuries and fractures, can be associated with articular compression or even some degree of comminution as well. So the diagram and schematic that you see in the top right side, you see it very often through the AO books, but frequently it is not the true case and orientation of the fractures. We have just heard that the higher the fracture, the more difficult it is. And there's a number of reasons for that. Quite often the fracture line isn't transverse, but more of a W or even an N shape. So it's very high at the back at the superior sciatic notch, the superior aspect of the sciatic notch, and even anterior, it can extend quite high up on the anterior column as well. Whenever you're doing these or trying to fix these fractures when they're in a lateral position through a Cocker-Langenbeck approach, again, the higher the fracture, the more difficult it is. You have the whole weight of the leg displacing the fracture medially just through gravity, and trying to get this reduced using manual traction is very difficult. You can see here in these x-rays, in particular the ones on the top right-hand side, this is a transverse fracture, but it's a very high transverse fracture. It extends all the way up into the sciatic notch, really right underneath or even beyond where the vessels are and the nerve to your glute medius. Trying to stretch these or work around these is very difficult when it's completely unnecessary. All you need to do is approach it from the medial side, a simple bit of traction from the GT in a supine position, and you can reduce these fractures nicely without any risk to the vessels and the nerves. Additionally, whenever you reduce these from a posterior approach, quite often the posterior column lines up well, but due to the indirect nature of the anterior reduction, often there's a mild or moderate rotational deformity that remains, so incomplete reduction. And just as we've heard earlier on, the radiographic findings and post-operative assessment might be very good, but the three-dimensional gap often isn't good enough. Relatively simple fractures like this, if you apply your post-operative assessment of fracture reduction to these, you draw your circles on the sourcil and the femoral head, and it looks pretty good even before you start doing any operations. But we both know that, and we all know that if you fix this from the back, you can get a nice, what looks like anatomic reduction. But if you did your 3D assessment, you'll find that there's a large anterior fracture gap often when you approach it from the back. T-types, they're similar but different. There may only be one additional fracture line, but usually the volume and the amount of energy required for these types of fractures to occur is higher. Often it's not as simple as what's shown in the schematics. There's articular impaction, there's comminution, often there's a quadrilateral plate injury as well. It's simply impossible to reduce these adequately and appropriately with minimum 1 millimeter or 2 millimeter steps in the joint for longevity of the joint. Anterior approaches really are the only way you can address these, whether it's through an ilioinguinal or whether it's through a stop approach, whatever you're best at. Here, it looks like a very simple T-shaped fracture, but it isn't. If you look at the right SI joint, you can see that the amount of energy required to cause this injury is significant. And inevitably, with further imaging and intra-op, you'll find that there's more comminution than the plain radiograph demonstrates. Often you'll see dissociation between the anterior column and anterior wall. It's impossible to fix this or reduce this accurately through a posterior approach. And in the bottom right, not only is there a T-shaped fracture, but there's another separate articular fragment. Again, if you're not approaching this from an anterior perspective with the patient in the supine position, it's very difficult to reduce this anatomically, and you're forced to accept suboptimal reduction, incongruent reduction. When you look at the Cocker-Langenbeck exposure, whether it's direct or indirect, from some of the x-rays I've just shown, you can see that the extension of the proximal aspect of the fracture goes to the very limit of where you can access, if not beyond where you can access. So for these simple reasons, you really need to consider using anterior approaches for these types of fractures. I'm not quite sure what the registrars are like in Pakistan and how strong they are, but I know if I'm trying to fix these through a Cocker-Langenbeck approach in a lateral position, after about 30 seconds, most of the registrars lose all their strength and the fracture simply displaces medially again. Whereas when you look at the ilioinguinal approach, it gives you complete access to everything you need to, both in the anterior and posterior columns for these transverse and T-shaped fractures. It also allows direct visualization of the joint, correction of any marginal impaction, bone grafting, articular reduction, and rigid fixation of the columns. And you can see here, even AO agrees that it's such a good approach, you can pretty much do anything you need to through it. And if AO says it's the right way to do it, well, it's the right way to do it. When you look through the windows, you can get high anterior column access, direct joint access, low anterior column, and visualization along the whole pelvic rim from your anterior ilioinguinal approach. I hear some of you saying, what do you do about the posterior column whenever you only have anterior access? I think it's quite simple. You just use your lateral window to drop a screw down the posterior column. After all, using the anterior approach, you've been able to reduce things anatomically. So you've got nice wide corridors that are safe, that you can do percutaneous fixation or limited fixation from the first window. In contrast, when you're trying to do posterior fixation and supplementary anterior percutaneous or limited fixation, anterograde anterior column screws are much more difficult to place. In particular, if you don't have absolute anatomic reduction of the anterior column, the canal or the width on the anterior column reduces significantly. And when doing it in a retrograde fashion, the patient starts off in completely the wrong position and needs to be repositioned. So for all these reasons, I think it's much better to use an anterior approach for your transverse and your T-shaped fractures. And when you look at these outcome-based studies, highlighted in blue is your transverse fractures. So you can see from a transverse fracture perspective, 13 out of 19 reduced anatomically, a couple congruent and 4 incongruent. However, when you compare and contrast that to your T-shaped fractures, only 7 out of the 18 are reduced anatomically. And I'm pretty certain that's because people are using Cocker-Langenbeck approaches to reduce the T-shaped fractures. When you look at all different fracture patterns, T-shaped fractures are the worst in terms of anatomic reduction, but quite a long way. And this is even confirmed or compared to double columns and all the other associated fracture pattern types. And when you look down further to the outcome and anatomic reduction by approach alone, you'll see that the ilioinguinal approach is about 80% anatomic reduction, whereas the Cocker-Langenbeck approach is only 70% anatomic reduction, with about 15% of incongruent reduction. And when you compare and contrast this to the figures above, I think most of these are due to using Cocker-Langenbeck approaches for your trans or your T-shaped fractures. So I think there's enough evidence here to show that we should really seriously be considering using anterior approaches for both our transverse and our T-shape. We all know and have heard earlier today that outcomes are almost exclusively based on the quality of the reduction achieved. So when you see these figures, I don't understand why anybody would use a Cocker-Langenbeck approach. So I think in summary, it's very obvious why the outcomes are worse when you use posterior approaches for transverse and in particular T-shaped fractures, inadequate visualization, inadequate access to the joint, ignore your gull sign and just fix it from the back. Inability to address acetabular impaction, but a quicker and easier operation. So I suggest that everybody treats the patient and not yourself, does that more difficult and arduous approach to ensure that you get anatomic reduction of the joint. And I think you should all change, or all of those who still use posterior approaches for these fractures should change today to an anterior approach. Thank you very much.
Thank you. Thank you. And Dr. Hanif, you have a comment?
I have a question that when we have posterior wall combination along with T or transverse type fracture, when the injury is more pronounced posteriorly and on the anterior side, we only have one fracture line, what would you prefer?
Hanif, I think you know the title for this talk didn't involve posterior wall fractures, yeah? I think the reality and the debate are two different things. You know, I think if there's simple fractures where you need to access everything predominantly from the front or the comminutions at the front, then inevitably using anterior approaches are better. But before my partner speaks about the benefits of using posterior approaches, I think we both know, and in addition to what was mentioned earlier on today, if the significant comminution and problems at the back, I think most people would genuinely, in reality, approach it from the back and maybe do a trochanteric flip osteotomy to access the front. But I think for the purposes of the debate, I was pointing out the outcomes-based reasons for using an anterior approach for all of these compared to a posterior approach. But obviously that will vary from specific fracture pattern and variant of the transverse and in particular T fractures.
Thanks.
Dr. Umair, you have a comment?
Can you listen?
Can't hear you. Dr. Umair?
Can you hear me now?
Yes.
Dr. Gavin, very good talk. I just want to add, even in my series, I think about 90 to 95% of the transverse fractures I approach to the anterior side. But we have to take into account the exit point of the fracture, the column that is more comminuted and displaced, and the tactile involvement. If, for example, you have a bit comminution or marginal impaction, and some of the aspects that require a specific access, only then you can go through the posterior aspect. Otherwise, I think the mobility and the complication profile of anterior approaches is much lower than cochlear lung impact, in my personal experience. I use modified stoppas and do almost all T types and transverse fractures to the anterior approach.
Sure, yeah, I would agree with that. I think Dr. Kasim, I think, who's going to speak next about the posterior approaches, will highlight the issues that may sway people to use posterior approaches for a small number of these types of fractures.
Okay, thank you, Gavin. And Dr. Kazim, are you online?
Hi, everyone. I am here. Sorry, I had to scrub in a case, so that's why I am right now in the theater, so bear with some of the noise over here. Thank you very much, Dr. Gavin. You made my life some easier. And let us see if I be able to just talk and just give some important aspect about the posterior approach for doing it. So I'm going to share my presentation now. Am I able to, Dr. Gavin, I think we have to.
I've already stopped sharing.
Okay, please. Thank you very much. Share screen. Okay, I'm sharing it. That's my screen picture. So, can you all see it right now? Can you all see it?
Yes, yes, go ahead.
Yeah, okay. Can I just start with my presentation? So there was a debate regarding which one is better or easier or convenient to be for the fracture reduction. We all know this T-type fracture, the bicolumnar fracture. What we need an absolute stability through anatomical reduction. That's the main aspect. And we all in the morning till now we have talked about basically congruity of the joint, how the displaced fragment need to be reduced, and all about the less than one to two to three. So that's all will be possible if we're able to reduce the fracture. The reduction is a tool over here, and that's basically the direct reduction always give you the better congruity of the joint. So basically, I will be talking about transverse T-type fracture fixed to the posterior approach, and we all know about it. I will going to go through it, and this what is a T-type diagrammatic presentation on the AP pelvis, how it look like as it going to the ischial bone. So it is T-type, it is called. That is to Jude views that how it's going to look like. We have discussed it. Dr. Gavin has also talked about it, and that CT scan, of course, give us the better idea all about it. And transverse fracture again, that's how it look like. So so for this type of fractures or any fracture in the acetabulum, what the most important aspect is the equipment that we need, the armamentarium that we have to have in our hand. So one is radiolucent table, and then again the pelvic system and the snatch reduction tools that we all need to have for the pelvis, especially for the pelvis 3.5 or 4.5 system, and again image intensifier, the most important aspect. So patient, some goes with the semi-prone, some goes with lateral, some goes with prone. So this is all about the orientation that people have in their mind while doing the pelvis fracture. And of course, the post, the patient need to be catheterized. That's what is all about. That's how the patient in the Coker-Langerbeck KL approach, posteriorly, we have to go through a KL approach, and that's how the patient will be in the prone position. And we have discussed in the morning, Dr. Ayaz has very well talk about how what are the landmarks, posterior suprailiac spine, a greater trochanter, and that's how it will be. And that's where the accessibility to the Coker-Langerbeck approach that we're going to have. We have a posterior column and posterior wall is more accessible, and with the help to the sciatic notch, we can put our hand, we can feel it, so we can have some idea of the interior aspect also through that this feeling of our index finger. So that's what we're going to start with it. We're going to make an incision, and that we're going to extend to the posterior suprailiac spine, and then again the iliotibial band and the gluteus maximus splitting. And then we go further, we're going to come across with the rotator, short rotators that will going to be stitch, and we're going to help and we're going to detach from the bone. That will going to be a very good structure, will going to help us prevent from the any iatrogenic injury to the sciatic notch. So that's how it will going to, we will going to process further, and that's what we have to keep in mind. We have to take care not to damage the medial circumflex artery, and that's how the things are. And that's this arrow mentioned where the sciatic nerve is, and then this the short rotator which has been detached will going to over it will going to be over the sciatic nerve that will going to help you while doing a surgery. If you are more concentrated on the surgery, that will going to help you to abstain from any sciatic nerve injury. So that's how we're going to start, and then we're going to put we have seen in the videos where you have to bone spike can be placed in the lesser sciatic notch, greater sciatic notch, and that's the tool. And that's how this is what my belief is, and my debate is, it's how we would reduce the transverse fracture. The reduction is the best, congruity of the joint is the best anatomical reduction. That will be more easier, in my opinion, to the posterior approach. And that's with the help of Sean Pin in the ischial tuberosity, that will going to help you to move the whole of the one part of the fracture, and that will help you to reduce the fracture. Again, the junk blood this reduction tool, it's very amazing. That's will going to, even with the 2 screws, you can reduce the fracture. And this offset reduction tools will going to go anteriorly to the sciatic, to the greater sciatic notch and go to anteriorly, and that will how it's going to reduce it. Once you're able to reduce the fracture, I think so your 90% of your work has been done, because the joint congruity you're able to achieve through this tools, through this mechanism, direct reduction tools, that what you have put. Once you are putting over there, then you're able to put a leg screw from the superior to the inferior part. Once this has been done, and then again that how you then you're going to put a plate. There might be some plate. There might be some debate about the double plating. And again, the most important prospect is how from here you can put your finger to the sciatic foramina, get a foramina into the anterior aspect, and that your guide wire can be, or your drill can going to guide you that through into the pubic bone, so that you can just have a screw, long screw, and just reduce and stabilize your anterior column. So these are this is known as a Junglut clamp, and this is one of the favorite of Professor Dixon and my mentor, Professor Intihab Tawfiq. We are very frequently using it. This will going to make your life easy. That will going to help you to reduce the fracture. Everything is in front of you. You can feel it. And there is nothing like any vascular structure. So it's very easy. Conveniently, you can use it. And that Sean pain, that what I've just been told, because it has been displaced because of the forces which causes the medialization or the distal fragment, or that will going to help you to, with the help of this, you can have the traction. With the help of it, you can reduce it. And once you have been there, so this how your work is made easy. This is another Farabuff reduction clamp that also is very useful to reduce your fracture, and that's again the offset reduction forceps that will going to again help you for the anterior column reduction. The reduction of this type of fracture is most important. This is the offset reduction forceps that has been used, that make your life easy, and that you're able to reduce the fracture. So these are all come into play posteriorly very easily. You can have a direct reduction on it, and that's how this go along. So again, in the posteriorly, when we want to put a plate, so we have a danger zone over here that we have to keep in mind while just doing it, because this is a place, if you're going to put a screw, it will be in the joint. So this two area which has been shaded with the blue, that will the safe area, and between the 4 to 5 centimeter, and that's where you have to avoid any screw placement. And this, what is the leg screw we have talked about? This where the leg screw of your first after reduction, this first leg screw, which is going to help you to reduce this if you see this transverse fracture, so this will reduce it, this fragments which you have done through with the help of a Farabuff or the offset, and that will going to cause it with the help of a leg screw, that will going to help you for the better stability. So this show the angulation that you need to have your screw for the leg screw into which come into play. And then again, this is another aspect which is important, how to put your screw direction toward the anterior column. So this what the angle that will where you have to start. There's an imaginary line from the greater sciatic foramina, which goes inside. You can start 1-2 centimeter behind it, and that the angle around the 40 degree can help you to guide you anteriorly. And with the help of your finger, you can, through the to greater ascitic notch, you can go anteriorly, and you can, that will even going to guide you, that will be on the right direction. So these are the few couple of patients that what we that you can see that what there with the fracture, and that there on the CT scan, that's how it's going to look like, and the double plating and the posterior to anterior screw that has been placed, the congruity has been maintained. Another patient that what we after posterior putting a plate, so from the posterior to anterior, that can be the screw can be placed, and that will going to make your life easy. The congruity can be maintained, and this is all about my debate on the posterior approach for the transverse fracture. Thank you.
Great job, Dr. Kazim. Now the session is open for further comments, suggestions.
मैं आ जाऊं? अच्छा बेटा मुझे दे दो फिर।
जी जनाब। जी डॉक्टर इंतखाब। Dr. Umair,
can you hear me?
Ji, now we can hear you.
Yeah, I was just wondering, previously, well, transverse fracture needs to be fixed in both columns. So what I have done in the past is that in the transverse fracture, open it up a little bit with laminar spreader, and then it's column because it's posteriorly, it's a flat surface. So I've applied narrow or a broad DCP after opening it to get the flatness of the plate direct on the flatness of the posterior acetabulum column, so that the rotation can get corrected, and of course with the manipulation with the shank screw and other thing. And then when I get the flatness of the rotation corrected, I may able to compress it with another plate. So that's and no screw was passed. So I have just done from posteriorly with two plates with the flatness of a broad DCP or a narrow DCP, able to deal with the transverse fracture. Thank you.
All right, Dr. Umair.
I have 2 or 3 comments to make. There's a very important consideration while selecting anterior or posterior approach in these fractures. I think whenever you can err on the side of anterior approach, it's good for 2 very important reasons. First, the muscles that attach to the lateral side of the pelvis are inserted through Sharp's fibers, whereas all the muscles on the inside of the pelvis, the iliopsoas, even the obturator internus, they are loosely attached, and there are no Sharp's fiber on the inner side of the pelvis. And it has been documented when you dissect off the Sharp's fibers, the risk of myositis ossificans is increased many folds. So the lateral and posterior approaches have higher incidence of heterotopic ossification and myositis. Secondly, while considering the delayed THR in mind, because this might be a consideration in a number of cases, you should disturb the abductors as little as possible, because abductor dysfunction is almost always there in all acetabular fractures, no matter what, even if you do anterior approaches, but the incidence and the magnitude is much higher for the cochlear Langenbeck and lateral approaches. So if you have a possibility that you can go interior, I think it's always beneficial.
My question is, my question is that as we have seen that in the transverse fracture, what is important is the roof arc measurement. And we also know that as in the posterior wall fracture and column fracture, we have also discussed that the fracture line passing through the supra-posterior area have poorer prognosis as compared to the anterior side, and the roof arc is also up to 70 degrees in the posterior side. So considering that thing in mind, don't you think, Umair, that the reducing the posterior side accurately is more important than reducing the anterior part of the transverse fracture?
It's a very good question. What I believe is that I reduce and fix these fractures through modified Stoppers approach. One of the luxury of this approach is that you have direct visual access through the stopes interval of the quadrilateral plate as well as the posterior column. The upper part of the posterior column becomes pretty visible if you go gently dissect along the obturator and internus muscle, and the entire working area of the T-type and transverse fractures is visible to you. So it no longer remains an indirect reduction for me, especially when the posterior fracture is higher exiting. And with the help of special clamps, what I do is that I drill a small hole in the lower part of the quadrilateral plate, just close to the ischial spine. And then using an offset asymmetrical clamp, I pull the posterior column upwards. And I think in most of the times, I can show you my cases, the reduction is pretty satisfactory. Much more difficult is the reduction and fixation of the anterior column while dealing from the posterior approach. And with due respect, I disagree that in any case of transverse and T fracture, you are never okay if you are fixed only the one side. The forces that are exerted along the mid-axial plane of the pelvis are too high in T-type and the transverse fracture types. So it's very important to fix the opposite side, no matter how undisplaced or no matter how undisplaced it is. It is important to fix the opposite pivot, so that it doesn't rotate when the patient sits or when they mobilize. Not only do we have to reduce the fracture, but we have to take into consideration the future mobility, the stability, and you have to give such a stable construct that patients start sitting from the same day and start mobilizing with the opposite limb the very next day. So it's important to fix the other column as well.
That's very right. I personally think that both sides should be fixed. But sometimes if you are approaching from one side, then the other side can be fixed with the percutaneous screw.
But reduction is mandatory for that. If you are going to the posterior side in a transverse or T-type, I think it's very useful to go for prone cochlear Langenbeck, because at least in my hand, it's the only way where we can apply sufficient force to the anterior column for reduction. In lateral decubitus position, the gravity effect of the femoral head is so high that I think almost no clamp can overcome it.
Yeah, that will display
so on that front, I totally agree with Dr. Gavin. In my own personal opinion, once you start fixing these fractures to the anterior approach and start achieving good results, I think the mobility profile and the reduction profile and the ease of doing it becomes easier with anterior approach. For these two fractures specifically. Obviously, if there's a posterior wall modifier or if there's a chondral modifier, if there's a marginal impaction, it's a no-brainer, you have to go from the posterior.
Yeah, true. Dr. Gavin has to say anything about this, or he has any opinion about?
I don't think I have much to add to what Umair has said. You know, I think as we spoke many times throughout the last few talks as well, it really comes down to your own comfort and sort of skill and experience too. You know, I actually, contrary to what I've said in the debate, I actually do a reasonable number of these from the back. You know, I think you can actually, especially in association with a trochanteric flip, accurately, either directly or indirectly reduce the anterior column. Quite often, if you use, a double plating technique, so you put a short plate on the posterior column element, and then I quite often will run a curved plate all the way around the top of the acetabulum, and especially as mentioned, a lot of these are not true transverse fractures. They are a little bit sort of have a wave to them or a W type pattern, and the high anterior ones, quite often you can catch them with that one or two anterior screws if you bend the plate properly. And again, it just depends what you're familiar with and what technique you have available to you and what traction devices you have available to. But despite sort of complaining about the registrar traction, I think, if you do a nice trochanteric flip, expose the anterior column, you can use your indirect reduction techniques to get good reduction, especially if you dislocate the joint. It takes the weight of the leg from the fragments. When it comes to T-shaped fractures, it is a little bit more difficult, and definitely sort of err towards anterior approaches for that. But certainly for transverse, I think you can deal with an awful lot of them through a posterior approach, especially if that's what you're used to. If you're more of an occasional acetabular surgeon and you do a lot of hip replacements and this type of thing, a lot of people are very familiar with a posterior approach. And so it's always a balance. Whenever you've got a lot of experience like Umair and you're doing a lot of anterior approaches, you're very comfortable with it. If you're not doing a lot of them, it can be quite a stressful experience. And so I think, again, we're always trying to achieve perfection, but I think as close to perfection as possible within your own circumstances, okay. So it's definitely still a debate, you know, and I agree with all points kind of raised. And I think it's much more comes down to an individual thing. And I think at the end of the day, whatever you get your best reduction with your minimum complications, it's all about the reduction at the end of the day.
Great debate. I think it served the purpose. We have heard both sides, and now we have to individualize the treatment, merits and demerits of both sides. But the principle is you have to fix both columns. You have to have fixation posteriorly if you want to go posterior, and then from there you fix the anterior column also. You don't come out with fixing the posterior column alone. If you're going from the front, again, you do the same thing. You go and fix the anterior plate through stopper, but you also fix the posterior part of the injury. So that, if that is done satisfactorily, to me, I started stopper not very long ago. So I'm very happy with the very low morbidity of the approach. Small incision, and you can do big things through small incision. The problem with KL, as mentioned rightly so, is the big morbidity associated, and a lot of patients have till long time a limp. A lot of times we injure some part of the gluteus, we injure some nerve there without realizing that, and so it's a huge approach. But if we can do the same thing with a much smaller approach, so I guess everybody has to make their own choices. Our job was to delineate merits of each approach, each fracture, which we have done adequately by very good job done by both speakers. I think we go on to the next part, which is seeing the video. How does the video people fix a transverse and a T-type? Let's go to that.
Transverse plus posterior wall fracture through the Coker-Langenbeck approach. For the transverse plus posterior wall fracture fixation, the patient is placed in a prone position, that is, face down. The surgeon stands lateral to the patient. The head is in this direction, the foot is in this direction. On the model, we will reflect the gluteus maximus muscle posteriorly. Then place a retractor into the lesser sciatic notch beneath the obturator internus muscle. This retracts that muscle, plus it retracts the sciatic nerve. We have to be careful with tension on the sciatic nerve. Another retractor can also be used in the greater notch in front of the piriformis muscle. And often, another retractor with the tip driven into the iliac wing to retract the abductor muscles. This now provides exposure of the retroacetabular surface from the ischial tuberosity to the inferior ilium. The hip capsule is seen here, which can be opened for access to the joint. Through the greater sciatic notch, we get access to the quadrilateral surface, the inner wall of the pelvis, and also to the pelvic brim and anterior column. There is a limited access for palpation to assess the reduction, or sometimes even to place a reduction clamp through the greater notch to the pelvic brim and anterior column. For this exercise, we'll use part of the 3.5 instrument set and this selection from the 4.5 set. These are the instruments used for the insertion of the 6 mm Schanz screw. Also needed this pelvic reduction forceps used with screws. The fragments are held in place with the small oblique pelvic reduction forceps and the bone holding rod, both with pointed ball tips. The template serves as a model for bending the plate with the bending pliers for reconstruction plates and the bending iron. Place the pelvis in the vise as if the patient were in the prone position. Seen on the close-up is a transverse plus posterior wall fracture with a posterior wall fragment remaining attached to the hip capsule. This injury typically is associated with a posterior dislocation of the femoral head. During the surgical approach, a free bone fragment of cancellous bone, covered partially by articular cartilage, was found in the wound. This fragment must be included in the final reconstruction. The first step will be reduction of the transverse fracture and lag screw fixation. Following this, the posterior wall will be reduced and plate internal fixation across both fractures will complete the fixation. The pelvic reduction forceps will be used for reduction of the transverse fracture. A 4.5 millimeter cortical screw is placed into the retroacetabular surface just lateral to the ischial spine. The 3.2 millimeter drill bit is used and a screw 10 millimeters longer than the measured depth is inserted. Another 4.5 millimeter cortical reduction screw will be placed into the inferior ilium at a point anterior to where the lag screw will be placed across the transverse fracture. The hole is drilled with a 3.2 millimeter bit, and once again a screw 10 millimeters longer than the measured depth is inserted. The reduction forceps are attached to the screws. The correct orientation of the reduction forceps prevents a stretch injury to the sciatic nerve. If the forceps are placed in the opposite manner, a stretch injury to the sciatic nerve can occur. However, we'll use this orientation for the video in order to increase visualization. The screws are not completely tightened so that the bone fragments may rotate underneath the reduction forceps. We'll now attempt to reduce the transverse fracture. The reduction appears perfect as visualized at the greater sciatic notch and the retroacetabular surface. Palpation through the greater sciatic notch, however, reveals a step along the quadrilateral surface and pelvic brim. Distraction of the femoral head from the joint also reveals a step in the articular surface. This malreduction of the acetabulum is due to rotation of the lower ischiopubic segment. A 4.5 millimeter hole is placed in the groove between the posterior rim of the acetabulum and the ischial tuberosity. A 6 millimeter shank screw is inserted into this hole. The transverse fracture will now be reduced by controlling the rotation of the ischiopubic fragment with the shank screw and the displacement with the pelvic reduction forceps, which are then locked. This maneuver may not be adequate to hold the reduction, and additionally, the small angled jaw clamp with ball tips can be inserted through the greater sciatic notch with one tip on the quadrilateral surface of the ischiopubic fragment near the pelvic brim. Palpation of the obturator canal through the greater sciatic notch is an aid in directing a lag screw across the transverse fracture towards the anterior column. The lag screw hole is started with a 3.5 millimeter drill bit at the level of the greater sciatic notch, but lateral to it. The screw is directed towards the superior pubic ramus. The femoral head is distracted during drilling to visualize the joint and avoid joint penetration. 2.5 millimeter drill bit is used to complete the threaded hole. The drill bit is seen to exit near the pectineal eminence. An ideal direction of the drill bit that follows the axis of the anterior column is not possible through the Coker-Langenbeck approach. The depth is checked and a 3.5 millimeter cortical screw inserted. The second 3.5 millimeter cortical lag screw is inserted near the border of the greater sciatic notch and just above the transverse fracture site. The 2.5 millimeter drill bit exits the bone on the quadrilateral surface of the ischiopubic segment. After length measurement, insertion of the lag screw. Joint with the release of traction, and the posterior wall is reconstructed beginning with the free fragment of cancellous bone and cartilage. This fragment will be held in place by the overlying posterior wall fragments. The posterior wall fragments attached to the hip capsule are now reduced into position and held with the ball spike and at times a periosteal elevator. These fragments will be fixed in place with a 3.5 millimeter cortical lag screw. A 3.5 millimeter gliding hole is drilled into the fragment, followed by...
So this part is the same as we observed in the last video, so we will skip that. And we will move to another video which will show us part of how to... How to reduce a T. And how is that different, or usko thoda differently approach kaise kar sakte hain.
Tectal T-shaped fracture operated through the extended iliofemoral approach. To perform the extended iliofemoral approach, the patient is now in a lateral position with the greater trochanter up. The foot is in this direction. The head is in this direction. And the surgeon stands in front of the patient. The tensor fasciae lata muscle and the gluteal muscles are reflected posteriorly from the lateral aspect of the iliac wing. The greater sciatic notch is exposed and the tip of a retractor inserted. The posterior column is exposed as with the Coker-Langenbeck approach, and a retractor inserted into the lesser notch. The external aspect of the bone is now visualized, including the ischial tuberosity, the retroacetabular surface, and the ilium. The hip capsule can be opened near the rim of the acetabulum to give access to the joint. The anterior column exposure can be increased by detaching the rectus femoris from the anterior inferior iliac spine, as well as the sartorius and inguinal ligament from the anterior superior spine. The abdominal muscles and the iliacus are detached from the anterior portion of the iliac crest, which allows exposure of the internal iliac fossa and pelvic brim. For this exercise, we'll use part of the 3.5 instrument set. These are the instruments needed for the insertion of the 6 mm shank screw. For reduction, we use the Federberth clamp and the oblique small reduction forceps. The template serves as a model for bending the plate with the bending pliers for reconstruction plates and the bending iron. The pelvis is then placed in the lateral position in the vise. A 3.5 mm reduction screw is placed into the posterior column. A hole is drilled with a 2.5 mm drill bit and the depth measured. A screw 4 mm longer than the measured length is inserted with the head left proud. Another 3.5 mm screw is inserted proximal to the fracture site and opposite the first screw. This screw is shorter than the measured length so that it does not protrude into the posterior column fracture site. A 4.5 mm hole is drilled in the groove between the posterior rim of the acetabulum and the ischial tuberosity. The depth is measured and a 6 mm shunt screw is inserted with the T-handle chuck. This shunt screw will control rotation of the posterior column along its longitudinal axis. The Federberth clamp is applied to the 3.5 cortical screw heads. The posterior column fracture is now reduced by simultaneously manipulating the Federberth clamp and the shunt screw. The posterior column fracture is initially fixed with a 3.5 mm cortical lag screw. The 3.5 mm bit drills the gliding hole. The 2.5 mm bit drills the threaded hole. The depth is measured and the screw inserted. The typical lag screw exits the quadrilateral surface. Now the Federberth clamp and screws can be removed. It is always necessary to check the reduction on the quadrilateral surface by palpating through the greater sciatic notch. A 6-hole straight 3.5 mm reconstruction plate will be contoured and applied to the posterior column fracture site. The bending template may be used. The plate is contoured with a curve parallel to the rim of the acetabulum. A 2.5 mm hole is drilled in the distal plate hole, the depth measured, and the 3.5 mm screw inserted. Screws are placed in the other plate holes as required to achieve good fixation. It's useful to drill 1 or 2 screw holes eccentrically in order to achieve some compression at the fracture site. The surgeon is now anterior to the patient for visualization of the anterior column fracture site. A 3.5 millimeter screw is placed on each side of the fracture site near the acetabular rim for the purpose of fracture reduction. The 2.5 millimeter drill bit is used. The Federer clamp is applied to the protruding screw heads and the anterior column fracture is reduced. It is typically necessary to also place a pointed tip reduction forceps from the pelvic brim to the outer aspect of the ilium in order to complete the reduction. 2 long 3.5 millimeter lag screws will be placed down the long axis of the anterior column for fixation. The direction of the screws inside the bone is shown. The screw starts on the external aspect of the ilium. The point of insertion is just posterior to the anterior pillar of the iliac wing and 3 centimeters proximal to the rim of the acetabulum. The distance from the rim of the acetabulum is slightly greater than the width of one's thumb. The anterior hip capsule is opened and the femoral head distracted to visualize the articular surface and thereby avoid joint penetration. A finger along the anterior column can also help in directing the drill bit. The 3.5 millimeter drill bit is used to drill a gliding hole in the proximal fragment. The hole is completed in the distal fragment with a 2.5 millimeter drill bit. The direction of this hole must be very precise for the screw to stay within the anterior column and not enter the joint. If the direction of the drill is perfect, the drill would exit the anterior column almost at the symphysis pubis. The length of such a hole is approximately 130 millimeters. The depth is measured and a 3.5 millimeter cortical screw inserted. 3.5 millimeter screws are useful because the drill bit and screw are slightly flexible and tend to follow the internal contour of the bone. A screwdriver placed in the initial 3.5 millimeter screw can act as a directional guide for placement of the second 3.5 millimeter lag screw. Through the extended iliofemoral approach, the hip capsule may be opened to directly visualize the articular reduction.
Okay, let's go to the video, from the video to the workshop table. We have here a model of a T-type fracture जो अभी आपको दिखाएं, आपकी स्क्रीन पे नजर आ रहा है. It has components. This is where the T is exiting in the isquiopubic ramus, and we will now fix it in the prone position. Let's do it from the posterior aspect.
So we
So
can't
the first
see
thing,
it right now.
I'm sorry. The first thing you have to do is to learn how to pass lag screws from the posterior to fix the
But I think
anterior
the video is
column.
not on. We can't see.
Sorry. आप ये मॉडल नहीं नजर आ रहा?
नहीं सर, वीडियो नहीं आ रहा उस पे.
Video is okay.
So I can see
Video is
that.
okay. I
Okay,
can
then
see.
there's
I
a
can see.
problem with me. Okay, sorry.
Kazim,
Okay.
Kazim, can you stop sharing your screen?
Okay, let me check. I think so. I stopped sharing it.
Click on the speaker view.
Close.
से हम पहले शैन स्क्रू डाल लेते हैं.
सर स्पीकर व्यू पे क्लिक करें जूम पे.
एक शैन लोड कर लें. 6 mm shan to control rotation.
शान कहाँ डाल रहे हैं आप?
इसकी टुब्रोस्टी की बेस पे.
So in the meantime you're doing, can I say 2 comments?
Please.
Firstly, when they were doing from the posterior approach, when they were fixing the transverse fracture, if you put a meta clamp in the through the sciatic foramen to manipulate the proximal portion segment of the fracture, then you can't sort of feel the fracture inside. There's no finger which can go in after putting any clamp. So you can't sort of, with the indirect reduction, it's very difficult to feel inside when a clamp is already in. And the second part is that from the anterior side or from the extended iliofemoral approach, they have denuded all the attachment from the iliac crest and the trochanteric osteotomy, and also from the inside. So that would leave the iliac, है ना, ये सारा जो iliac wing है, that would be denuded from any blood supply. Thirdly, they are also using 3.5 millimeter screws for reduction for the fab of TAM. I think it needs stronger screws for reducing it. So these are the 3 comments I want to make. Thank you.
जी बिल्कुल ठीक है. अब ठीक है, हमने यहाँ लेग स्क्रू डाला है फॉर इलियक क्रेस्ट की पोस्टीरियर कॉलम की रोटेशन कंट्रोल करने के लिए. ठीक, वो भी हम दिखाते हैं. नाउ वी हैव पास्ड एक रिडक्शन क्लैम्प फॉर द रिडक्शन ऑफ द एंटीरियर कॉलम राइट थ्रू ए पोस्टीरियर अप्रोच. We can have it other way around. Now in this model we don't have a greater trochanter, so ideal would be one and the greater limb on the greater trochanter and other on the anterior column below the T. यहाँ हमने कुछ manipulate किया है. Being in a workshop, we have taken the liberty of going through almost the lesser sciatic area into the क्योंकि हमारे पास greater trochanter का वो leverage नहीं है यहाँ पे. Now, so the first point to learn here is to be able to pass screws from posterior into the anterior column, right? With finger through the greater sciatic notch, as much as you can go, slide along the quadrilateral plate to give you the direction. Okay? So वो आप हम शुरू करते हैं, which is almost about a centimeter, 2 centimeters away from the tip of the greater sciatic notch for entry point. Or I'm rocking it also to see that my thing is not exiting somewhere in the, it did exit, so I could feel it. ठीक है अच्छा मैं अब खोल के दिखाता so ये हमने bit डाली है into the from the posterior into the anterior column right so anterior column में वो exit नहीं हुई यहाँ अभी इसको और लंबा डाल सकते थे अब हम इसको एग्जिट भी करा के देखते हैं अनफॉर्चुनेटली इट्स नॉट लॉन्ग इनफ और ये वो पॉइंट है कि यहाँ पे हमारे पास लॉन्ग 2.5 mm की ड्रिल बिट होनी चाहिए थिएटर में और आइडियली विद मेजरमेंट्स होनी चाहिए तो उसी पे आप मेजर भी कर लेते हैं वो एक स्टेप आपका बच जाता है आगे तो अभी तक नहीं आई है दैट मीन्स आई एम ऑलमोस्ट ओके अब इसको मजीद हम आगे नहीं ले जा सकते Is it out somewhere? Nice. So we are still not out. So we are almost in this point. ठीक है? So depth gauge डाल के भी मैं दिखा देता हूँ. So if you see the depth gauge, it's almost like 110 screw already, and we haven't penetrated the anterior column area from the posterior. So that was the idea here, to learn from the posterior side how to put a screw in the anterior column, provided, of course, whatever we have discussed is under 10 screw now. इससे भी लंबा आ सकता है. I think we are serving our purpose. Provided we have adequate anterior column reduction. ठीक है जी. और उसके लिए यहाँ आपकी जो if you're going following a posterior approach, a finger along the quadrilateral surface would be able to guide you towards the anterior column. The obturator oblique view would be able to guide your drill along the anterior column from posterior. So अपना C-arm view के साथ साथ आप finger की tactile sensation को मैच करते हुए अपनी ड्रिल बिट आगे बढ़ाते हैं और उसको एज रिक्वायर्ड एडजस्ट करते हैं. ये एक स्क्रू हमने ऑलमोस्ट डाल लिया. हमारे पास पावर ड्राइवर नहीं है ना थिएटर में. आई ऑलवेज यूज दैट. My supinators and pronators have become very weak because of that. उसके लिए तगड़े रेजिडेंट्स होने चाहिए थिएटर में, which we have. Sure. अच्छा एक हो गया. अब हम इससे लंबी बिट है वो जो आपकी गोल्ड I use they have a drill bit which is graduated as well as 2.5 as well as long enough to traverse to such long situations. Now I'm going to use another screw in the same direction. और वो सही कहते हैं कि आप एक स्क्रू ड्राइवर लगा लें. आरिफ ये पकड़ो in the direction, and then you about few millimeters away, again following the same principle of your line, and you can follow this screw direction. So we exited across the fracture too early, so we will need to modify our direction. Okay. Okay. We are hitting the first screw. That's okay because it was distal enough. So let's measure it. We are adequately behind across the fracture. इसको डालो. This time we are 100. You see, we were parallel to the screw. We haven't penetrated the anterior cortex yet, and we are using a second leg screw. Dr. Intikhab uses 6.5 screw here. I still use 3.5 and try to use two of them as parallel as possible. But anyhow, this same can be done with a single cannulated screw 6.5 mm or 7.3 mm, would also depend on the size of the patient also. And so if you can cross with a 6.5 or 7.3 single screw, that should be of equal strength. These are two 3.5 screws, so 7 mm बनता है, 3.5 plus 3.5, और अगर आप 7.3 का लगा दें तो वो और भी अच्छा है. इससे जरा ये होता है, if they cross they are good. They two screws control rotation also. थोड़ा सा ये मैं advantage लेता हूँ इसमें. But वो एक screw में I think compression अच्छी आ जाती है, strength अच्छी है, तो should be okay theoretically. जा रहा है? Okay, we are putting second lag screw now. तो अपने रेजिडेंट्स को मैं कहता हूँ कि डंबल पकड़ के ना सुपिनेटर और प्रोनेटर अपने बनाया करें जाके जिम में. तो जो मैं भी करता था एज ए रेजिडेंट, 10 किलो का डंबल लेके हाथ में और ओनली सुपिनेशन एंड प्रोनेशन. अगर आपने आर्थोपॉड बनना है, ये पावर ड्राइवर तो अब आया, जब हम रेजिडेंट थे ये नहीं होता था. तो ये इस तरह के लंबे लंबे स्क्रूज के लिए you know you get tired, fatigued. चलेंगे, ये हो गया अब. ठीक है, ठीक इनफ. सो दोनों स्क्रू हमारे लैग स्क्रू डाल गए हैं. ये इंटीरियर कॉलम है, जॉइंट देख लें, और हमारा अभी तक कोई इतना बार नहीं आया. ठीक है, सो इसको खोल देते हैं फिलहाल इस क्लैंप को. एंड वी फोकस नाउ ऑन द पोस्टीरियर कॉलम जो हमने यहाँ से रोटेशन कंट्रोल की है. और फेराबफ आपको लगाना सिखा देते हैं, या जुंगलूच भी इस तरह लगता है. सो yeah, I guess this should be a appropriate point. कोशिश करें कि आपका प्लेट के पॉइंट से हट के एक 30 का देना या 25 का दे दो. वो ये इंतखाब भाई की बात सही है. यहाँ 4.5 के एक्चुअली जो हमारे पास थिएटर में है उसमें 4.5 का ही आता है. मजबूत स्क्रू लगे तो अच्छा है. तो हमने दो छोटे स्क्रू इधर लगा के अब हम, ये फेराबफ क्लैंप है जिससे कि आप एडजस्ट कर सकते हैं. इसका मुंह बड़ा भी कर सकते हैं. इसमें ये एडजस्टेबिलिटी है, दो साइड के स्क्रू होते हैं तो आप ज्यादा खोल सकते हैं डिपेंडिंग आपने खोलना कितना है. तो अब हम लगा रहे हैं और हमारा असिस्टेंट रोटेशन इससे कंट्रोल करें, या लाइक दिस. पुश डाउन. अच्छा, ये फेराबफ में यहाँ वो लॉक होना चाहिए, इसमें लॉक नहीं है. हाँ, ये वाला दे दो. बस पकड़ के खड़ा रहना पड़ेगा. So we are engaging another clamp. This is called Munib clamp. देखें ना पीछे लॉक है ना, उससे हमें फायदा हुआ एकदम, हर चीज स्टैटिक लॉक. अब आप देख लें, फाइनल चीज ये है कि आपने रोटेशन सही करनी हो तो कर लें अभी. और कंप्रेस हो रहा है. अच्छा, थोड़ा सा मैंने इसको कंप्रेस कर दिया. ठीक है. नाउ आवर पोस्टीरियर कॉलम इज स्टेबलाइज्ड, कंप्रेस्ड विदाउट एनी रोटेशन. यहाँ एडजस्टमेंट करनी है तो आप कर लें, कंप्रेशन करनी है तो इससे फेराबफ क्लैंप से आ जाएगी. और आप दोबारा उसको अंदर फिंगर डाल के पैल्पेट करें और फील करें कि कोई स्टेप तो नहीं है. स्टेप है तो एडजस्ट करें. ठीक है ना. तो अभी तो हम मॉडल में बेसिकली ऑब्जेक्टिव ये है कि हम इसको अब नेक्स्ट ऑब्जेक्टिव ये है कि अगर हम इसको लैग कर सकते हैं तो पोस्टीरियर कॉलम को भी लैग कर दें, वो चीज फिर प्लेट के नीचे आ जाएगी।
Masood, is there a preference for to doing the anterior column first or the posterior column first?
ठीक है, ओके जी सर, दोबारा क्या कहा?
Is there a preference to do the anterior column or the posterior column first? You can do
वो मैं तो
anywhere.
अपनी प्रेफरेंस बता रहा हूँ, क्योंकि आप इंटीरियर से फारिग हो गए, पोस्टीरियर तो आपके सामने ही पड़ा था, तो इसलिए तो मुश्किल काम आप पहले कर लें, उसको रिड्यूस करना और स्क्रू डालना 38 35।
AO says to go for anterior column fixation first, then posterior.
वो एग्जैक्टली प्रिंसिपल तो यही होना चाहिए कि जो सबसे पहला काम तो रिडक्शन है। हमने पोस्टीरियर की भी अंदाजा लगा लिया था रिडक्शन, तो और फिर हमने उसको रिड्यूस किया एंटीरियर को, उसमें स्क्रू डाले, और अब हम करते हुए पीछे आ गए, पीछे पोस्टीरियर कॉलम में लैग स्क्रू डाल रहे हैं, तो वो आगे। अच्छा, एक should be enough theoretically in this model, क्योंकि अगर आपको जरूरत है तो आप 2 डाल लें लैग स्क्रू इन द पोस्टीरियर कॉलम, और फिर ये स्क्रू निकाल लें, फिर अब आप खोल लें अपना खुल गया। तो अब हमारा इसको भी निकाल लो, ये टी क्लैम्प को भी, अपना शैन को भी निकाल लो, तो हमारी फिक्सेशन रीजनेबली स्टेबल हो गई है। पकड़ना जरा, सॉफ्ट मॉडल है हमारा। कोई अगर अब यहाँ जरूरत है तो देखें, आपको मैं दिखा, थोड़ी सी मूवमेंट नजर आ रही है, क्योंकि जाहिर है वो मॉडल में स्ट्रेंथ अशरफ भाई जो बनाते हैं 80 साल की औरत का मॉडल, तो अब मैं इसी स्क्रू को यूज करते हुए एक और स्क्रू भी डाल सकता हूँ, प्रोवाइडेड कि मुझे जरूरत महसूस हुई है कि पोस्टीरियर कॉलम में फिक्सेशन और चाहिए, मैं और उसको लैग कर दूंगा। ठीक है, प्लेट ने तो सिर्फ न्यूट्रलाइजेशन ही काम करना है। 40 के दिन या 38 35। तो वही स्क्रू होल मैंने यूज करते हुए उसकी डायरेक्शन बदल दी और उसको मजीद लैग कर दिया। जा रहा है? So we are there. Now it's a rigid setup. 2 screw posterior में, 2 anterior में, it's reasonably rigid setup. अब हमें सिर्फ recon plate लगानी है, जो कि अब आप देखें कि यहाँ से थोड़ा screws penetrate किए हैं, लेकिन वो एक neutral जगह है quadrilateral plate पे, जहाँ कोई इतना vital structure नहीं है। जाहिर है उसको भी छोटा किया जा सकता है screw को। So this is our reduction. Our joint is does not have any screw penetration, metal penetration नहीं है, और reduction हमारी reasonable है इस model के हिसाब से, and reasonably rigid, right? It's not moving like the way it was. Anterior column, posterior column ठीक ठाक है। अब आप प्लेट लगा लें, जो पहले हमने सीख ली है, उसको दोबारा करने की जरूरत नहीं है। वो किधर की बेंट प्लेट पिछली? हाँ, ये वाली, ये दोबारा उसकी बेंडिंग वही है जो पहले आपको बताई है। ये 2 ऑपोजिट डायरेक्शन में बेंड होगी और इधर लग जाएगी। ठीक, इन स्क्रूज से जरा सा हटते जाएं और आप लगा दें एज अ न्यूट्रल।
How many screws on either side? How many screws on either side of fracture?
2 on either side of the fracture. 2, at least 2. So ये 2 डिस्टल पे इस्कियम वाले और ये 2 डिस्टल पे प्रॉक्सिमल पे इलियम वाले, ये वाले। So I think that was the essence of this workshop. The objective number one is reduction of both anterior and posterior columns. Objective number two is to be able to reduce with is to be able to fix with lag screws depending on with the opposite column depending on the approach you have. We acquired a posterior approach, so I fixed the anterior column first, lagged them with at least 2 screws or one 6.5 or 7.3 big bolt if possible, and then fix the posterior column also with 2 smaller lag screws. And now final thing would be posterior neutralization plate, जो कि हमने सीख लिया. So this is a T fracture now fixed in front of you. ठीक है जी? Any comments or any suggestions? इसी चीज को आप एंटीरियर से भी कर सकते हैं, इसी को आप स्टोपा से भी करेंगे. स्टोपे में बहुत अच्छा नो डाउट आपके एक्सपोजर मिलता है ऑल द वे, जो उमैर कह रहे थे जैसे कि आप यहाँ से जाएंगे पोस्टीरियर कॉलम को ऐसे उठा लेते हैं ऊपर को, तो वो एंटीरियर तो आपके सामने होता है, पोस्टीरियर भी स्किल स्पाइन तक का ऑलमोस्ट विजन आपको नजर आ जाता है, और उसके नीचे आप इंस्ट्रूमेंट डाल के उसके जरा साइड पे आप हुक डाल के उसको ऊपर उठा सकते हैं, जो पॉसिबल होता है. और फिर आप यहाँ से क्वाड्रिलैटरल प्लेट के जरिए एंटीरियर कॉलम को लैग कर लें, पोस्टीरियर कॉलम को लैग कर लें और एंटीरियर सी प्लेट यहाँ लगा लें. ठीक है ना, जो गैविन ने जैसे बताया. सो इसको यहाँ रोकते हैं, अभी हो गया टाइम 2:30 बज गए हैं. सो लेट मी सी द प्रोग्राम अभी क्या रहता है. तो अभी हम आगे अभी बाई कॉलम पे जाना है, वो एक बड़ी दुनिया है, उस पर डिबेट है, उसकी वर्कशॉप है, कोशिश करता हूँ उसकी वीडियो भी मिल जाए, अभी है नहीं मेरे पास. लेकिन अभी ब्रेक फॉर नमाज करते हैं, आधा घंटा, 2:30 बज गए हैं तो 3 बजे मिलते हैं. वी ब्रेक फॉर हाफ एन आवर फॉर नमाज एंड जोहर एंड वर्किंग लंच, तो 3 बजे इंशाल्लाह मिलते हैं. थैंक यू. Assalamu alaikum. Let us start the post lunch and namaz session. Sharif told me that we are running 2.5 hours late. I said, okay, we'll see. We'll try to skip some. We may have to skip some, but let's see. अच्छा जी, बिस्मिल्लाह करें। अब हम डिबेट 4 की तरफ आ गए हैं। तो ये डिबेट वो सिर्फ लेग स्क्रू फिक्सेशन वाली सही नहीं हुई, क्यों नहीं? वो भी इसमें शोएब साहब नहीं थे, बाकी 2-3 हो गए उसमें। ट्रांसवर्स फ्रैक्चर की डिबेट हो गई। अब हम डिबेट 4 में जा रहे हैं, जो कि बाई कॉलम फ्रैक्चर के बारे में है। तो सबसे पहले उसके ओपनिंग करेंगे डॉक्टर नासिर विद व्हाट इज अ बाई कॉलम फ्रैक्चर, ठीक है? फिर हम उसको आगे लेके चलते हैं। सो डॉक्टर नासिर, ओवर टू यू सर।
Okay, ji. Bismillahirrahmanirrahim. Assalamu alaikum. So my talk is only about the introduction of bicolumnar fracture. What are these fractures? And the treatment part will be taken by my colleagues, which will have their debate after that. So a bicolumnar fracture is obviously is a well-known entity. This is a very good study which I have found, although a little bit old, but gives us a very good insight of the incidence of these kind of fractures. It was published done in Edinburgh and was published in JBJS. It's a prospective study of 351 patients done from January 1988 to December 2003, and showed that every three people out of 1 lakh per year, that's the incidence of the acetabular fractures. And the bicolumnar fracture itself accounts for 20% of all acetabular fractures. What they have found is that the fall from height is the most common mechanism of these. And over a period of years, they have found that the mortality rate for these kind of fractures is decreasing. That is because of obviously good healthcare system and things and innovations which is available. The osteoarthritis incidence in the acetabular fracture has also been seen decreasing from 31% to 14%. It was till 2003. So now I believe that it would have decreased in the last 15 years. And it is because of the good training and subspecialty training and identifying the type of the fracture and its treatment. So I'm not going to go into detail of the column concept because it has already been discussed a lot of times. But if we see into the associated type of fractures, we can see that all type of associated fracture actually disrupts the both column along with. But it is only the true bicolumnar fracture which causes the dissociation of the articular surface from the axial skeleton. And no part of the acetabulum, if we can see over here, is attached to the axial skeleton. However, in all the previous 4 types, some part of the acetabulum is there, which is communicated with the axial skeleton. So that is by definition, the true bicolumnar fracture is the one in which no part of joint surface remains attached to the stable proximal part of the iliac wing and axial skeleton, such that it represents a complete articular fracture. It is formed by the association of posterior column fracture and the anterior column fracture, as we know. And it presents in variety of fracture presentation as well as variety of combination. But to combine all that, there has been a very nice study done in China in Level 1 Trauma Center, published in 2019. And what they did, they took 71 both column fractures in their institute, and they did a 3-dimensional CT scan, and then they superimposed the images over the hemipelvis, and then they saw that what is the most common type of fracture presented. So what they found is that they found 3 common lines. The one line is actually extends from anterior to the iliac tubercle and comes down to the acetabulum or the ischium. The second line, type line B, extends from posterior to the iliac tubercle and it comes down towards the acetabulum and ischium. And the type C line is the one which actually disrupts the posterior column and meets the line A or B. So when they combine the data, what they found that 90% of the fracture will lie in this Y type of area within the hemipelvis. So the A being a short type of or a low bicolumnar fracture, B being the high bicolumnar fracture, and C disrupting the posterior column. So this is how we are going to radiologically find out and assess that how it looks like. So these are the normal lines, and for bicolumnar fracture, if the iliopectineal line, which is the anterior column, the ilioischial line, which is posterior column, the teardrop, if they are disrupted, and the line is extending superiorly into the ilium or obturator fossa, it is the bicolumnar fracture. Similarly, we know in the obturator oblique view and the ilial oblique view, it shows us the full profile of the column, anterior and posterior column. If they are disrupted in these views, this is a bicolumnar fracture. So this is an example. We can say it's a high type bicolumnar fracture in which the line is extending posterior to the iliac tubercle and then disrupting the posterior column and anterior column both. And this is a very, very important sign, spur sign, which is a pathognomic sign for the bicolumnar fracture, and it occurs because of the dissociation of both columns, and then the column gets displaced, but the intact part of the ilium, which is intact with the axial skeleton, the beak of it actually shows up as a spur on the obturator oblique view. So this is pathognomic of bicolumnar fracture. In the CT scan, it is very important to know that how the orientation of the lines will be in the axial view, because a true orthopedic surgeon will always start seeing his CT scan from the axial view, and he will not depend upon 3D reconstruction, and also 3D reconstruction might not be available in all the centers as well. So the bicolumnar fracture actually is a coronal plane fracture. So the orientation will be in the coronal plane like this. The transverse fractures will be in the sagittal plane, and the wall fracture will be in the acetabular walls only. Then they will not extend superiorly or inferiorly into the obturator fossa. So this is an example. On the left side, we can see there is an orientation of the fracture line in the coronal plane. It is a column fracture. And on the right side, we can see the line extending from anterior to posterior, that is in the sagittal plane, and this is a transverse fracture. So if we combine and differentiate, the column fracture, the bicolumnar fracture will lie in the coronal plane, while the transverse or T-type fracture will lie in sagittal plane, or the T-type will be in both planes. There will be complete dissociation of the articular surface, and no acetabular fragment is attached to the axial skeleton in both column fracture, while the transverse and T-type fracture are partially articular, and part of the acetabulum will be attached to the axial skeleton. And this is my last slide, in which the algorithm has been shown that how we can identify. And because this algorithm has already been presented in a couple of presentations, I'm not going to go into details of that, but I will summarize it that if any fracture which will disrupt the ilioischial and iliopectineal line, and the fracture orientation is from superior to inferior, that is, it is extending into the iliac wing, or it is also disrupting the obturator fossa, and a spur sign is present radiologically, it is a bicolumnar fracture. Thank you very much. That's my presentation. And for further question and proceeding, I will refer it to Professor Masood Kumar.
Excellent, sir. Very well, concise, precise, in due time. Thank you. Dr. Malik Javed Saab is next. We'll talk about non-operative options for bicolumnar fracture.
Hello, Masood Saab, if Sharif can load my presentation, please.
Okay, sir. Okay. Sharif. जी सर बिल्कुल आ गई नजर आ रही.
Right. Okay. Thanks very much, Masood. I'll be short as well, because since we are running late, and a non-operative treatment of bicolumnar fracture is really, nowadays the indications for the bicolumnar fractures are much less than as before. But because most of the fractures, most of the time now, the trend is towards the operative surgery. Next, please. Now, treatment, there are different, the treatment of this bicolumnar fracture depends on various factors. If one is the patient factor, and then their fracture factors, and then the expertise available. I mean, these are the three, when you are treating a bicolumnar fracture, or for that matter, any fracture, these are the three things I think that one has to consider, the surgeon has to consider, whether what is the patient like, and what is the fracture like, and what is his own expertise like, whether he will be able to take it on. Next, please. Now, if in case of patient factor, I think age is the most important factor. If the patient is very old and is fragile and you know, is not very mobile patient, I think then one has to be very cautious about operating on this patient, and so one has to opt for the non-operative treatment if other conditions also are, you know, satisfying. Now, the pre-injury activity level is important, and medical comorbidity is important. In old people, you know, there are other conditions. These people do suffer from other, you know, cardiac condition or pulmonary condition or other problem. So whether to see whether they are fit for such kind of surgery, and then in associated injuries, if there is a high velocity injury, especially in young people, they may have other associated injury which may need some time to actually sort it out, and during that time, that patient will have to be treated as non-operatively till you know, till things become favorable, or the situation becomes favorable. And then one has to also look at the functional demands of the patient as well, whether the, you know, what is the functional demand, if the patient was already as a bed-bound patient, or, you know, a bed to chair, or just a, in a household ambulant or a community ambulant. Right. Next, please. Now, then the fracture factors, if there is a, you know, undisplaced fracture, which by definition is not a bicolumnar fracture, bicolumnar fracture are usually displaced fracture, but if it is, you know, very much undisplaced, so one can treat it non-operatively. And then in bicolumnar fractures which have secondary congruency, we'll come to that, what actually secondary congruency means, then it will qualify for non-operative treatment. And severe osteopenia, if the bone is very osteoporotic, then and of course, if the patient doesn't want it, and the patient, you know, doesn't want surgery, so that is also a factor for the non-operative management as well. Next, please. Right. So other non-operative management, if the patient has pre-existing arthritis of the hip, so if there is severe arthritis of the hip already, so one may, you know, go for the non-operative till the fracture heals, and then one can go for the total hip replacement, or total hip replacement if conditions allow. And then there are some local soft tissue problems, like there's a big moral level lesion. If that's there, and it doesn't really allow to surgery, then one has to go for non-operative treatment. And if there is an open fracture, which is again open fracture, one has to go for the non-operative treatment till the conditions are okay, or the, you know, the wound has healed, and everything, there is no sign of an infection. And then one has a suprapubic catheter. So in that case, I think the inguinal or SOPA approach will be contraindicated, or the anterior approaches will be, one has to only have posterior approach, and the fracture may not be able to be controlled. One may not be able to control the fracture through only one approach. So in that case, again, the non-operative management will be the best option in that case. Next, please. Next, please. Right, these are just few pictures of the bicolumn fracture as, and then this is the next. Right, next one, please. Next. Right, so this is the, I just wanted to show you the picture of this. This is the big bruise over the lateral aspect of the thigh, and this is a moral level lesion, which is a localized area of subcutaneous fat necrosis over the lateral aspect of the hip. So operating through it has been associated with a high risk of infection. Next, please. Next, please. And then whether you need to see whether there is a congruity of the fracture. The curve of the femoral head, normally it should fit exactly into the dome of the acetabulum in all three radiographic views. So Mata has recommended use of roof arc measurements to measure this incongruity. I think we've been through this. Next, please. Next, please. So roof angle, one has to measure is an estimation of amount weight-bearing dome involved in measurement on all three radiographs with the leg out of traction, and medial roof angle measured on the AP view, anterior roof angle measured on the operator oblique view, and posterior roof angle measured on the iliac oblique view. Next, please. Next. Right, so this is the way how you measure it. Next, please. Next. Next, please. Right. So this was the paper that actually is written by Mata, and he recommends that criteria for non-operative treatment would be in any acetabular fracture would be. Go back, please. Right. Okay, so non-operative treatment of bicolumnar fracture, there's the secondary congress sorry. So criteria for non-operative treatment according to Mata is CT subchondral arc is intact in the superior 10 millimeter of the acetabulum. Femoral head remains congruent with the superior acetabulum in AP and 45 degrees oblique views, and there is no evidence of posterior hip instability. Next, please. Next, please. Next. So, and there is, but in case of, go back, please. Go back, please. Yes. So there is a concept of this secondary congruency in bicolumnar fractures. The bicolumnar fracture, as we just heard, they are very complex fractures, and the acetabulum is actually floating. So there's a large articular fragment. They are displaced, and they are actually rotated. And this displacement of fragments, they are displaced and they rotate, but they maintain congruency with the femoral head, and they have parallelism with the femoral head. So the femoral head is still in contact with the articular fragments, and there may be a gap of about 3 to 4 millimeter, but still the major part of the head is in contact with the articular surface. This is called as the secondary congruency principle. So it has to be congruent again on all the 8 views of the femoral head on the AP, iliac, and operator view. Next, please. Next. In this case, there is a fracture there. On the right side, you see there is a fracture exiting through the iliac crest area, and there's a fracture through the acetabulum. And so this is a bicolumnar fracture. And if you look at the other views, the head is in contact with the articular surface both superiorly as well as medially. Similarly here, so this will be this view, and there is the gap. It doesn't look that much. So there is this concept of this is the concept of this secondary congruency. Next, please. Next, please. Right, again, so this is just a CT scan view, which Dr. Nasser has already showed. Next, please. Next, please. So the treatment, the goal of the treatment is restoration of the articular surface and prevent post-traumatic arthritis, and to mobilize the patient as early as possible. This is in general, this should be the goal of our treatment in any treatment, but whether we can achieve this in case of bicolumnar fracture. Next, please. Next, please. Right, so as far as the management is concerned, the ATLS protocol has to be followed as in any other case. Then non-operative management of this will be to see whether the hip is is in place or is it dislocated. If it is dislocated, so first it has to be reduced. The hip has to be, the patient may be put on a skeletal traction to allow soft tissue healing, and to maintain leg length, and also to maintain the femoral head reduction. Next, please. Next, please. So bed rest is necessary in the acute injury phase. Mobilization as soon as the symptoms would allow. I mean, when the patient can weight bear or patient can actually mobilize. and it should begin with touchdown partial weight bearing radiograph at frequent intervals to actually see so that the fragments do not get displaced during the during the during the treatment, and if it does, then the strategy might have to change. So the secondary congruency principle must have to be retained and maintained through the treatment. So gradually progress to full weight bearing when there is adequate fracture healing, usually by 6 to 12 weeks. And during this treatment, joint mobilization should start as soon as the patient is able to move. Next, please. Next. All right, so traction with traction table or just by manual traction, and they normally a supracondylar pin is passed in the femur, and about 10 to 30 pound of weight is hang over the end of the traction, and the traction is usually up to 8 weeks, and ciliary X-rays are being done. Next, please. Next, please. Thank you very much. I think this was a short overview of the non-operative treatment. Usually, I mean, nowadays you see it very rarely, non-operative treatment done. But anyway, for some cases which are where it is indicated, I think this is a good way out. Thank you.
Gee, thank you, Malik Saab. I think quite comprehensively covered the indications for a non-operative management of a bi-column fracture and the principle of secondary congruency. We now move on. Next is Dr. Naveed of bi-column fracture treatment. We'll have two options now in the next two talks, one through ilium-guinal approach and the another one through modified stop approach. So first will be Dr. Naveed through a by ilium-guinal approach. Dr. Naveed, please.
Can you all see my slides?
Yes, we can.
Okay, so I will be describing briefly the ilium-guinal approach, and obviously can't say it is a true debate to justify. Obviously, every fracture has its own indications. So, ilium-guinal approach was first described by Lutner and designed for assessing anterior aspects of the innominate bone. And there are certain anterior fracture types for which this approach is designed: anterior wall, anterior column, posterior hemitransverse, and associated both columns, certain types or certain configurations, and then transverse is already discussed previously with some more anterior column displacement than posterior column, and no posterior wall involvement. So obviously in both these categories, associated both column and transverse. So you need to, these are the kind of fractures which can be managed with a single approach depending on which side is more comminuted. So you have to read the fracture in detail, and obviously the reduction would not be direct for the other column, which is not being directly visualized in your approach. So you have to decide whether it is posterior required or it is anterior approach required based on where the more combination or more displacement lies, and whether you would be able to achieve indirect reduction or not. And again, the prerequisite is no wall component is involved on either side if you are going in for indirect reduction. So internal iliac fossa is accessible, pelvic brim is accessible, anterior wall is obviously accessible, iliopectoral eminence and caudal surface. So these are surfaces which are accessible directly through this approach, and with some modifications, exposure can be increased. And medial aspect of the ischium to ischial spine, pubic ramus, esophagus pubis, SI joint, So the position is usually supine, hip is kept flexed. It is essential to relax the soft muscle and the neurovascular bundle. Traction can be applied with a lateral pin in the trochanter or longitudinal traction manually, or maybe a special traction table. Both things are okay. So 3 centimeter incision is started proximal to 3 centimeter proximal to some pubis along the anterior spine and goes towards the iliac crest up to almost anterior third of the iliac crest. So it's a relatively very long incision. And just going briefly through the pictorial diagram on what to expect, you go through the superficial dissection, identify the inguinal canal, then further deep dissection through the fascia along the iliac crest as well, and the external ring is identified, anterior iliac spine is identified, and obviously, and it is divided into 3 or 4 distinct windows for better communication, or you can say in terms of ease of access. So first is the lateral window, relatively easy to make. And for this window, you have to dissect the abdominal fascia of the iliac crest, and then superior elevation of the iliacus of the internal iliac fossa. Relatively easy to make this window, but you need to be careful about some vessels, especially in elderly people, where the vessels may disturb directly from the iliac bone and may not be easily collapsible. So the use of bone wax may stop bleeding in those cases. So lateral window exposes the sacroiliac joint and dissects over the pelvic rim up to the upper one third of the pelvic rim. So for second window incision inside the external oblique, 2 centimeter cranial to the upper dorsal, ASIS to 1 centimeter proximal to external inguinal ring, and you need to identify ilioinguinal nerve before proceeding for the inguinal ring, and identify the spermatic cord in the male patient and round ligament in the female patient, secure it, and the sweet contents to expose floor of the inguinal canal, expose the inguinal ligament. Inside the inguinal ligament, 2 millimeter. You need to leave a 2 millimeter cuff for later repair when you are incising the inguinal ligament. So identify the lateral femoral cutaneous nerve and preserve or cut it. I mean, you can see the lateral femoral cutaneous nerve on the lateral side of the middle window. So if it is easily detectable, it is not in your way, you can try to preserve it, but sometimes it is sacrificed, so it may be okay. So now this is the most important step. So for you have to retract the neurovascular vascular structures on the vein and the femoral artery on the medial side. The nerve lies in the soft muscle, but the iliopeculiar fascia is really very adherent to the soft muscle. So this is a very important step. Once you identify the iliopeculiar fascia and you cut it along the pelvic brim, so that will expose the entire middle window and your fracture and the choroidal blade and everything. I mean, it's the most important procedure. And just cutting the iliopeculiar fascia, then most of the square will be complete. Okay. So we will use scissors, long scissors, to cut the fascia inside the fascia down to the midline of the brim, and that will connect the true and the false pelvis and will expose your fracture and the choroidal blade. So obviously after this, when the fracture is exposed, one of the problem with this approach is that you cannot dislocate the femur. So if there is marginal infection, you have to address, or you have to see for any loose bodies. You can, before reducing the fracture, you can observe or do those maneuvers through the fracture. So the anterior wall of the fracture and the femoral head, you can see through the fracture before reduction after completing the second window. So medial window in the classic description, stay on same side of the table, dissect medial to the external iliac vessels and translate ipsilateral rectus tendon. But obviously there are some modifications done with this approach. Instead of you can go more medially, and instead of using this third window, you can give a proper financial incision that probably later on might talk about for the stop approach or something that may be included in the medial side of the inguinal approach. So this is the modification. Modified stupa, move to contralateral side of the table, cross midline with the skin incision, and split the linea alba and elevate the cranial aspect of rectus insertion, and you can avoid the full tenotomy muscle completely. So mobilize the bladder and perivascular fate, identify and ligate corona mortis, which is important, and protect the upper nerve neurovascular bundle. And it enhances the exposure for if you have Davis and Davis as well, and also it will increase your exposure to the inner border of laser and greater sciatic notches. So that's how you have to behind pubic bone you have to actively identify the connection between the internal and external vessels to ligate the corona mortis. And obviously this has its own complication. It's a long incision, 2 to 5% infection rate, 2% femoral nerve palsy rate. A lateral femoral protein nerve paresis could be there, even if it is preserved, it may resolve after a year. Alternative ossification, as Dr. Umair described, is not as common as the posterior approach, but still 2 to 10% is there. And vascular injury is less than 1% if you are very careful. So obviously a lot of modification has been described. None of them obviously give you a very clear direct exposure to the posterior plane. You have to rely on your direct reduction. But modifications are basically done to reduce your extent of dissection and give you maximum exposure. I mean, more exposure to the parietal plate, maybe more exposure to the direct reduction of application of clamps for the posterior column. So one of the approaches were described as the modified alien approach, or you can see the they give more midline incision. I mean, this black line describing the conventional incision, little bit more midline, more medial incision than for modified approach. Windows are essentially the same: the lateral window, middle window, and the third medial window. And sometimes you can also describe the fourth window if you are doing more like a financial type instead of using the medial window of the alveolar approach. So one example actually showing the bicolumn fracture identified, description in both the lines in 2 different views. So once the approach is made, as I told earlier, it is possible also to deal some of the marginal infection. So if the marginal infection obviously more posterior or more involving the dome, it may be difficult through this approach, but still you can approach marginal infection indirectly through the fracture or by making some window in the iliacortical bone and doing some instrumentation and dealing with the marginal before you reduce the anterior column fracture. So there are different methods described for reduction of the anterior column fractures. You can So you can use the clamps, put the K-wires, pass long screws, apply the plate, or you can apply the plate first and do some direct reduction. So first you have to reduce the anterior column because it is in the front. In your direct square, you have to reduce and stabilize the anterior column first, and then come to the posterior column. So different ways you can utilize. You can use a simple symmetric clamps, and if bone is osteoporotic, you can use a disc as well. A ball and spike type of thing, or you can use the eccentric clamps as well to stabilize to reduce the posterior column, or even if the exposure allows, you can use the simple point reduction clamps to hold the fracture to reduce the posterior column. Obviously, confirm in different views, and then you have to pass long by screws from anterior to posterior column. You cannot apply a plate directly. You have to do indirect fixation. Fixation must. And the passage of this screw, its direction depend on your fracture line, whether it's more oblique or acute, and obviously length of screws also determine what is the orientation of fracture line. So sometimes you may need a very long screws up to 90 to 100 millimeters. Sometimes 60, 70 millimeters screw might be okay. So thank you.
Good. Thank you, Dr. Naveed. Ilioinguinal approach, the traditional approach to fix anterior-based injuries and bicolumn injuries. Next is Dr. Umair Nadeem from Lahore. He will be taking us through his experience of fixing bicolumn fracture through modified stopper. Over to you, Dr. Umair.
Sir, are we sharing my screen? Can you listen and hear to me?
Yes.
I'll be presenting my experience of my modified Stopper's approach, anterior interpelvic approach. We have had experience of 150 plus cases of fixing the bicolumn fractures with this approach. I learned it back from America in Seattle from the American faculty. And in America, I don't know the trends in Europe and others. I think most of the surgeons are now moving towards this approach because of its minimal mobility and ease of doing fixation. The goals of modern acetabular surgery, while it is hip preservation with anatomical reduction and rigid fixation, and to minimize the patient mobility in terms of pain, blood loss, and hospital stay, and also rapid return to functional activity. We all know the anterior approaches to the acetabulum. Modified stopper, it was initially designed for hernia repair by Rennie Stopper in 1975. Later, it was modified and adapted for acetabular surgery by Hershvenso and Collet et al. In 1994. The main advantage of this approach is access to the entire anterior column combined with its lateral window, and also excellent visualization of quadrilateral surface. This fracture, the fractures involving the quadrilateral plate, these are prognostically very important. So a direct access and ability to directly plate under vision this surface gives a great advantage with this approach. We can also do direct instrumentation intrapectineal plating, and in many of the cases, total brim level reduction and fixation becomes possible in a bicolumn fracture. In many cases, all you have at the end is just a 6 centimeter incision and you have fixed the entire bicolumn fracture. There is also a technique of all AIP fixation of bicolumn injuries where you can use a posterior column operate through the AIP interval, and also you can use long periacetabular screws through this approach without opening the lateral window. However, the obturator neurovascular bundle is critical and has to be protected with this approach. This is the surface, the pelvic surfaces which become accessible through this approach. You can see the entire iliac fossa, the pelvic brim, quadrilateral plate, and good reaches of posterior column become directly accessible, not just palpable, but accessible. We do a modified Stopper's approach on a totally wooden table, locally adapted wooden table, which is totally radiolucent, and we can adjust the height even. The surgeon stands from the opposite side of the injury, and the image intensifier is on the same side of the injury. And we use this bolster below the knee joint to relax the iliopsoas muscle. These are small transverse calvineal incision just above the pubic symphysis. If you have to use a lateral window, which is not necessary in all cases, you can incision along the iliac crest, just as in case of ilioinguinal approach. After the skin incision, you divide the linea alba in the middle. It is very important to go as far cephaloid as possible with this incision. Sometimes just an inch below the umbilicus, because all your medial access to all the way up to the SHI depends on the relaxation and division of these recti abdominae muscles. And also a little modification that I do is that I release the lower part of the rectus abdominis of the anteroinferior body of the pubis without dividing the rectus muscle. We're not dividing the tendon, but we release subperiostally from the anterior part of the pubic body. So this muscle complex becomes relaxed. The more relaxed it gets, the greater your access to the structures. So much so that in my last 10 or 15 cases, I have been able to achieve complete access of the anterior wall of acetabulum without using the middle window. Once you have opened this space of radius in the prevesical area, you bluntly peel off all the prevesical facial layers, and you identify the sharp posterior border of the pubis, which is called pecten pubis. Before proceeding with any dissection, it is important in this approach to identify and positively ligate the corona mortis complex. This is a vascular communication between the obturator and the external iliac circulation. 90% of the times it is venous, It is extra periosteal, but sometimes it can be significant and arterial as well. So one must be cognizant of it and take an active control of it. Once you have taken control of these vessels, you can sharply dissect the iliopectineal fascia directly over the pelvic brim without ever even approaching or ever seeing any neurovascular structure till yet, apart from corona mortis. What's needed is a bit patient and gradual dissemination of the approach. Initially, it appears that you won't have much access, but as you keep on dissecting, gradually identifying the structure, almost complete and pelvic brim becomes visible. After you have divided the iliopectineal fascia, we have this specially adapted cobra clamp, which goes below the lacuna vasculorum and musculorum all the way to the anterior wall, and this can bluntly gently put away all these neurovascular structure and iliopsoas muscle. The obturator nerve becomes visible to you. At this time, you start dissecting and peeling off these muscles very bluntly with the help of a Cobb's elevator. This you sometimes become amazed how much access it provides to you all the way to the posterior column, so much so you can feel the ischial spine through this interval. You can see the entire quadrilateral plate is directly visible. It's not just palpable, it's visible, and also you can do direct instrumentation. And this is perhaps the reason I was explaining that you can put small drill holes here and you can get a very good control of clamp. Actually, the force that is required to pull it back is much more than you are actually envisaged in the start. So I use pelvic collinear clamps through the lateral window, putting a tine over the ischial spine, and the force that I usually anticipate is much more than is required for normal common reduction. But this is possible through this interval. Sometimes you should be wary of a lower division of the internal iliac vasculature, and in these cases the dissection becomes difficult. So a good pelvic and acetabular surgeon should always be able to replan, readjust, and even to give a separate incision, whatever is good for the patient. It's not that you go just with a unifocal mind inside. When you have to fix the posterior column or have to pass antegrade posterior column screw, or if the fracture is higher exiting, you can go all the way up with the help of this lateral window. I won't go into much detail. The section is quite the same as in case of the ilioinguinal approach. You get access to the lower part of the SI joint. You have to protect the L5 as nerve root. In this way, this part of the bone becomes completely communicable to this lower part of the AIP. So actually what you do is that you're not dissecting the veins, the arteries, or the even lymphatics, which you do in the ilioinguinal approach. So risk of thrombosis of the vessels, I have had no thrombosis, no nerve injury, and no infection in my around 150 cases of modified strofa. And I have also published about this. Again, this is all the area that becomes accessible with modified strofa. Reduction techniques, we all know dynamic limb positioning, gravity, traction, and use of special clamps. I think all of us are well aware of that. In addition is this pelvic collinear clamp. This is especially adapted to modified Stopper's approach in the sense that this clamp applies a huge amount of force and in a vector that helps in anatomical reduction of the posterior column. It is not readily available in Pakistan, but when I went to America, I had a local vendor who donated it to our center, and I've had very good success with this. This is the infrapectineal plate I was talking about. If you have a quadrilateral plate displacement, and in certain scenarios where you want a direct dome disimpaction and articular grafting, and you want to do a rafter fixation, this plate is very beneficial. Not only it helps in a very stout reduction and fixation of quadrilateral plate, but it can also add to the overall stability of the construct in elderly osteoporotic patients. I will be sharing some of my cases with good results, even in 60+ old patients with this approach. This is the spring plate buttress mode. This is normally used in the ilioinguinal approach. In ilioinguinal, you have a bird's view of the pelvis. It's like you see the entire pelvis from the front. You have this impression that everything is accessible to you. But what I want to humbly say is that the actual working area, the area that brings about the results, is this one. This is here you do the dome disimpaction. This is here you apply direct plating to the quadrilateral plate. This is here you get hold and control of the posterior column. So in my experience, having direct access to this part, this working part of the acetabulum, is prognostically very important. This was just what I was telling you, that you can do combined plating in elderly osteoporotic to add to the stability of the construct. and to help in early mobilization. And I have applied this plate in a number of my patients. This is direct posterior column plating through the AIP. In certain cases where you have a pretty high exit of the posterior column, even in transverse fractures, and for certain scenario, you cannot open the lateral window for antegrade posterior column screws, or there are some other contraindications. Like I had this guy who had friction burns over the entire iliac fossa and in this region. So what I did was just a 5 centimeter incision. The entire bicolumn fracture was fixed through the 6 centimeter incision, and the posterior column was plated through the AIP. I have published my results of fixation with modified stoppers approach. This was the paper published this year in Journal of Pakistan Orthopedic Association. It had my early results with 52 patients fixed with modified stopper interval. The paper is available online, and my results were quite available to the series of those of Mata and Olson. About 80% excellent, good to excellent results in this series. You can access this paper online. I also, this technique of direct intrapectineal buttressing through the AIP for the quadrilateral surface, we have done extensive work on that. I also, my published series of 21 cases in the International Korean Journal of Hip and Pelvis, and I have reported some fascinating results with this technique. You can also access it online. So I will be briefly discussing some of my interesting cases. This was a young female, fell from the 3rd floor, and she had this true bicolumn injury. Okay, one thing I want to raise for the resident. In my opinion, and also in the modern literature, the word bicolumn fracture is kind of a misnomer. Anything that involves both the anterior and the posterior column is a bicolumn fracture. In that case, even a T-type and a transverse is a bicolumn. The words we should use for an associated both column injury, type C, is true bicolumn or true associated both column injury, because we have a complete articular dissociation in these cases where no part of the sciatic buttress communicates with the rest of the acetabular components. So this is a complete articular injury, and as in this scenario. So this is, we fixed through the AIP. Suprapectineal plate, again, the inferior pectineal plate, antegrade posterior column screw. It was a type C3 according to AO, because SI joint was also disrupted to pass an SI screw. These are oblique views. You can see on the Mata radiological grade, it was a good reduction. So good reduction always translates with good outcome. You can see combined suprapectineal, and this is the infrapectineal plate. You can see direct plating with 2 screws above and below with the help of this AIP interval. You can see a small lateral window that was used for fixation of posterior column with antegrade screws. This is my post-op follow-up after 7 months. You can see a complete healing, a spectacular preservation of hip joint space. And on Merle-Diabny score, the patient scored 18 by 18. You can see her post-op video at 6 months. She is still in my follow-up and she is doing well. Case number 2. This was also a young female. She had a motor vehicle accident. She was about 32 years old at the time. It was a low anterior column posterior hemitransverse. You can see a significant displacement. Again, the patient was approached through modified Stoppers approach. Suprapectineal plate, iliac dome corridor screw fixation of this periacetabular component, and antegrade posterior column screw. Initially, I used to pass this one 4.5 mm screw. Now I either pass a 6.5 single screw, just like Dr. Masood said, or I pass 2 screws. Depends on the extent of displacement. Again, oblique views, you can see adequate reduction. These are the X-rays 6 months post-op. All these videos are being published with patient's consent, only for academic purposes. Again, she reported no pain and almost complete return of function. This is a very interesting case, and I will be publishing it next on this. This is a patient. This is a 68 years old male. This is a very low anterior column posterior hemitransverse. You can see a positive gull sign. I hope you can appreciate this one. And also you can see a combination and almost complete displacement of the quadrilateral plate. This fracture with a positive gull sign, in the previous literature, many have even recommended a primary THR in this case. But I think the modern acetabular surgery is moving away from that. There are certain aspects of the fracture or of the fixation which, if we take care of, we can have very good results, and we can avoid THR even in these prognostically poor patients. You can see significant chondral impaction even on this oblique view. You can see this is significantly displaced upwards. CT scan also shows the extent of comminution and displacement. So this is my approach. I approach these patients through modified Stoppers approach. I passed a scan screw right at the time of the surgery, not beforehand. And we assess the joint and its reduction parameters. And this is what I have done. I approach this impacted part. You can see this cancellous impaction and this gull sign, classical gull sign. I access through a small cortical window in the quadrilateral plate and directly access it under the imaging, umbilical imaging. Can you appreciate a gull sign negation? The joint, the dome displacement has been restored, and there is a defect behind, just like it was explained for the posterior wall fractures. And not only was it grafted, but a rafter screw was placed to support this autologous graft. This dome has been completely restored. I have applied no fixation. Even then, you can see the dome is coming back to life. This was my fixation. Again, because of being an elderly patient, I applied a suprapectineal plate, a direct infrapectineal plate through the AIP interval with rafter screws supporting the graft, and this single 6.5 mm anti-grade posterior column screw. This is oblique imaging. Again, you can see I showed you iliac oblique view pre-op. Can you appreciate this fragment? It has been totally restored and the joint gull sign has been totally abolished. You can see a congruent reduction. Okay, and this screw is supporting it behind. So this happens when we go like this. This is 1.5 year follow-up for this patient. You can see there is very good joint space preservation, almost equal to the opposite side. And there are no significant changes of AVN in the femoral head. And this is the patient. These are the patients which encourage you to be fastidious, to be meticulous, and be more precise with your approach to this patient. You can have wonderful results. This patient is 18 by 18 on Merlet-Diopne score. This patient, this was already discussed case in my previous talk. I will go through quickly. This was again a true bicolumn in a young patient with significant comminution, again restored through modified Stoppers approach. It was a MATA 1 reduction. This is all the NCN we have in this patient, although it is a true bicolumn. A small suprapubic NCN and this lateral window for the fixation of the intercalary fragments of the iliac wing and anti-grade posterior column screw, like this. And this is my X-ray, almost 1 year of follow-up. His name is Ishan. He's still in contact with me and very happy with the results. He also had a pelvic ring. He had an APC opening of the right SI joint. And again, another happy patient. This was also a young patient. I will discuss case just briefly to show you that we can also pass a retrograde trans-ischial screw for the posterior column fixation when the posterior injury is below the 3 o'clock acetabular diaphragm. Instead of going antegrade, we can also pass retrograde trans-ischial screws. This is a young female. She, again, history of fall from 2nd floor. Although there is impaction, it was a T-type fracture. No, it was an anterior column posterior hemitransverse, low anterior column posterior hemitransverse. Again, fixation through modified Stoppers approach, and only 5 centimeter NCN for this entire fixation. You can see restoration of the joint and restoration of the dome. We can apply the same criteria that I explained earlier, the hip joint shift, the Marta's criteria, CT scan. You can see there is no significant gap or problem. This again is an elderly patient. It was a true bicolumn injury. Again, complete dissociation of acetabulum from the axial skeleton. Again, fixed through modified Stoppers approach, restoration of dome with the help of iliac dome corridor screw, 2 anterior posterior column screw, and suprapectineal plate. You can see reduction and fixation. Although there is about 1 millimeter gap, there is not significant articular gap. Okay, this is probably the last case I'll be discussing for modified Stoppers approach. Again, this is an elderly geriatric patient, 60 plus age. You can see gull sign, displacement of quadrilateral plate, a positive V sign of protrusio and displacement. What we do is that we again, through modified Stoppers approach, we do a dome disimpaction. You can see a complete articulation with the help direct pressure, just like in Schedger fracture, you can apply direct pressure to the autograft with the help of this plate. Not only does that buttress, but it also supports the dome in this restored position.
And then because the lower fracture was below the acetabular 3 o'clock dial position, I passed a percutaneous retrograde transiscal screw into the posterior column. Again, you can see a reduction. And this is my 6 months follow-up preserved. The graft has healed very well. And again, he's walking totally pain-free and returned to function. So a girl sign does not mean THR. I have had good results. I will be publishing my results hopefully in the near future. And there are a lot of other cases, I think, but for time constraint, I will stop here. Any questions?
Very good, Dr. Mayor. Thank you very much. The House is open for comments, discussion.
Speechless, Umair Nadeem, very well done.
Thank you, sir.
Just wanted to ask one question, that when you are fixing bicolumnar, so what is your sequence of dealing, particularly when you are passing the posterior screws retrograde from ischium to ilium? So what is your, how do you take control of that?
Okay, so I think this is a very good question. But before proceeding to my actual normal sequence, all of us know, in a true bicolumn injury, it is absolutely essential to go from proximal to distal. Never approach any other injury first, because even a small reduction of this intercalary fragment or the periacetabular fragment will lead to huge amplification of displacement at the acetabular level. So I start with fixing anatomically the iliac wing. And I think this is not a 2D reduction, this is not a 3D reduction, it is a 5D reduction. We apply axial traction for ligamentotaxis. I pass a sand screw through the ilium for coronal and frontal plate adjustment. It means every aspect of the deformity of this intercalary fragment has to be reduced. Once you have fixed this dome part, and dome corridor screw, I think this is the biggest screw you can pass in the body. This is about 140 mm, 140 to 150 mm, and it goes all the way from inferior iliac spine to posterior inferior iliac spine. It supports the dome and holds stable the entire pelvic acetabular component. After this, I reduce and fix the entire anterior column. The anterior column is anatomically reduced and fixed. Once this wing and anterior column component is totally reduced, after that I use a pelvic linear clamp or asymmetric pelvic reduction clamp for anatomical reduction and fixation of the posterior column. The spike of the posterior column is you can see in this view. You can see this entire complex. This was pretty much displaced. If you can see, this was like here in the pre-op X-rays. You have to reduce this into the axilla of the reduction complex. Then I approach it through the lateral window of the strofa. Only 4 centimeter in CN is required. You have a good trajectory control. And in AP, iliac oblique and obturator oblique views, I pass these screws into the posterior column. This is my sequence for a normal bicolumn. Now your question was for the retroischial screw. This was derived from my experience in total percutaneous fixation of bicolumn fractures. I will show just one case later on, but quickly about this screw. This is passed, this entry point is about 1.2 to 1.3 centimeter in lateral and a bit posterior from the highest point of the ischium in the AP view. Can you see this highest point? It just is infralateral to it, okay? Once you make an entry, you have to hold the leg in about 90 degree of flexion and 20 degree of abduction with the help of an assistant. One good thing that I'm lucky about at Gurki Hospital is that we have an amazing team. I have 4 or 5 residents who washed up with me. We have an integrated pelvic team who assist me, so I'm not short on men. And also because of complete radiolucency of the table with a wooden table, using image as a breeze, I have 4 or 5 trained pelvic radiographers who assist with me with these specialized screw fixations. And then again in AP view,
sorry, Umair, do you mean that this screw is put percutaneously, or is it through
this is entirely percutaneous, sir. Sir, this is percutaneous, but this is a very good question. This is percutaneous. The trajectory is percutaneous, but through the small 6 centimeter AIP interval, I am already holding my posterior column into reduction with an asymmetric pelvic reduction clamp. There is never a compromise on reduction. it was very beautifully stated by Dr. Kyle yesterday, and I loved that. Don't fix a malunion. Similarly, don't fix a mal-reduced fracture in acetabulum. You are actually generating shear. Our conservatively treated patient is better than a poorly fixed patient with gaps, and because you're not even allowing the natural ligamentotaxis to work if you fix in a wrong position. So first step is to reduce anatomically, and once you're satisfied, it takes just 6 to 7 minutes to pass this screw. The trajectory and the corridor is very narrow. You can enter here and you can actually come out of the body from this part. We can have a separate talk on this, on passing this percutaneous screw. I have a lecture we can discuss sometime later. I will just show one last case because it is interesting in the context. I think it is not in this talk, where we completely fix the T-types and transverse fracture to entirely percutaneously with an antegrade anterior column screw and a retrograde transaxial screw. I have good results with them as well.
Excellent job, Dr. Can you elaborate your disimpaction technique?
Yes, I will elaborate again. I think there are just recent papers in the last 3 or 4 years on this technique, and I think it will be a rage in the future because I am being more and more convinced that the geriatric acetabular fractures are they can. I perhaps paradoxically even have better results in this older population than the middle-aged population. I don't know why, but this is you can see the results. I will explain your answer to your question with the help of certain images. Okay, you can see the gull sign.
Yes.
It means that you have an articular impaction sometimes in the middle fossa. Sometimes this part is directly visible. Dr. Hanif, what is important is that one has to realize you cannot access this impacted part directly with the help of iliomanular. You need either an erect articular manipulation and reduction. You can never, because the obliquity and the angle with which I approach is very difficult to protect.
There's a problem with the voice, I think. I can't hear you properly.
Okay, I will repeat. I said that to be able to achieve this direct articular reduction, you need to open the stopper interval. One of my reasons for going for stopper in all the cases is that because of this this luxury of having to deal directly with this dome part. You access through the stopper interval, you realize that this is the gull sign. I have this specially small periosteum elevator. You can use a long, small periosteum elevator for this, or you can use a blunt spatula, anything. You can see this dense cancellous bone part, Dr. Hanif?
Yes. All right. Yes, yes, yes.
And you can see this articular, this chondral part. So there is no point in fixing all this if you have this remaining gull sign. It will heal with devastating arthritis. So what you do is that it is sometimes very difficult to locate this part because this is, I will show you in an oblique view, if you can bear with me. This is the iliac oblique view. You can see this articular impaction is only in the middle fossa. It's not exactly involving the anterior part of the articular cup and not exactly involving the posterior part. It is more in the central part. So your pre-op planning must tell you where to make that small window in the quadrilateral surface. Okay, because this is sometimes a very narrow corridor that you have to access, just like this. So because you might be putting the spatula in AP view, but it is not holding that fragment because in the anteroposterior domain, you are not in the proper plane. So you can see the reduction, direct articular reduction through the QP plate. Okay, so and it is important to hold this in place. I take a small wedge-shaped graft from the iliac crust and I directly implant it with the help of a curved hemostat over the chondral disimpaction and then hold it in place with this rafter screw. This is very important. This chondral stability is very important, and I've shown you results at 1.5 years.
Okay, so you use all the 3 views, AP and Judas?
With experience, you just need a single view because when I am directly approaching my QP plate, I have from my pre-op stereognosis of my mind with the 3D model that where I exactly have to enter. But in earlier cases, you can use iliac oblique and AP. Ilico-oblique will help you directly tracing the condyle impaction. You can see this part.
Yes, yes.
This is the entire prognosis in this patient, I think, rest on this fragment. And this is so central in location and difficult to locate that you can hardly reduce. And you can see in post-op radiographs, you can see the same middle fossa, complete articular congruity, and the rafter screw supporting it.
Excellent.
And because of this direct infrapectineal plating, I am holding this complex just like you hold with the help of a T-plate in a Schatzger injury. Because it's not that you just apply a rafter screw, you have to buttress the entire complex, especially in elderly osteoporotics.
So how many screws do you use for the infrapectineal plate?
Again, very good question. I think it all depends on the fracture geometry, and I think the time is short. I can go on and on. I have a number of cases where I just apply the proximal 2 screws and use the infrapectineal plate just as a buttress. You can see, even in this case, you can see only 1 screw was applied because this is not my working area. My working area is this buttress. So it depends what you're trying to achieve. If you have a fracture through the quadrilateral plate in this area, then the distal fixation with stout 2 or 3 screws is important. I can show you in the other case. I think this is a very good example of infrapectineal buttress. You can see I have applied 3 screws in this scenario because it was biomechanically important in this scenario. Sometimes I applied just a 4-hole plate all the way to this level, which is just holding back the spine of the QP. So it depends on the fracture geometry. But in general, in pelvis, sir.
These screws are applied on the pubis, while the other one you applied in the ischial spine, isn't it? These are the different places on the medial end.
Sir, I will explain. This plate is not on the pelvic brim. This is below the pecten pubis, directly applied to the posterior surface of the pubis. This is going from the posterior surface of the pubis, spanning the quadrilateral plate, and going all the way to the lower root of the sciatic buttress. Once you start achieving results, my international paper on this plate, and I have had about 80 to 90% success even in patients with gull sign.
Good. I think we have had good discussion on it now. The use of infrapectineal plate is the take-home message, and obviously reduction of the fragment articular surface, which is very much accessible through the STOPA, which Dr. Umair has very aptly described and even had a short video. I think that is the take-home message, and that I feel is a big advantage of STOPA over ilioinguinal. So hence the purpose of my keeping it as a video. Ilioinguinal definitely has its own advantages in terms of all the 3 windows and exposure, but then we have to individualize our treatment according to the fracture pattern, and all this has to be discussed and planned pre-operatively. In the interest of time, thank you, Dr. Umair. In the interest of time, we would move ahead. And if we get more time, Dr. Umair will give you more time to show your cases. You have a lovely collection. And we would love to see your failures also. Those are very important for us to learn.
Yes. Sorry to interrupt. Very, very, very important. I have had spectacular failures.
Successes are very good to show, but we need to learn from our failures. But let's move on. If we get time, we'll get back to you. Next is a video of bicolumn fracture fixation surgically. We will show that and then go to our last workshop of fixing an anterior column posterior hemitransverse fracture, application of C plate and lag screw fixation of the posterior column. But let's see the video first. Thank you.
Application 63C1 through the ilioinguinal approach. Following the completion of this exercise, you should be able to describe the pathoanatomy of the both column fracture, recognize the importance of reduction for the outcome of a both column fracture, and outline the instrumentation and the steps for reduction and fixation. The standard instruments for reduction are the Farabeuf clamp and 2-pointed reduction forceps. The special pelvic reduction instruments are the angled reduction forceps, the large reduction forceps, and the ball spike. All of these instruments have a pointed ball tip. These instruments from the basic pelvic instrument set are used to insert the 3.5 mm cortex screws. The bending template and the bending pliers are needed to contour the plate. The plastic model shows that a part of the iliac wing is still attached to the sacrum. There is also a large free fragment of the iliac wing. The anterior column fragment is connected to the articular surface, as is the posterior column. The main fracture line through the iliac wing is oblique and runs from lateral to medial. The greater sciatic notch is fractured. The distal fragment is displaced medially. There is no continuity between the dome and the sacroiliac joint. The hip capsule usually remains intact. It is attached to the anterior and posterior columns, allowing indirect reduction of the posterior column through an anterior approach when ligamentotaxis is applied. When viewed from the internal aspect, the sacroiliac joint and the iliac wing fragment that remains attached to the sacrum can be seen. Connected to the articular surface, and this is the anterior column component with the acetabular dome. It is also possible to view the posterior column component. Part of the anterior column with the superior pubis ramus can be seen as well. The femoral head is visible, or at least palpable, through the fracture of the quadrilateral surface. The anatomical reduction starts at the proximal aspect of the iliac wing. It is important to restore its normal curvature. A Fariberg clamp is used to reposition the free fragment of the iliac wing. The pointed reduction forceps is applied to reduce and temporarily fix the iliac crest. A hole for a lag screw is prepared in the usual manner, close to the peripheral border of the iliac crest. To compress the fracture line, a 3.5 mm cortex screw is inserted. The Fariberg clamp is removed. Then the small free fragment of the inner posterior aspect of the pelvis is repositioned. The ball spike is used to exert pressure, and a lag screw is inserted. Even though this fragment is non-articular, anatomical reduction is mandatory to ensure the overall alignment of the fragments. The pointed reduction forceps is removed. Now the concavity of the iliac fossa must be restored. The iliac wing is rotated internally using a Fariberg clamp. The large pelvic reduction forceps is positioned around the anterior column and the repaired portion of the iliac wing to provide additional reduction across the oblique fracture line. Care is taken not to inadvertently open the fracture on the opposite side. The pointed reduction forceps is used to maintain anatomical reduction across the superior fracture line of the anterior column. The anterior column is secured to the iliac wing with a lag screw whose trajectory begins lateral to the anterior inferior iliac spine. The screw is directed into the posterior innominate bone just lateral to the sacroiliac joint. In young hard bone, where there is good screw purchase, the far cortex does not have to be perforated. The Fariberg clamp is removed. In the next step, a short lag screw is inserted from the inner aspect of the fossa to the outer iliac wing fragment, crossing the oblique fracture line. The pelvic reduction forceps is removed. A lag screw is now inserted across the iliac crest. The reduction forceps is removed. A 12-hole 3.5 J-shaped reconstruction plate is contoured to fit the pelvic brim. The plate must be long enough to provide adequate fixation of both the posterior and the anterior fractures. This plate usually is extended to the pubic body. The bending template is molded to the bone so that the contours of the bone can be transferred to the plate. The anterior column runs from the anterior to the posterior aspect of the pelvis. It is concave, then convex, and then concave again. The bending pliers are used to contour the plate. As the primary purpose of this plate is to buttress the anterior column, posterior contouring is critical. First, the concave contouring is performed. The plate is flipped and the convex contouring is made. The curvature of the plate is adjusted by bending along its longitudinal axis. After the plate has been contoured, its profile is checked against the template. The plate is laid on the pelvic brim with the proximal end held in place using the ball spike. At the distal end, the plate position is adjusted and the plate is fixed in place with a 3.5 mm screw. After adjusting the plate position in the posterior aspect of the pelvis, a 3.5 mm screw is inserted parallel to the sacroiliac joint. The distal screw is secured. The ball spike is introduced to help improve the position of the anterior column fracture components, and a screw is inserted through the third distal plate hole. A second screw is placed in the proximal end of the plate. The large angled reduction forceps is introduced. In this situation, the short arm is placed through the second window and the long arm through the third window. The forceps is applied from the pelvic brim to the quadrilateral surface. The posterior column is reduced to its correct position. Now the posterior column is fixed by inserting a lag screw through the plate. This screw is directed towards the ischial tuberosity. The reduction forceps is removed. A lag screw is inserted through the adjacent proximal plate hole, oriented in the direction of the ischial spine. It is not necessary to fill all the plate holes with screws. Screws must not be inserted through the plate holes in the area of the iliopectineal eminence, so as to avoid the serious risk of penetrating the hip joint. Usually, under clinical conditions, the final reduction of the articular surface cannot be directly visualized. However, for this exercise, the hip capsule has been opened to allow direct visualization. You should now be able to describe the pathoanatomy of the both column fracture, recognize the importance of reduction for the outcome of a both column fracture, and outline the instrumentation and the steps for reduction and fixation.
We go back to the the workshop table, and we'll try to make a simile of a both column type injury, but actually it is posterior hemitransfer, so we will try to demonstrate the same principles on almost the same model. So let's go there. So this will be our last workshop. As you can see, says right hemipelvis broken anterior column, and then also the posterior column is broken almost like T, but since this part of the acetabulum is intact with the sciatic buttress and this area, so it will be called a posterior hemitransverse anterior column fracture. Had it been like this, dissected out, this line goes like this, then it would be a true bicolumn injury, because then the whole, by definition, whole acetabulum is detached from the axial skeleton, or at least the sciatic buttress area. So we will start the fixation. And as I mentioned, as the video also mentioned, we will start fixation from the top. So clamps first, reduction from the top. As the patient is of course supine. We have ilium-guinal daluders. So we will fix the top. We exited posteriorly, so we will retry and redirect and drop it. Yeah, good. That should be nice. Okay, we're okay. That catch. नहीं निकालो आप उधर आ जाओ नहीं छोटा होगा 60 दे दो So principle is to start from the top and then gradually go down towards the side of the joint. We're fixing the iliac blade component of the anterior column injury first. Yeah, good. थोड़ा हो गया tight हो? Yes, sir. Yeah, you can remove the clamp now. Okay, then is this component, which is, we'll reduce this, is it clamp again? We can hold it through a parabuff like this, वो थोड़ा narrow वाला. Yeah, and then go. Next step would be to इसकी rotation भी control करना जरूरी है ना. You can have a parabuff here to control rotation. So this exposure may not be there in an inguinal. You have to have a human retractor behind the anterior inferior iliac spine so that you have exposure. Now the next step is, the next important screw is from the anterior iliac spine, anterior inferior iliac spine, you have to target the sciatic buttress. हाँ, चलिए आप करें. Which is usually starts from the posterior third of it, and you have to target the sciatic buttress and remain inside the bone like this. The trajectory has to be like this. So make sure you are following the principles of drilling. Don't come out posteriorly. Usually, as Dr. Mayer also mentioned, 100, 120, even 30 type screws are doable. But if you want, take like depth gauge.
So
90.
100.
चलो ठीक है ठीक है So we don't have a vice grip. Best would be to fix the model in a vice grip so that don't require so many hands to fix at the time of fixation. But anyhow.
Prof. Masood, do you have a collinear clamp?
Yes, we have a collinear clamp, not here, but in the operating room. And actually, it's available in Pakistan. Dr. Mayer, it is available in Karachi from a local vendor who brought it from China. So, either have available.
Okay, that's very good, sir.
Can you share the details?
When I checked back in 2019, it was not available.
हाँ.
It's good, it's available now.
एक दो साल हुए हैं. So ये अब ये drill करें. We need to fix this. थोड़ा सा. Our fixation is not good. So we have come out. You see, we have come out. It's not good. So we'll revise that. And there is angle and opening at the fracture site. So these are important things to learn. इसको निकालें. We were not careful. We never looked at the back side if it's penetrating out or not.
Masood, in real thing, you won't be able to look at the back anyway. So I think there is.
नहीं वो उससे आता है ना सर जो आपका.
So we can use the image.
Oblique view है. Operator oblique को आप outlet mode में थोड़ा twist करें ना तो फिर उसमें नजर भी आ जाता है. आप within the two tables हैं या नहीं है. और
dynamic obturator oblique.
So if you have to err, you have to err on the anterior side, I would say.
The outer side.
No, yeah. No, wait.
Outer side.
You see, you will be able to see if you're doing an ilioinguinal approach. So you're seeing your drill on the inside, or even,
yeah.
Okay, we have it here. Let's apply the clamp again.
That view is also called, I think, dynamic obturator oblique view. The combination of obturator oblique and the outlet view.
It is called what? Dynamic?
I think dynamic obturator oblique view, I think.
Yeah, okay. Yeah. Okay, we have reapplied the clamp drill bit, please. So you're starting from the same point, and I think we have to err on the side of our direction has to be towards the greater sciatic notch. Let's make another attempt. This time we should check from behind.
Yeah, I think
okay.
It should be all right.
And this area is actually underexposure, so it is better to err on this side. If it comes out here, you can still push it back.
That's what
retry.
That's what I was saying. That's what I was saying.
All right.
जी वही बिल्कुल आप मेरा भी वही point of view है कि आप उसमें error कम होगी पीछे 100.
We use a combination of obturator outlet and then inlet views while passing the screw.
because in outlet view, you can see the supraacetabular tear drop, which is equal to the dome corridor. So if you have this is important in modified stop-up approach because of minimalist exposure. So I pass this screw percutaneous.
But it is almost percutaneous because इसका direct exposure नहीं आता आपको. इसका during surgery तो this is almost like you have to soft tissue full visualization of the inferior iliac spine is never there in a routine ilioinguinal approach. So you have to do a lot of Hohmann retraction और फिर almost वो through the soft tissue ही आप जा रहे होते हैं. I agree with you, Dr. Umair, के इसका अंदाजा सही करना पड़ता है. It comes with practice, I guess. So doing it without a power driver is a good exercise. Biryani bhi azam ho jayegi.
Dr. Umair, you said that you use a special retractor that you have made locally. Vendor, is it a long kind of Hohmann? Is it a long Hohmann or is it something else?
It is a special Cobra retractor.
It's a Cobra retractor, right? But with a long tip, I suppose.
It has a slight curve to it. It's actually like a Cobra, small gentle curve. And a tip, it is especially designed to take away the neurovascular structure and the iliopsoas muscle away to the anterior wall. And honestly speaking, all the instruments are local. I devised it according to our budget. Reproducibility is important.
हमारा ये भी सही reduce better. अच्छा जी, ये अब हमने देख लें पीछे से नहीं आया, आगे से भी. So we are probably within the table. We'll pass the last screw now to have this final reduction of the iliac blade. The 60 there. Yes, 65 कर दे. 60 है flower. हाँ. मॉडल का यही फायदा है कि आप मल्टीपल पासेस ले सकते हैं और लेने भी चाहिए. जो प्रैक्टिसिंग रेजिडेंट है उसको. चलो बच्चे खोलो इसको. चलें, ये हमारा टॉप कंपोनेंट ऑलमोस्ट फिक्स हो गया. अब हमने प्लेट लगानी है इधर और फिर हमने पोस्टीरियर चीज को लैग करना है. तो अभी प्लेट के थ्रू भी लैग कर सकते हैं और अभी भी एक्चुअली आप फिक्स कर सकते हैं पोस्टीरियर कॉलम को. जो है क्लैंप्स लगाने आसान है. बहरहाल प्लेट लगाते हैं. तो ये सी प्लेट है, 12 या 14 होल की तकरीबन सब में काफ़ी होती है. देखें ऐसे. उससे पहले हम इंटीरियर कॉलम को
Instead of this buttress screw, can we fix it with just with a small DCP over the anterior part, or?
जी कर सकते हैं. वो DCP तो बड़ा अच्छा हो गया. रिकॉन प्लेट लगा सकते हैं जो कि
same thing. I meant the same. Yeah. So I think that will be. Wouldn't that be easier? It will better than the. I know it's a much stronger construct would be the buttress screw is much
लगा
stronger.
सकते हैं सर, ये आप पहला स्क्रू सक्सेसफुली लगा लेना तो वो इतना मजबूत होता है, फिर आप कहते हैं यार ये जो है ना प्लेट से तो बड़ी अच्छी चीज मैंने लगा दी है। सो इस तरह हम कंटूर करेंगे। ये मैंने रिड्यूस किया क्लैंप लगा के, एंटीरियर जो कॉलम का फ्रैक्चर था। चलो एक स्क्रू लगाओ इधर। छोटी प्लेट भी ले सकते हैं, आप देखें कि ये इससे छोटी है ये तो 12
Prof. Masood, how do you contour the plate? How do you contour the plate?
7 8 1 मिनट 9 10 11 12 टेम्पलेट से करें सर। वो आमतौर पे मैंने तो ये सी वाली को तो बहुत ही कम कंटूर किया है, जो नो। और अगर बाय द बुक जाना है तो वो टेम्पलेट लेके उससे आप कंटूर कर सकते हैं।
How do you do that? आपकी टेक्निक क्या है?
मैं तो नहीं करता, वो खुद ही बैठ जाती है अपने उस पे, ज्यादातर नहीं करता। मतलब ये 3.5 रिकॉन की यही खूबसूरती है कि ये कुछ ना कुछ खुद भी बैठती है। छोटा ले लो, चलो ठीक।
I have seen Prof. Romans in Germany. He used to hammer it down, and he has the incito benders, incito clamps to contour the plate.
Okay, Hanif, I have those benders, and I think in situ twisting and torsional control of the plate contour is very important.
But sometimes you sometimes जी उसमें ओके आप बात कर लें।
I use a straight recon plate of the size that I need, and then first of all I use a spine bender. I think because of my working in a spine center, and also being a spine surgeon, I've extrapolated some instruments from the spine surgery. I use a spine bender for twisting and torsioning of the plate. First of all, I give a coronal bend to the plate and fashion it into the shape of the C. In second stage, I contour it for the iliopsoas gutter and the pectineal recess. This is bending in the second plane. And thirdly, I use, with the help of two specially flattened out screwdrivers, I bring in a torsional twist in the distal part of the plate just at the level of iliopectineal eminence and rotate it by some 30 to 40 degrees.
जी वो इन सीटू स्क्रूड्राइवर्स से तो before doing clamp मंगवा सकते हैं। अभी कैसा बेंडर होता है? I have no idea. I've never done spine.
Sir, I will send you pics. This is used for bending the TPSF rods, and this gives a very good free hand access for whatever kind of bending you want.
I cannot imagine. I've never seen it. So वो इसलिए imagination में भी नहीं आ रहा ना।
जी sir, I will share with you sir.
लेकिन वो जो है ना ये clamp वो मैं खुश करता हूँ वो।
How about hammering it down?
I do hammering with the help of ball spike pusher in patients who are not very osteoporotic for the iliopsoas gutter part. The part of the plate, the proximal part of the plate that is sitting into the iliac fossa. Hammering this plate to match the contour of the iliopsoas gutter is important, because basically you are applying a buttress plate and your fixation should proceed from proximal to distal even in this plate. So even if there is a slight contour mismatch, this can lead to opening and closing of the fracture planes either on the same side or on the opposite side. So basically the principle that I follow is that I closely follow the contour of the pelvic rim, but use selective under contouring or over contouring at places to achieve the effect that I want. Like at a certain point, I might need compression, and at the other side, I might need buttressing effect. So I think this suprapectineal plate does a lot of things, and you require quite a lot of precision in contouring and matching the contour of the plate.
In one of my case, when I hammer it down for the contouring, I lost the reduction. So I don't know what to do. What is your
Dr. Hanif, there are certain points in your fixation scheme when you use that hammer. Don't use hammer without stabilizing the construct proximally. At least pass one screw
in the sciatic buttress area, and at least provisionally hold the distal part of the plate in the pubis. Then you can use gentle hammering to precise matching of the contour.
Another technique, I devised.
Not only does that help with the reduction and fixation, it also helps in anatomical placement of the entire brim reduction. Sometimes you see the brim is reduced, but when you see the AP view, the brim appears to be underused globally, because actually while you are able to reduce the fractures and fix them, but you are unable to match the contour of the opposite brim. So with increasing experience, I try to contour it as much as possible to the brim anatomy.
Sometimes, I use the small fragment 3.5 plate holders or, the bone holders to bend it down. Sometimes it helps. But, my another problem I normally have, and this is a question from Prof. Masood and other faculty also, that sometimes, I am unable to put, the meta offset clamp into the medial window, you can say, to reduce the fracture. How to tackle with that?
If you want to pass a mortar clamp for the ilium approach, I think although in certain fracture types that is very useful, but I think the thing you can better use is that you can use a large king tong through the lateral surface of the eyelid wing, make a small incision into the abductors, pass one tine into the lateral pelvis, and then pass the lateral, the other tine through the middle window into the quadrilateral plate area while using the ilium approach.
And what to do in Stopa, modified Stopa approach?
In Stopa, use a pelvic collinear clamp or use a large king tong, as I just explained. Or in Stopa, the best clamp is the one applied directly through the AIP. If the geometry so allows, I use an offset pelvic reduction clamp through the AIP interval. But the lower tine is quite tricky, and I take it down all the way to the ischial spine.
No, yes, it's the offset one. Its angle pushes the bladder back. It is pressure, giving the pressure on the bladder.
I see a very good modular and adjustable mortar reduction clamp in America. It had a small, cogwheel type adjustment and the center pivot, and you can actually increase the offset or decrease the offset angle or go all neutral. So I think that can be helpful. What I use is that I have a big array of this clamp with all different angles and time adjustment, and sometimes you just have to go by trial and error, because you see the individual fracture geometries vary a lot, and you're right, sometimes you find difficulty in applying it.
And about infrapectinal plate.
Sir, Masood is saying something.
उस पे आते हैं इंफ्रापेक्टिनियल प्लेट पे, पहले इसको पूरा कर लें. अब हमने पोस्टीरियर कॉलम रिड्यूस किया हुआ है, तो सिर्फ जो पॉइंट ऑफ एंट्री ऑफ leg screw of posterior column through this ilioinguinal approach या lateral window और स्टोपा के साथ अगर बनाएं तो वो आप देख लें. इसी तरह ये एक्सपोजर होता है आपके पास pelvic brim के नीचे इतना, बस इससे ज्यादा ilioinguinal से इस विंडो से, क्योंकि यहाँ से फिंगर आ रही है आपकी, तो यहाँ से इस ब्रिम के नीचे से बहुत मुश्किल से ही जाती है. So again you have to rely on the iliac oblique view for your the correct placement of your bit. और यहाँ तो मॉडल में हमें आसानी है, तो हम अब जाते हैं अपना
ब्रिम से कितना दूर रखना है? ब्रिम से कितना दूर रखना है? ब्रिम से कितना दूर होगा?
ब्रिम से तो हम 1-2 सेंटीमीटर दूर हैं ऑलमोस्ट. ये जैसे इसमें आप देखें ब्रिम से मैं काफी दूर हूँ, प्लेट लगी है ब्रिम के लैटरल, फिर अब मैं उससे भी 1 सेंटीमीटर लैटरल हूँ. ये अब मैंने स्क्रू डाला है, तो ये पीछे है, जॉइंट भी फ्री है और मेरा क्वाड्रिलैटरल प्लेट में भी नहीं निकला है. सो आई एम बिहाइंड द जॉइंट इनटू द क्वाड्रिलैटरल प्लेट. और जितना मैं, ये ड्रिल इतनी लंबी नहीं है, वही लंबी ड्रिल बिट्स चाहिए होती हैं यहाँ पे डेप्थ गेज. सो वही कोशिश ये करनी है, अगर आप एक बड़ा डाल दें तो वो बेस्ट है 96.5 का या 7.3 का, नहीं तो आप 2 छोटे जरूर डालें, एक छोटा ना डालें. उस 2 छोटों में काफी अच्छी स्ट्रेंथ आ जाती है.
Prof. Masood, sometime in obese patient, it is very difficult to angle it. तो उसमें क्या करते हैं आप?
हाँ बिल्कुल, वो बस दुआ करते हैं सर, और क्या हो जाए.
acetabular surgery is very fascinating, and it keeps you fascinating till the very end.
I think the bottom line
Once
is
you're
you
into
keep
it, no other
struggling,
surgery looks as good.
and every case should be learning source of learning for you. So obese patients, obviously you modify and you innovate and you see what can be done within this circumstance of obesity and how you can manage. बाद दफा तो belly इतनी आपको तंग करती है कि आपको head down भी किया है मैंने. आप पेशेंट को हेड डाउन करते हैं कि बेली के कंटेंट ऊपर चले जाएं थोड़े ग्रेविटी से, सो फौरन आप स्क्रू डाल के फिर स्ट्रेट कर देते हैं. तो मुख्तलिफ तरीके हैं. आप होम एंड रिट्रैक्टर को इधर और ऊपर फंसा सकते हैं,
हेड डाउन बड़ी अच्छी टेक्निक
यहाँ ऐसा जॉइंट के. सो वो वक्ती तौर पे तो क्योंकि पेशेंट अंडर कंट्रोल्ड एनेस्थीसिया पे है तो वो आप कर सकते हैं. आई थिंक कोई हर्ज नहीं है. तो अब हमने पहला स्क्रू डाल लिया है, तो इस तरह के हमने 2 स्क्रू डालने हैं. ठीक है. सो उससे साइड पे उसी तरह अब हम ये क्लैंप ऑलमोस्ट निकाल सकते हैं. तो इसे आगे कर लें थोड़ा और साइड पे कर लें. अक्सर ये होता है बाल टकरा रहे होते हैं, लेकिन आप वो टकराने से पहले सीआम में देख लेते हैं. यहाँ हमारे पास सीआम नहीं है तो हम चले गए हैं. थोड़ा सा शुरू में टकराए हैं और फिर चले गए हैं. तो 1 मिनट और फिर हम पीछे छोड़ें. शुभ छोड़ें. जॉइंट भी देख लें. मॉडल में तो ये लिबर्टी है हमारे पास सारी कि हम चारों तरफ घुमा के अभी देख लें कि सीआम नहीं है. तो ये हम कर रहे हैं फॉर द बिगिनर्स जो खासतौर पे रेजिडेंट हमारे 90. अभी स्टॉपा से पहले इलिंग वाइनल सीखना जरूरी है, बाद में स्टॉपा पे जाएं. इलिंग वाइनल्स का लर्निंग कर्व ले लें और फिर स्टॉपा पे जाएं. जो है ना, मुझे अभी भी याद है डॉक्टर उमैर के जब मैं पहला अपना स्टॉपा कर रहा था तो आई इंजर्ड द फेमरल वेन. सो वो होमन से हो गई है. वो थी भी एक एल्डरली खातून, you know, about 70 plus. So we had fully flexed the hip, but despite that, I managed to injure the femoral vein. So it's quite an experience to manage that.
Stopper, you have to go very slow while making the interval.
Yes.
It is. There's a political analogy I think I should not be using here.
मैं हमेशा ये कहता हूँ कि हमें अपने इस तरह के एक्सपीरियंसेस जरूर शेयर करने चाहिए सबको, और सबके साथ एक एक दो
मैंने
तीन दिन
जब
जरूर
स्टॉपर लर्न की थी तो आई वाज इन सिएटल अमेरिका. सो आई वाज लकी कि वहाँ पे एक बायोमेडिकल वर्कशॉप थी. दे डोंट कॉल इट कैडावर एनीमोर बिकॉज इट्स जस्ट इंडिविजुअल कंपोनेंट जिसमें बड़ी वेल प्रिजर्व कैडावर्स थी. So I was able to practice it on 8 bodies in 4 days. So इधर भी आके शुरू में बहुत आराम से और बड़े केयरफुली करना पड़ा.
Cadaver is different. Human life patient
human body is very different. Yes.
Cadaver is a must before you embark on this type of surgery.
Yes, it's a good stepping stage for life surgery.
बहुत जरूरी है cadaver learning.
And also for residents, I would like to say. A good bicolumn fixation needs a culmination of individual skills. आप simple skills को एक ladder को follow करते हुए पहुंचे यहाँ पे तो फिर आपके लिए बहुत आसान होगा. Like start fixing posterior wall, simple fixations. फिर simple iliac wing के fractures को screw से fix करें. फिर simple transverse fractures पे आएं और end पे complex fractures.
चलें तो ये
सर कितने स्क्रू लगाएंगे?
ये 2 लेग स्क्रू डाल दिए मैंने. ये और ये प्लेट लगे इंटीरियर कॉलम पे. ये हमने लिए एक ब्लेड फिक्स कर दिया. ये बड़ा 120 का आमतौर पे स्क्रू आता है जो हमने डाल दिया फाइनली बटरेस प्लेट के थ्रू, फिक्सिंग द इंटीरियर inferior iliac spine to the sciatic buttress.
ठीक है.
And 2 leg screws now in the posterior column. So this is essentially of a non-complicated bicolumn fracture. This is the final fixation.
सर प्लेट में कितने स्क्रू होने चाहिए either साइड पे?
प्लेट मैंने तो कम लगाए हैं अभी. आप ये मैंने तो 3 लगाए जस्ट फॉर आप एटलीस्ट 3 इधर तो आराम से आ जाते हैं. 3 ऊपर 3 नीचे आ जाते हैं. 3 तो होने चाहिए
एटलीस्ट 3. ओके सर.
हाँ जी.
Dr. Hanif, जो literature demand करता है वो at least 2 in the region of sciatic buttress and 2 into the pubic body.
Okay.
लेकिन elderly patient में osteoporotics में आप ज़्यादा डाल सकते हैं.
अच्छा, अब जो मैंने नहीं किया अभी वो मैंने अभी अगर टाइम मिला ना तो मैं अपना फेलियर भी दिखाऊंगा, तो मैं हर दफा दिखाता हूँ. लेकिन एक हमारा पेशेंट था 80 ईयर ओल्ड, तो मैंने उसका ऑलमोस्ट टी टाइप फ्रैक्चर था और स्टॉपा में कर रहा था. तो वी वर एबल टू यूज दिस टेक्निक ऑफ रिडक्शन ऑफ द गल्फ साइन. बड़ा अच्छा हमने वहाँ थोड़ा बोन ग्राफ्ट भी पैक कर दिया. बट मैंने फिर इधर स्प्रिंग प्लेट की तरह जैसे अभी मैं दिखा रहा हूँ वो लगाई, डिस्टल रेडियस की प्लेट जो आगे से टी शेप होती है. लेकिन और रिडक्शन ठीक थी हमारी सी आर्म पे पोस्ट ऑप, तो मैंने उतार दी ट्रैक्शन. लेकिन बाद में वो डिस्प्लेस हो गया वार्ड में जाके ना विद इन 1 वीक, एंड द हेड माइग्रेटेड प्रॉक्सिमली, क्वाड्रिलैटरल प्लेट गॉट डिस्प्लेस्ड. तो फिर मैंने डॉक्टर मैर का आर्टिकल पढ़ा. He has very nicely described this technique of intrapectineal plate, sorry, जो कि डॉक्टर मैर, if I'm not wrong, अभी यहाँ मेरे पास वो नहीं है ना, प्लायर बेंडर नहीं है.
बंद कर रहे सर, इससे हो जाएगी, इससे हो जाएगी.
इससे हो जाएगी.
Sir, may I add one thing? This is a bender plier. In my hands, this instrument, मतलब ये उतनी बेंडिंग कभी भी नहीं देता जो सर रिक्वायर्ड होती है.
हाँ, वो सही कह रहे हैं आप. उसको और भी
एक्चुअली इसके प्रॉक्सिमल पार्ट में काफी ज्यादा बेंड देना पड़ता है, और आल्सो देयर इज अ टॉर्जनल ट्विस्ट दैट यू हैव टू गिव.
और एक्चुअली ट्विस्ट भी देना पड़ेगा. ट्विस्ट के लिए भी देखते हैं
ट्विस्ट की फाइन ट्यूनिंग इज वेरी इंपॉर्टेंट.
ट्विस्ट डिस्टली देंगे ना,
ये मैंने किया है जी.
Masood, may I say something? Kyle is with us as well. So we can carry on the discussion in English. That would be much better. So just to sort of attract his attention, what does he do for his plate contouring of the plate and the anteriorly? Kyle, are you here with us?
Yeah, I'm here. I think there is an art to plate bending, and some people try to bend it towards the end of the plate, and you need to bend it before you need the contour. And so I kind of start at one side and move to the other. And to be honest, it's to be used as a kind of a buttress plate. So at the end, I do want it up a little bit. But I think it takes some experience, so you certainly can do it on a model that will help you. But you'll see that if you overbend it, the problem is to kind of correct that is almost it's impossible to do. So you end up having to just throw the plate away. So it's kind of it's a little bit of a technique, and that's because of the plate material. You can't ever bend it exactly the same place. And so you have to kind of under contour it for the most part and bend it before you need it to bend. And then I think you'll be able to go from one side of the bone to the other. I think to get a better kind of contour of the plate.
So where to give the twist, Prof. Masood? Where to give the twist? Distal part, right?
नहीं दिया, वो वैसे ही बैठ के.
वैसे distal part में देते हैं.
In real time, you have to give this twist about 4 screw holes from the most distal part. This is a twist of about 30 to 40 degrees towards the posterior surface of the pubis. And also, this plate is very flexible. For individual fracture types, you can apply it in a lot of different ways.
अच्छा, ये देखें उमर,
very beautifully applied, sir. Very nicely applied.
This is in the right place.
Yes, sir, it's in the right place. Just one thing, I would like to, if I have some marker from the distal part, I would like it to be a bit more towards the brim area, because the where you have applied just inferior to it, this obturator canal. For obturator nerve, so this plate should be a bit more towards the pelvic brim. Yes, this distance should be a bit more less. Yes, just a little bit more, like 1 centimeter.
How about proximal?
Proximal is very nice.
Nice, just the bend should be more. It should be more closely applied to the sciatic buttress.
हाँ, लेकिन ये देखिए मॉडल पे तो बिल्कुल बैठ गई है, मॉडल पे
Yes,
सही
very beautiful.
मॉडल के
Nice
कंटूर
demonstration.
जाहिर है नेचुरल बॉडी का कंटूर इस तरह नहीं होता, but
In real life, the screw placement is difficult because of abdomen is in place. You have to sometimes bend the slant the hands quite a bit. So sometimes screw placement is a bit challenging. But once you experience and master it over a few cases, then it becomes easier.
So, Dr. Umar, you mean
Sir,
superior,
I would
right?
like to just add 2 points. I would like to add 2 points. I have locally made aluminum templates. You have like for 12 hole size, locally made aluminum templates. Whenever you start plating, use this template over the brim and apply pressure with your hands. Take it out and then use it as a Xerox for your actual plate contouring. 1 point. And the second point is that the plate should always match the brim shape, but it should be slightly under contoured or pre-contoured at certain places to achieve the effect. Just like Dr. Kyle very beautifully said, that if you over contour it, sometimes you say it appears that your fracture is well reduced and fixed, but in the overall global reduction is affected, and the brim reduction is also affected.
So you mean it has to be a little bit superior, right? Towards the brim.
The infrapectinal plate? No, I'm talking about overall plates. Both plates.
No. I mean the same infrapectinal plate. The one it is applied here, it should be a little bit superior, right? Little bit
superior, yes, because to avoid the obturator nerve.
And how many holes do you use?
Normally, an 8 to 10 hole plate is good enough. But sometimes I apply just 4 or 5 when I use it as a spring plate. This is pelvic collinear clamp, so this is available in Karachi now. Very good.
ये just to show the residents, this is a pelvic collinear clamp, ठीक है जी, और इसकी मुख्तलिफ attachments हैं, कम एंगल की भी है.
It's a bit way too wide for application.
It looks wide.
बिल्कुल. It's quite wide for
ये
pelvic
देखें,
application.
इसके 3 attachments हैं, ये साथ आती हैं, तो ये आप attach कर सकते हैं. तो खोलो इसको.
Is it local made, sir?
ये नहीं, चाइना है जी, चाइना है, पाकिस्तान एंड चाइना सीपैक के तहत आया है.
सर इस्लामाबाद भिजवा दें.
इस्लामाबाद तो हर चीज है सर, हम तो कोने में खड़े हैं. ये देखें, ये कम हो गया. सॉरी, ये कम.
Yes, this
is beautiful. This is the configuration.
ठीक है ना जी. और तीसरा भी मैं दिखा देता हूँ इसका. निकालो तीसरा कौन सा?
Sir, how much did it cost to you?
मेरा ख्याल है 2 लाख या 2.5 लाख का था टोटल सारा. ऐसे ही.
Masood, can I ask you? Can we ask this plate that you put below the brim? Is it a buttress mode or is it actually friction mode or is it compression mode?
सर ये तो बटरेस ही है, न्यूट्रल है. मैंने इसके जरिए कोई कंप्रेशन नहीं की है. ये वाली.
So my next question would be, instead of putting a recon plate or this DCP plate, if we can we not just put a 1/3 tubular plate, which is easier to actually mold and
mold
contour and yeah. No, but would it not be? I mean, not do the same job?
जी करेगी. 1/3 tubular बिल्कुल करेगी. बिल्कुल, I agree. वो बस इसकी स्ट्रेंथ जरा उससे ज्यादा है ना सर, ये है मसला.
Strength का issue है. दूसरा, your implant should have good malleability, strength with malleability, which I think 1/3 tubular will lack.
No, but 1/3 tubular is much more malleable than the recon plate. Recon plate has all the properties of.
But I think the recon is stronger as well as malleable.
Stronger. Its angles and its connection points are stronger.
That's why I asked whether it's in a buttress mode or is it in a compression mode. Because if it is in a buttress mode, you just need some support.
This plate is almost always in buttress mode because it buttresses the quadrilateral plate. The distal screws are just for holding it in place.
Right.
अच्छा जी, ये प्रैक्टिकल पार्ट खत्म करते हैं. लेट्स गो टू द टॉक शो. उधर आते हैं. जैसे डॉक्टर इंतखाब भी कह रहे थे, we need to chat more with Dr. Kyle now. So what I will do is skip the last two talks for a moment. We'll skip the videos. We have already covered the approaches actually, Dr. Ayaz ki talk and in the videos also. So we'll go directly to case discussion and bicolumn fracture, especially case discussion on bicolumn fractures by Dr. Kyle Dixon. So I think we have almost an hour with us, the last hour of this course, and we give the mic now to Dr. Dixon. Dr. Dixon, are you with us?
Yes, I'm with you. And let me
Great. Go ahead, please.
Let me get my screen shared and. All right, can you hear me and see everything okay?
Yes, perfectly okay.
Okay, so I do apologize because I think initially I was going to talk about T fractures as well as bicolumnar, and it looks like I'm just going to talk about bicolumnar, but I put the T fractures are already in the lecture. So if I do overlap, hopefully I'll just give you some pointers that will make things a little bit better. But this is the initial case, and I would love to see my video face, but I'm not sure how to maybe come out of, I apologize. There we go. That way I know that you guys are looking at me. And then I can show some things on the model as well. So essentially, this is a gentleman. The nice thing is the segmental loss of his left tibia kept him coming back. He's not someone that would normally come back. And to be honest, I think people that do this will tell you that their worst fractures are the T posterior wall. It actually, what Joel's worst results were. And the reason I think these are harder than the both column is you can actually have a malunion of your both column, but the two columns are reduced well. And therefore it may be rotated, but the two columns. With a T fracture, you basically have part of the column or part of the articular surface that's fixed, and you got to bring the other two to it. So to be honest, I get much more worried about T-type fractures than both column. So here's the case, and you can see kind of a T-type fracture. There's some comminution at the bottom with the ischium there that I don't really have to worry too much about. I'm more focused on the articular surface. You can see he had a previous accident with a femur fracture, and then he, as I said, he has an open tibia. So what are the indications for surgery? It's essentially, and I think these have gone over in terms of your roof arc measurement. If there's more than millimeter of displacement, any subluxation, and then posterior walls, and then we also talked about secondary congruence of the both columns. In general, I tend to approach transverses and T's through a posterior approach. If there's a delay in surgery, and Letronel's was 3 weeks, even a week, especially in a transtectal, I think that you need to do an extended iliofemoral because these really need to be anatomically reduced. They're a little bit like the posterior column. Ilioinguinal, surprisingly, comparing my results with Letronel's, I had a lot more cases where the anterior portion of the transverse column fracture was higher than the posterior. So an ilioinguinal in those cases can do that. I should state from the beginning, and I know I'm an exception to this, but the modified Stapa approach is, gave a lot of people a lot of things to publish about, and it's very sexy, and I'm not very sexy. But the idea being is my ilioinguinal, it includes a modified Stapa. So if to some degree, if I only need the modified Stapa approach, then that's all I'll do. But to me, the modified Stapa is no different than the ilioinguinal. It's just a portion of the ilioinguinal is the way that I look at it. In terms of T fractures, again, this is probably more significant because you've got a separation of the anterior and the posterior columns to some degree. But again, most of the time, you can use a Coker-Langenbach, and then I give you Letronel 72% of the time, 52% of mine. And that's probably because I did some more with the ilioinguinal, but I also had more extended iliofemoral that I did. And to some degree, I know there are a lot of people don't like extended iliofemoral because it's a pretty big surgery, but to me, it's a great way to get to both sides of the columns. What are my indications for it? Well, if it's a transtectal, and if there's significant displacement of the anterior column, and I kind of asked that question a number of times, is that anterior column high enough? Do I need to worry about it? And if I don't, if it's low enough, and based on the anterior roof arc measurements, I may just ignore it and just fix the posterior part of it, even in a transtectal if it's higher posteriorly versus anterior. I think you got to be careful with associated rami fractures and symphysis, because that then does not allow you to do the indirect reduction. So to be honest, with you're doing a Coker for a T-type fracture, you're basically trying to indirectly reduce the anterior column. And I had a little discussion on that because the modified stoppa is being used a lot more for transverse and Ts. And if you look at every one of those post-op films, there's a gap in the posterior wall. And you can't help but do that because you're squeezing it together anteriorly. In these fractures, the labrum is always damaged in the posterior side in terms of a detachment. So you can't do an indirect reduction of that posterior wall, where the opposite isn't true. So from a posterior approach, the labrum's usually fine on the anterior side, so you can do an indirect reduction. So I wanted to make sure that I was clear with that. And as you see, Letronel's class or time to use an extended was more than 3 weeks. Even a week, I have a hard time reducing it. And so Letronel may have been more better surgeon than me, but I can't make it perfect if there's more than a week delay. So to me, that's another time. You can certainly do the sequential one, ilioinguinal, Coker-Langenbach. Now, I guess I did that a lot more than Letronel did. He did it 2%, I did it 9% of the time. And that's usually because it's either planned to do it or I can't reduce the opposite column through the approach that I picked. So I went to the other. Simultaneous, it's very interesting. A lot of, we tried this, Dr. Barris and I were both in New Orleans for a while, and we both came to the same conclusion that when you're kind of doing both approaches, you just don't get the benefit of each approach separately. And so we stopped doing it. And then again, the ilioinguinal in Letronel's hand was very rare. And that was when the anterior column's a little higher. In my case, in my study, it was 10%. So how do I approach this? Well, I do the pre-op plan. I certainly choose, I draw the fracture out on the pelvis, and I'm going to just show you my pelvis. And I apologize because there's tons of different colors in it. And that's just the last week of surgery that I've done. And so the fact that I've done more of 1,000 cases that I still draw it out, I think it's important to draw out. I may be getting older, but it still really helps me to draw it out, because then I choose the approach because I'm trying to see where do I need to put my clamps to reduce it. In terms of reduction, and I'm going to talk a little bit about transverse, and this may be very simple for some people, but I'm amazed at how even very well-known acetabular surgeons do not understand this concept. And it's really the difference between a transverse fracture, T transverse, and a column fracture. And I think the important part, and I'm going to just hold this up a little bit, is they're essentially 90 degrees to each other. So a transverse fracture kind of comes up this way and almost makes a W on the articular surface. A column fracture is essentially 90 degrees to that. And so the displacement and the orientation of the fracture are very important, because if you're going to try to clamp the reduction, you've got to be 90 degrees to that fracture plane. So if you do not understand that fracture plane, you're never going to get an anatomical reduction. And for a transverse, and it's just nice that they seem to break the same way. And that's really Lettradell's whole point for his classification. But there's two axes of rotation for a transverse type fracture. So there's one axis that goes essentially a rod that's through your symphysis. So this inferior piece kind of rotates in. That's one axis. The second axis is from the symphysis to where it breaks posteriorly, and this bottom piece rotates this way. So, and I know that's hard to understand, so grab a pelvis and make sure that you understand that, because if you are operating on acetabulums and don't understand that rotation, you're not getting an adequate reduction because you don't understand how it displaces. And then the nice thing about understanding that, so I put the pelvis prone and the femur kind of sits down here, but when you put that ischial pin in, and I usually put it right next to the femur, there's two directions that you can move that kind of joystick to help you get your reduction. And if you understand the rotation, you'll understand how to move your clamp. So this, or not your clamp, but essentially the joystick. So this joystick that goes into the ischium, and I hope that I'm showing that correctly, I basically have to go distal with it, down the femur, and then away from the femur. And those are the two rotations that will correct the rotation of that transverse. And I apologize if that's simple, but I've been amazed at how many people don't understand that. We talked a lot about the lag screw and the adequate stabilization. So here's kind of a transverse posterior wall. Those, and I think we've talked about that high incidence of pre-op sciatic nerve, because you cannot have a posterior wall without some bruising to the sciatic nerve. And so you've got to be careful with it. And then essentially the T-type adds a complexity. So the T-type moves just like a transverse. The difference is there's now a fracture between the two columns, and it's almost like those, as the head pushes medially more, those columns tend to rotate around that. And so that's just talking a little bit about the rotation of the T-type. So in terms of the different types of fractures, I think the transtectal are the ones that if you don't get them anatomically reduced, you will be doing a total hip on them. And those are just some of a picture of it. So again, the transverse and the columns, they're 90 degree, the fracture planes are different than the posterior wall ones. So we can look at this fracture and we can see it's kind of a transverse type fracture with a posterior wall. Here's another one, same kind of thing. So it's up and down and transverse through it. In terms of other cases of transverse fractures where the head kind of pushes medially, I show this case, and it's not my drawing, but if this is your pre-op plan, things are not going to go well after surgery. And there's been a couple of people that have mentioned it, but the importance of anatomical reduction, I can't emphasize enough. But if you have it drawn out like this, I think this is good because you then understand it, but then you, besides having it drawn out on the fracture pattern, and you can see the detail that I've gone to, I know exactly there's two interarticular pieces, there's two posterior wall, there's even this little anterior piece. I really understand the fracture, and I can tell you probably the greatest compliment I ever got from Joel is when we were doing a case during fellowship, and I said, if you take your clamp and just move it a little bit around here, you can be more perpendicular. And he did it. And of course, the fracture reduced. And he said, you know, I've gotten lazy not coming in, but because you understand the fracture, you are able to kind of just tell me what to do. And it was amazing after I told them that, if there wasn't anybody visiting, I pretty much did all his fractures. And so he just watched. But of course, if someone's visiting, they didn't really want to come and see me operated. They want to see Joel. Here's the ones that just scare me, the transtectal transverse. And these just have to be anatomically reduced. You see that there's the trochanteric osteotomy. To me, that means that I probably did an extended iliofemoral on it. Yes, you can do them with the coker to help get around a little bit, but for the most part, from a coker, I can't see the fracture plane that goes anteriorly. And this blue line kind of shows you a little bit, but every transverse and T fracture is in this area. So if I, through the extended, I can basically put a clamp here and reduce this anatomically. I can't get to that with a coker with a slide or a osteotomy of the greater trochanter. And so there the patient is, and I think we got a nice reduction. Larry Marsh, a friend of mine, but we've argued about this quite a bit because there are, and I would think tibial plateau is a great example. I think we've all seen tibial plateaus that are reduced absolutely horribly, but they do pretty well. And so he went over all the factors that go into articular cartilage or how patients do. And it's certainly the age, the location, the cartilage thickness, the biological, mechanical things, the amount of initial joint damage. And then the one I put in yellow, congruency and reduction. All those other things we have no control over. The only thing we have control over is congruency and reduction. And so to me, that's the most important thing as a surgeon that I can do. Those other factors are true. They're out of our hands though. I love this study by Steve Olson because what he did in cadavers is he broke the acetabulum, and to some degree, doing some Fuji film and other things, you can never make it perfect. So when I say a perfect reduction, it's almost in quotation because there's a radial preload to the acetabulum. And so to some degree, and that's why I talk about the buttressing of it, because really I'm trying to reproduce that radial preload, but even in a cadaver, or an open acetabulum, he was not able to do that even with over contouring. Where are the poor results? Even more than 1 millimeter of displacement if there's any incongruency and if there's injury to the femoral head. Up until our study, either Letronel or Mata really said impaction was a problem. I do think impaction is a problem, and it may represent an increased problems with the damage that occurs to the articular surface. And so you have to be, I think, just a little bit more careful in those. And I think if you haven't read it on the chat, I kind of talked a little bit about this, but the kind of the gall sign that was initially described by Letronel was kind of bastardized by people in the literature. And he never talked about it as an impaction. He talked about it as an elevation. As long as there's cortical bone with that elevation, in his case, an anterior wall type fracture, the idea being is that you can reduce that and hold that. When there's an impaction on that medial side, I can reduce it and hold it, but for the most part, these patients end up going to a total hip. So either I'm not fixating it well enough, but I certainly put some artificial bone, some Norion in there. I put screws, I raft it, and I still have problems. And so to some degree, those are ones that I tend to fix, and then I do a total hip on at the same time. So the two components, of course, is femoral head congruence as well as reduction. And I think intraoperative C-arm is critical, although there's many parts of the world that don't have that. But I think you have to be willing to take everything down. And I think we've all seen the surgeons that, oh, that looks good enough. But you have to be very critical because you're the most important part, and you have to be willing to say, no, that's not acceptable, and take it down. In terms of the assessment, so I look at every radiograph, and it's not just the 3 obliques. I basically run the C-arm and do all the different obliques and make sure that I'm happy with the congruency of the femoral head in the acetabulum and the reductions. The other thing that I make sure is I got a view that shows all the hardware out of the joint. And that's all you need is one view to show that. And sometimes I'll take the screw out because I'm just not sure, it's too close to me. Remember, I'll never look better the next day. And so in terms of my initial look at this, and that was the first 500 cases, I ended up taking 4 to the OR because I got a CT post-operatively. And I don't always get a CT, but a lot of times if I'm reducing the opposite column, so if I'm reducing the anterior column from a Coker, or in a both column, the posterior column through an ilioinguinal, which is the most common, I'll sometimes get a CT to make sure that I don't know. Now, to be honest, I probably should have done it in all of them because it would have helped me. I don't know if it necessarily helped the patients because 4 out of 500 isn't a huge amount done, but it helps me kind of get a better look at that other column. This is a case, and so I'm the rodeo doctor. And so if you saw my picture with my cowboy hat on, but I'm really not a cowboy at all. But anyway, this lady was a professional racer. This is actually her horse, Latte. And unfortunately, this fell on her and she had a transtectal transverse posterior wall. And we're going to talk a little bit about this case. Here's her initial injury. And again, you know, it's right up in that dome. You can see where the dome is displaced there, as well as a posterior wall. So here's your CT scan, and with some comminution of that posterior wall. So we'll get to that story later, but I chose an extended iliofemoral on her, and a lot of people are scared of it, but I think if you do it correctly, you can do it without abductor weakness, and it can actually be a very nice way to reduce things. So my indications, I think most of them were both column type fractures where there was a separate U. These are some reasons why I use it in terms of a both column. But if there's a segmental posterior column, a complicated posterior wall, where I can't use an ilioinguinal, because that would be my approach of choice for both columns. These are reasons that I may do it. Again, a delay of a certain amount. So all of the fractures I draw out and kind of keep the data sheet on them, but you can see this piece right here, and I'm going to use my cursor, is basically a segmental part of the notch. I don't know how to reduce that with either a Coker, ilioinguinal, modified stappa. I think all of those in my hands, I cannot reduce that. The only thing I can reduce it is through an extended iliofemoral. And if someone knows how to fix it without doing an extended, please send me a video or something to show me how to do it, because I don't think you can do that. So here's a case, and again, this is a separate piece, and I've got a lot of lines drawn there for different fractures. It's always interesting when I look up here, you know, this is the inner fracture and this is the outer, but it looks like there's almost 4 fractures there, and that's just one fracture line. So understanding the x-rays, I think, is a good thing. Again, this is your U-type in terms of a little bit more of a iliac oblique and the different fracture lines that are present. And interestingly, this can be a real problem because it can be anterior. And of course, there's a lot of bleeders there. So you have to be very careful. A lot of times I'm, to be honest, just using a Holman to try to get that back off of the anterior portion. But a lot of times I have to pack this because there's a lot of venous bleeding in these areas. Here's the actual extended iliofemoral on one of those. One of my favorite clamps, these young Bluth clamps. And you can see by kind of getting it down, we can reduce it quite nicely. And there's some, you know, a gap there of some comminution there, but placement of the plates and eventual fixation of it. And again, the trochanteric osteotomy that I use. Here's a both column again. So a lot of times with these posterior walls, you can reach around and put a clamp on it. And usually it's the ones that are kind of up here and then they have a long piece here. And those are a little easier. When they're down like this a little bit, I don't think I can fix that through the ilioinguinal. So that's another one that I would do an extended iliofemoral on. This is another one that I did an extended iliofemoral. Now, I just had to be a little bit careful because this is to remind me to, when I disagree with Letronel or do something different, I don't know if I disagree with him ever, But Letronel never did an osteotomy, so he always took the tendons down. First part of my career, this is what I did essentially on this lady, is I took down the tendon, and we ended up doing a study and found that the trochanteric, or at least in our study, we couldn't see that the trochanteric osteotomy made a difference. Now you'll hear people doing it of the crest and of the ASIS. I don't do that because I like that to be intact for me to be able to help me get my reduction. So I do it on the greater trochanter, but I don't do it in other areas. And the question that I brought this up earlier is, do I need to reduce the anterior column? And that's especially in those T fractures, because it's hard to get to it. And is it able to get to it? And that's a lot of time getting that angled monoclamp around there. And as I mentioned yesterday, do not fix a malunion. So if you don't get it perfect, don't just run a screw down the anterior column. Yeah, those screws are cool and they make you look sexy, but if they're fixing a malunion, I think it's better just to leave them alone. So these are the factors besides whether that anterior column means, again, the contralateral rami or symphyseal. It's very hard to do an indirect reduction on those. And then of course the delay. Now I have fellows that still don't, they've been with me, they've done tons of extended and they just don't feel comfortable with it. So they'll still do 2 approaches. If you do that, just make sure you don't block that column with a screw. So you start with a coker and then you're going to an anterior ilioinguinal or modified stop approach. Make sure you don't block that column so you can still fix it. And then I think simultaneously never worked for me. I think sometimes you have to go to that next sequential, and that's generally if you can't get the column reduced, even though you thought maybe you could initially. And this is the talk about the labrum and the capsule, why you can do an indirect reduction of the anterior column from the front, but you can't do it from the front to do the posterior column. And that's just due to the fracture soft tissue injury. In terms of the timing, yes, you want a well-resuscitated patient. You've got to understand everything in the appropriate team, and sometimes it takes longer. So this lady had her injury. This was the barrel raiser, and I'm actually in scout camp with my son in the hills of North Carolina, and I no cell service, nothing. I have to walk to the the head camp counselor's office, and this is part of Boy Scouts. And this husband's on the thing, and he says he wants me to fix his wife, and I said, I'm at scout camp, I really can't do that. And I gave him Joel Mata's name and Phil Krieger, and I said these 2 guys, I would let them fix me. And I said there's not many people I would let fix me, but these 2 I'd let fix me. And so I hung up, and then an hour later, someone came and said, oh, he wants to see you back. And so I went back to the counselor, or to the satellite phone, and he said, well, if this is your wife, would you fix it? And I said, yes, if it's my wife, I'd fix it, but your wife is not my wife. Anyway, he had worked out a thing with Clint Black, I think is his name. He's a country singer that supports the rodeo, and he was going to fly his private plane, pick me up in North Carolina, fly me to Houston. I was going to fix her and then come back the same day. And so I asked my son if that was okay. He said, that would be cool, Dad, go. And so that's what I did. And so I'm not coming to Pakistan anymore unless I have a private plane, because this is the way to go. I get onto the plane, they say, no metal detectors, whatever. You walk in, there's a chef there, he makes me breakfast, and I lay down and I sleep the whole way to Houston and on the way back. So that's the only way to travel.
We'll buy it next time.
Thanks. It's ruined me for life, to be honest. So this was the surgery. We did an extended iliofemoral. I don't want to take down both of the tendons to the anterior column. So I'm always thinking about blood supply. So I'll either take down the rectus or I'll take down the sartorius, but I won't do both. We did a kind of a trochanteric osteotomy. There was a significant impaction. We used some Norion. And this is my actual EBL was 350, which wasn't bad. 5 hours, that's a little bit longer than my normal extended iliofemoral. It's usually at least, the average is around 3 hours. Now, every one of my extended iliofemorals get radiation, and doesn't matter the age of the patient or not, 750 centigrays to the abductors, because there's a 100% chance of HO. And I think Dr. Sen made this point, HO isn't always bad. It's when there's significant loss of motion that it becomes significant. But I radiate all of them. And I radiate all of them because a simple question that I asked to Letronel's radiation oncologist, I said, if your, whatever the worst age is, 11-year-old daughter had an extended iliofemoral, would you radiate them? And they said, yes. There's always a risk of radiating and then post-radiation cancer. But interestingly, I found out that if you live in Denver, which is a mile high, or up in some of the mountains of Pakistan, a year of living there, you get the same amount of radiation as 750 centigrays, just because you're closer to the sun. So all of them get radiated. So here's the actual case. And she was very appreciative. And she said, you know, she was thanking me. And I said, the only way to thank me is to get you back to the National Rodeo Finals, and then I'll come. And so that's what happened. A year and a half later, she ended up winning the, you know, both the barrel racing. She also became the cowboy of the whole contest. So she won a truck and a saddle, and so she basically won the whole thing as the rodeo. This is her. The guy next to him in the hat is me. But it was actually very nice. This study unfortunately never got published, although I put down core of 14. But I was asked the question, should we be doing an extended iliofemoral? And of course, my answer to that is yes, but I think there's complications. And I learned something from looking this study up. It never got published because I didn't spend the time that needed to do that. But the idea being is that there was a 17% infection rate. And I found that what I was doing, and that's not that I changed what I do, but it just allowed me to explain it to people. But a lot of my cases come from other orthopedic surgeons, and some of them are quite well-known trauma surgeons, and they've done a Coker and they failed, and I need to do an extended iliofemoral. And when you combine a Coker with the extended, I think that's damage, you know, potentially can be problematic. And so these were some of the complications when I looked at stuff. Interestingly, my first 7 extended iliofemorals, when I got into practice, 2 of them got infected. And of course, that made me go back to Letronel's book and find out, what am I doing wrong? Because he didn't have any infections with those. And to some degree, I had to kind of rethink about, you know, the prep of it and everything. And I don't know if I talked about that, but we'll certainly talk about that later. So here's the kind of again, a fracture pattern in terms of an anterior column, posterior hemitraverse with a posterior wall. So it kind of acts as a both column fracture because none of that articular surface is really reduced to it. Here's again, a posterior column, anterior hemitraverse. And that's actually just classified with the T-type fractures. This gentleman, you can see the callus there. So he got to me kind of later on. So my pre-op plan for T-shapes, I mean, draw it out, understand the fracture patterns. And as I said, I don't want to do extended iliofemoral, but once I understand it, and really, well, I'm not going to go over this again, but that rotation that happens with those inferior segments, make sure you understand them, because that's how you're going to be able to reduce them. And then we asked these questions already. So I'm moving on. So this was that gentleman that came a little bit late. I do use the roof arc measurements as an important thing, really to find those transtectal ones that I think need to have perfect reduction. And so we ended up fixing that one in this direction and have follow up on him. We talked a little bit about that. This was brought up a few times in terms of your anatomical reduction and how it decreases. I always hate this study because it's true. I think it's true data, but I don't ever want, if I'm delayed, not to get a perfect reduction. And so I've really kind of focused on trying to release the fracture more, which causes more vascular damage to the bone. But I think that the key to me is there's nothing worse when I'm doing a T fracture and I can't reduce it. And the reason I can't reduce it is because of the rami fracture. And so I've kind of changed sometimes what I do, and I actually kind of separate that inferior rami and clean it out. And that's usually through kind of an anterior approach so I may have to stage it, but that allows me to kind of get the reduction. My thinking on why it's harder to do is because the fracture started to heal. So here's a T-type, there's a high kind of anterior column. To me, that's, pretty easy to fix because I can get to that anterior column from the back. The impacted pieces, I think you've got to look at those because I think a lot of patients or a lot of doctors just end up ignoring those. Most of my cokers I do in the prone position because generally reducing it to the anterior column, the head that sits on that anterior column, it's easier to reduce that transverse component. And especially even with the posterior wall, it's not that you can't do them in the lateral decubitus, but it's sometimes better. This is the lateral traction bar to it. And I think one of the faculty showed that where he puts that in, and I can tell you, it's, to me, one of the caveats of trying to do good surgery here is if you can get the femoral head in the right place, it makes your life so much easier because then you're reducing it to a reduced femoral head. If you can't hold that femoral head in the right position, it's just a struggle. And these are difficult enough without using all your tips and tricks to get them reduced. So reduction, these are some of the other things that you can do it. And I think the key is getting that femoral head and then understanding the different clamps. And so this is more of a transverse, and this is the order that I do as well. So a lot of times, because of the direction of the fracture plane, this angled monoclamp to the right is the first thing that I do. To be honest, I still struggle. So I usually have the Faribault, or not the Faribault, the Youngbluth clamp. Now I usually have it turned the other direction. It's kind of facing the wrong direction in this picture. And then if I'm still struggling, and to be honest, the Youngbluth will make this posterior column like spot on. I'm like high-fiving people. And then I put my finger around the notch and I feel all the way around to the anterior column, and it's not reduced. And it's because I need this pin in the ischium, again, kind of next to the femur, and then it pushes up towards the top of the picture and then down. And if you do those maneuvers, you'll be much happier with your reduction. And I think this is just on the C-arm. And then this is the finger going around to look at it. And this is a better picture because I put the Youngbluth in the correct direction. I'd like to do it as much of a gap as possible because what I can then do is put the angled monoclamp between the center of it, as well as my finger to kind of look at it. Now, another little technical point that's a big deal. The direction of your screws is very important. So the idea is I know this posterior piece, this piece down, I can't get my cursor, down on this piece down here, I know the direction I have to reduce it. So as opposed to this top screw, I end up making this screw kind of down towards the femur, as well as also kind of angled more distally. So it almost acts as this pin to me. So it basically makes the rotation. And so there's times where I've changed the angle of the screw. And I know that sounds really complex, but the idea being is if you're making that small little change, you can get a much better reduction. And then the different angled monoclamps. And someone mentioned they do have newer ones. I still like these, and that may be because I'm just old. this is me kind of reaching around, trying to show you that you can kind of reduce the T-type fractures from the back by kind of coming in there and kind of manipulating that with the angled monoclamp. So here's a T-type with a posterior wall kind of comminuted. And this is one that we could reach around, and it's because of that bigger anterior column. The anterior column is more of a transtectal instead of a juxtatectal instead of a transtectal. And so you could reduce it even though it's quite comminuted. Again, another one. Now this one has a little bit more comminution. And so this is one that I wanted to get there front because this is a transtectal, and this anterior piece is important. And so I needed to be on both sides of the post. I needed to see both the anterior column as well as the posterior column. Again, another one that we did an extended iliofemoral, and that was just because I was kind of worried about that anterior column piece. It's essentially, the approach is basically, you know, taking off the butt from the outer terminus and then a Smith-Peterson down inferiorly, and of course gives you a lot of exposure to where you need to be. But again, I hate it. I'd rather not do it. I know it takes for a longer day. I generally put them in the lateral position to do it. Again, another extended iliofemoral. It shows you that 4 hours was that time with a 700 cc blood loss. Here's a case, head dislocated. They reduced it, and then the fracture pattern of the transverse posterior wall, T-type, and then that's the fixation of it. Again, you see the suture anchors there that I tied those things back on. Again, this one had an associated pelvis injury as well as a T-type, and as Letournel's rule, you know, start from the back and move forward. And so we fixed the pelvis first, and then we kind of moved towards the acetabulum. And again, because of the high anterior column, we did the extended and the delay. And I think that was a couple of weeks delayed from the time of injury to the time of surgery. Yeah, that was 2 weeks. So again, I think we've gone over that. I'm going to skip that. So here's one that I was talking about that really 10% of the cases, which is quite a bit. So the posterior column's low, and you see you can actually kind of get a nice reduction through your ilioinguinal of your anterior column. Now, what I kind of harped on the thing, and I'm not sure I'm totally clear with it. I understand by doing this through an ilioinguinal or a modified stappa that I can make this look like spot on. The problem is, if you really are critical, the gap where it comes out here is always a little bit wide. There's nothing you can do about that. Now, the question is that important? At least in about 10% of my cases, I said no, because I thought it was low enough and it should be okay, because I can get this column to look very great from this view, but there's always a little gap there of the posterior wall. And that's kind of what I was saying there. And I don't ever use the triradiate. I certainly do kind of a modified extensile lateral, and not necessarily the same. And again, that was kind of the one similar. Well, this was the gentleman that we started to say were the kind of the extended iliofemoral. And even though there was a nail in, we still did the trochanteric osteotomy. And you see that there's still comminution there. It's and I thought that this wasn't necessarily involved with the joint, so just a free piece there. And you see that I just kind of left this alone. And I think that some people might fix it, but again, the SI joints are reduced well. And I'm trying to look at how many. So I ended up seeing him for years, not so much because I didn't treat the tibia initially, but he eventually needed an Elizaroff. And so this is a few years later, and we're happy with that. That's the summary of approaches, and we're going to kind of skip over that with time. And remember, the pelvis is a place to work and not to play. So we're going to just talk a little bit about both columns, and Masood, you can stop me at any point if I get too long. But again, the same kind of principles. You have to understand the fracture. And to be honest, these things rotate the same thing. It's almost like a saloon door, and your head kind of pushes medially on this both column. We all know about kind of Letournel's approach to it, and depending on where that head is during the accident can give you different type of fractures. I still do the APs and the Judays, the CT cut, and I don't use a lot of 3Ds. I think they're helpful for the people that are learning it, but I think that sometimes that makes you cheat a little bit, and you don't go through the 2D CT and really understand the rotation of the fragment. So I'm okay using it, but just don't get lazy with it and make sure you do it. I love this study by Potter, and this was done with Helfet, and he did it based on what was his reason for doing the MRI? I can't even remember, but I thought it was very interesting because there was, significant numbers of contusions of the head, and the sciatic nerve, again, I said, is almost always some damage to it, 92% of it. So I think that I always warn the patients they can develop a sciatica afterwards. I put them on gabapentin for a while, and that usually helps. Again, plan out your reduction, good quality x-rays. The pelvis sets up nicely for the obliques because the wing is like 90 degrees to the obturator, and that's why those obliques work and help you see it. And also explains why sometimes it looks like it's not even displaced, but that's why you got to get your Judet views to make sure. And we've seen this a couple of times. The spur sign is kind of pathognomonic of the both column. Now you can always see it, and Letournel talked about that. It's always there in a both column. You may not be able to see it, but it's really the remnant of the intact part of the iliac wing and what you're going to generally bring to it. And so your both column tends to push both of the columns medially, and then kind of separates the two columns as well. And that's just the fixation of one. And we've talked a little bit about that. There's 4 fractures that go through both columns, but the both column is the only one where it separates all the articular surface from the acetabulum. And we just talked about that. There are ones that have secondary congruence where the dome stays, but medially. To be honest, I've operated on 92% of mine, so it's 8% where the whole column kind of moves, or I guess the whole acetabulum moves medially, but it stays together. And those are ones that you can do it. Some interesting things that you may not necessarily think about, but the anterior column is kind of where you see most of the roof with it. And where they go up, some 82% go up to the crest. I'm going to remove my thing so I can see the rest of my slides. 28% go to the inner spinous areas. Secondary fracture lines, it's very interesting. For the anterior column, it's 98% of the time. So most of the time there is one. In the posterior column, it's about 20%. So here's kind of a both column fracture. And again, looking at kind of the two columns in terms of the anterior and posterior are divided here in the secondary fracture line of the anterior column. So here's a both column that has a little bit of a posterior wall. I'm not sure I would have done that through the ilioinguinal, and this is a case that we're going to show a little bit later, so we'll talk more about that. Here's a both column posterior wall. This is the fracture that I was talking about. You can reach around with your angled monoclamp from the front, put that down, and then put a screw that essentially goes right to the posterior wall from here anteriorly and fixes that. And I think that it's kind of a direct reduction because you're putting a clamp on it, but I think you can get that well reduced. So the secondary fracture lines of the anterior column, certainly the superior root of the rami, superior rami, and then the triangular piece of the anterior column. Here's a posterior wall, and we showed this one earlier that, I didn't think I could reduce that posterior wall with that both columns, so we did an extended iliofemoral. Again, the sciatic buttress as well. And the rotation, again, as the head pushes in, kind of almost rotates those columns around. So what about the posterior column? You get a segmental pieces at 20% of the time. 15% of those are kind of posterior walls. 5% are that superior wall where you can fix those through the iliolinguinal. And I should have put some slides in there of fixing that, because I do have slides where you can reach around with the angled monoclamp. Here's one that we fixed through the iliolinguinal, and that looks like a tough posterior wall to do, but I thought I could see it enough kind of from the modified stop a portion of it and fix it. But that was a little bit challenging, and I knew that would be challenging, but I also knew I'd just roll them over and do a posterior column or a Coker-Langenbach to fix it. Again, that U-type fracture there, that I don't think there's any way to do that except through an extended iliofemoral. We talked a little bit about that. When I'm drawing out the fracture, I think, as I said, I can't emphasize it enough, but nobody likes to draw it out. But I want to, my first thing is there a column versus a transverse fracture? Because that really helps me in terms of the orientation of the fracture, and then whether a wall exists. So I start at the AP, and I look at the various places where they potentially break. And we've talked a little bit about that, and so I won't talk about that anymore. And kind of where the fracture lines are, and then eventually I'll go to the iliac oblique, and I'm going to kind of work through it. I wanted to get to this point, so I'm actually just marking where that fracture line comes out. So I know where it comes out on the crest up here. I know where there's a fracture, separate piece here, the walls, I know where they're broken. And then I basically kind of connect the lines when I'm trying to draw it out. And again, I'm using the obturator oblique to get where those fractures are, drawing that out on the thing. And then, so when I get these initial pieces drawn out, then I can kind of connect them. Why is the CT important? I really think it's for the posterior wall and the rotations of the fragment. Really, sometimes marginal impactions are hard to see on the plain x-rays. It helps me look at intra-articular. It helps me see if there's femoral head fractures, because if there's a impaction of the femoral head, I don't have a good way of fixing those. And I want to let the patient know that I'm not sure if that's going to make it so that it's very hard to do. I just talked a little bit about the two-dimensional of the CT versus the 3C. Here's another posterior wall that I thought I could maybe get that piece, and I couldn't. And so that's why I did an iliolinguinal followed up by a Coker-Langenbach. The notch piece, we've shown that. And when you're when you're connecting the lines, and I'm going down through the CT, this is how it kind of, I put this in this position, the pelvis, so that I can connect and follow the lines down and make sure that I understand. And if you haven't done this, I think you'll be surprised at how difficult it is. And, you know, I'll usually start with the outside of the pelvis, and I go down following that line and maybe some additional cortical pieces. And when these other pieces come in, and then you'll see sometimes where there's 3 different lines, and you got to make sure that your model correlates with that. Now I go down the inside, and again, see any articular that might have articular pieces in, and those are what I'm drawing in there. And again, this is the inside of the pelvis. Again, following these lines down, and then making sure that each line of them you can see. And there they are, kind of, so you have some cortical pieces there as well as some articular pieces. And then by the end of it, you should have a very nice kind of a description of it. And so I'm kind of going through this a little fast. Then I look at the rotation. That's my final thing I do. So how this actually rotates. And so as the head pushes from the lateral side in, this kind of rotates. And you see that this piece also moves forward anteriorly. And then the 2 rotations of the 2 columns as they kind of head out. And then this is basically fixation of that really bad with the separate notch piece, and then the fixation of the head, which I think we got a pretty good reduction. So here's a case, and we've seen this one before a little bit, but she's a 52-year-old, somewhat obese, some medical issues. But here's her fracture. And I give you a size of how she is. And I'm going to go back a little bit. The interesting thing again, and I mentioned this yesterday, this is the thing that still bothers her. So 10 years out from this, this is the problem, not necessarily her acetabulum, which is very funny. But anyway, so there was a surgeon in Houston who did 4 years of medical school, 5 years of residency, and 1 year at Southwestern. And Adam Starr's there, who I love Adam, but he tries to do more percutaneous type stuff. And he got to town and claimed he wanted to do all the acetabular and pelvic fractures. So I only showed this because this one didn't go well for him. Again, this is the drawn out fracture. And I asked myself, and I don't know, because eventually we had to fix her because it didn't go well. But this piece, could I have reduced that from ilioinguinal? And the answer is probably not. Now, the question you can ask is, do you need to? And I think this is an important area. And so I probably would have done an extended iliofemoral anyway. But here's her CT scan. And again, a both column type fracture with that kind of piece of the posterior wall that I'm kind of showing there. And knowing that I would have a hard time doing that. But this is what was done percutaneously. And that might offend a lot of people. It certainly offended me because you can see that there's still a fairly big size gap in the fracture. Now you know that because there's a gap here. And even though you could say, oh, well, that looks pretty good, that's not too bad. To me, you can always get one view that make it look good. But my thing is that's inadequate. Now, fortunately for her, some cousin or whatever is an anesthesiologist. And so what happened is 11 days post-op, this happened. And eventually got to me and we did a kind of an extended iliofemoral. Any questions that I'm missing there? Oh. Okay, and here's your 3-year follow-up. And I think we eventually do it. Here's a 85-year-old history of bladder cancer, fell standing it. And we're seeing a lot more of these. I apologize, that x-ray is horrible. But again, this was kind of what I was talking a little bit is, you know, when you see and you think there might be an impaction medially, you have to be careful that it's not just an anterior column that's displaced a little bit because the results is completely different. So even though there's kind of an elevation in this patient of that kind of articular surface here, it's not an impaction. And so these can actually do quite well with fixing them versus the impaction. This one we ended up doing a total hip on it, and I may have screwed up the case because to some degree, I'm not sure I can see it, but to me, that usually means that there's an impaction there. So I apologize for that. Those are terrible things. Here's a really an anterior column, posterior hemitraverse. And so you've got to understand that fracture pattern. Essentially, it's a both column by description because there's no articular surface. But if you don't understand that the anterior column has a different fracture plane than the posterior hemitraverse, you're going to have a difficulty reducing it. Again, some of the pictures, and I'm kind of moving fast for time. And eventually we did an extended iliofemoral. We talked about that. Here's another 33-year-old, very young, and this is kind of an interesting case. He was fixed more than 3 months ago. A well-known trauma surgeon and another orthopedic surgeon called me, and I actually flew to Columbus to fix this. And it was a both column that was fixed through an ilioinguinal. And to be honest, I call these people, and so I think maybe a lot of people think I'm a dick, and I'm okay with that. But I think if I don't let them know, I think that's wrong. And they said, oh, you know, I was going to fix the posterior column, and the anesthesia said they got sick, and so I never really got to the posterior column. And to me, I said, unfortunately, the anterior column isn't reduced well. And you can say, oh, well, I don't really see any fracture lines. But what they've done is they've over-rotated that anterior column, and that's why it's sticking so far out here. And so this is a 33-year-old. This is someone that I'm going to have to do kind of an ilioinguinal, you know, break the fracture, take off this hardware, and then do an extended iliofemoral where I do the posterior part. and I basically break the fracture and then refix it. And so I have to free it up. So that's why I got to go both anterior and posterior. And to be honest, I have to release here. If I don't release this area, I'm never going to get a good reduction of it. And you'll see what happened to some degree. So I flew out to Columbus. I fixed this, did the or I was planning on doing everything in one day. Unfortunately, through the ilioinguinal, I lost a blood volume. And to me, that's when I stopped. And so I said, listen, I'm sorry, but I'm not going to do any more. We'll come back in a week and do the second stage. And that's what I ended up doing. So ilioinguinal, removed it, osteotomy, release of the anterior column, did the extended iliofemoral a week later, did a posterior column osteotomy, released anatomical reduction of the joint. So here's what we did. You see the amount of comminution that I caused anterior as well as posterior, but it allowed me to reduce the anterior posterior column, I think fairly anatomical. And so here's the posterior column. And interestingly, so this is the 3-year, and I think we're probably about 8 years, or it's probably further. And the joint still looks good. I'm still worried this person's going to need, there's some osteophytes there. So I think that there was, maybe not as perfect reduction, but more likely some damage to the cartilage that was present there that I didn't necessarily think about. But the nice thing is he hasn't had his hip replacement we at least have given him 7 years, and I have to ask the referring doctor if he's ever had it. But, I told him, listen, if we can get 10 years out, that would be good. And so at this point, at 3 years, he hadn't had it done. And I think he's out 7 years now without it. Here's again, kind of the posterior wall that we did through an ilioinguinal. I think that actually I saw some big people that you guys had fixed. And I always thought that you guys only had skinny patients in Pakistan, but you have some big people as well. So unfortunately, where I work is the South. And so my patients look a little more like this than then like this. And Joel used to laugh at me about that. And I think that's it. Any questions?
Great job, Dr. Kyle. Thank you very much. Very explicit presentation of cases as well as concepts. Problem is, as time passes by, we are losing the attendance also. So,
nobody's here anymore, huh?
No, we still have 24. That's people who are eager to hear you are still here. Any comments, questions from the house?
Always great to listen, Kyle. It's pretty good. Thank you, Kyle. Thank you very much.
Oh, thank you, Inktab.
So any specific indications you would like to tell us for a total percutaneous in a transverse straightforward?
Yeah, so so when unfortunately I'm a reviewer and I get a bad rap because to some degree I do have cases where I've done some percutaneous. Now I never am totally percutaneous. So for instance, on the model, sometimes you'll get this anterior column kind of fracture where I actually
lower your camera a bit.
Oh, sorry. Yeah.
Yeah. That's better. That's better.
Sorry about that. So the idea being is when you get these anterior column fractures, I've actually, made just a small incision here. And the idea being is I put a clamp in it. So to some degree, if you're strictly asking for percutaneous, I don't think there's an indication. Now, can you do it with a small incision? Yes. And, sometimes I can just slide in the linear clamp that you showed and get like a perfect reduction. I put one tong here and then one tong back underneath I'm not showing it very good, underneath the lesser notch. and I'm basically clamping down that anterior column, and I can feel it, and it's just through a little bit of an incision on the wing, and then I can put some percutaneous screws kind of from anterior column to posterior column. And so those are ones that I've done some percutaneous screws on. But again, I think if you're doing it percutaneously without actually clamping the bone, I'm not sure you're doing it well enough. And you might have good results with it, but those are maybe ones that wouldn't have been problematic if you had done nothing to them. So I know that may be a little controversial statement, but anyway. Now, I take that back for pelvic fractures. There's a lot of those I'll do percutaneously because I think I can get it reduced, and I don't think the degree of reduction is as important in the pelvis as it is in the acetabulum.
I think there are certain areas where you have defined indications for total percutaneous fixations, like in young patients where you have disturbed Marta's angle and roof arcs, but where you can achieve close reduction. You can also go for total percutaneous fixation for early return to function and early mobility. I have one or two cases. If we have time, I can share my screen just quickly.
Yeah, so if you don't mind me just commenting, and you're going to think I'm a dick after this, but to some degree, I don't believe you can do a closed reduction, and you might show x-rays and I think maybe even a CT scan. And I've certainly had Adam and Chip Rout show me these cases, and they've had good follow-up with them. Most of the time, I don't believe that the reduction of a transtectal type injury you can get closed.
No,
and
Dr. Kyle, there are very specific indications in which we do this when the tectal displacement and the special configuration of the fracture within which we do it. I will just like to, just for the audience interest, I can share just two cases, and I would like your expert comments on them.
Sure. Now remember, you asked me for my opinion, so you have to be careful, okay with my opinion.
Yes, openly. Yeah, we are all here to learn from you. Can you please unshare your screen? I would like to share with you.
Dr. Mayer, we have to wrap it up. Sorry, we are 10 minutes past 6. Any last burning comments from the house or questions? And still take that in the next 2 minutes. We will continue discussion on the WhatsApp group. I think, Dr. Mayer, that will be another forum we can use.
Well, thank you guys. And I can tell you from the time I was there before to now, the level of expertise is like 100% better. So you guys are doing awesome. So you're doing a great job.
Yes, thank you, Dr. Kyle, also for your time and continued interest in our courses and continued participation. And it's a great value addition to whatever we do here in Pakistan. And you have a lot of contribution in whatever results we are producing also. So you should be proud of whatever little work and achievements we have done so far. So it's my humble duty to close the course now. I think, as I said yesterday, I'm pressed for time and the place we are here. People may soon switch off the electricity to just push me out. Thank you, all the faculty members, my colleagues, local, national, international, all the way from Peshawar to Karachi, from Lahore to Islamabad, and from Houston to Singapore and India also this time. So I think we had a very nice discussion, whatever we could within our time frame. And I hope the residents, the attendants have had some good take-home messages. We tried to discuss whatever could be points of discussion, whatever could be controversial points. We tried to stay back on them and had some sort of debate type of material on them. But despite that, we missed out on 2 talks, which I would humbly apologize to Dr. Omer and Dr. Intikhab. That's the only thing left out in the program. I wish we could have done that within the time frame, but sometimes we just overshoot, and some of the speakers did overshoot. Anyway, that happens every time, no problem. So I hope this was the first virtual course, Dr. Kyle, of its kind in Pakistan on pelvis and acetabulum. Due to COVID, we could not conduct a hands-on type of thing, and you see, I am the only one sitting in the hall now. But I think overall, I will look forward for your feedback as well as all the faculty's feedback and all the attendants, residents' feedback who attended this course, and how was the lectures, talks, and especially the workshop part of it. And did it make some sense or not, and how could we improve on it? So just give that to us in writing. We will hopefully meet in a group format again, maybe sometime later this year or next year. So till then, it's goodbye from me, and goodbye, Kyle, and assalamu alaikum to all colleagues in Pakistan. Thank you very much. Bye-bye.
Take care.
Thank you very much.